Do we have the judges, please?
Judges, please turn on your video and unmute yourself. I request the judges to please turn on your video.
All participants are requested to follow the rules and instructions which were given to you, that you have to complete it within your stipulated time of 5 minutes. At the fourth minute, you will be given a warning that you are completing your the time, and at the you have to complete it within the stipulated time, that is 5 minutes. If it overshoots, we will stop your slide share at the fifth minute.
Dr. Sumer, could you please call out the judges?
Yes. Do we have the judges today? Dr. Jawahar Rathore and Dr. Amol Singham for the paper presentation. Are they available?
Who all are there?
Dr. Jawahar Rathore and Dr. Amol Singham. Are they on the screen?
No, I can't see them. Both of them are not here. Both of them are not here, sir.
Okay. I'll just give them.
I'll just keep you muted until you make the call.
I'm calling. Dr. Rathod is joining. You would see him. He's trying to join on the line. Can you see him? Please confirm whether you can see the judge on the screen. Vijay Shield.
No, sir, I can't see them yet.
Dr. Rathod is trying to join, but he's not able to. I'll send him his number on the group.
Yeah, please send it to me. I'll call him.
Has the judges joined? So we can ask him to start presenting.
Yes, Dr. Jawar is joining from his phone, and
Should
I
I
couldn't reach Dr. Singham.
should I ask him to start the paper?
Is anybody going to judge?
Dr. Jawahar.
Yeah, he'll join. He's not here yet.
Hello, 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 hello,
Hello.
hello. Am I audible to you? Hello,
Uh, yes. Is this Dr. Jawahar, our judge? Hello.
hello.
Hello, Sumer. Hello,
Yes.
Sumer. Can you hear me?
Yes, madam.
I think Dr. Rathod has joined.
Shall I start the session?
Yeah, if we have just one or two judges, we can at least start.
So, Dr.
Hello,
Sushant,
hello. Am I audible, sir?
Dr. Mishra is also going to join very
Ma'am,
shortly.
Hello, hello,
I'm contacting Dr. Gyan
hello.
Mishra.
he is there for the poster. He will join at 11. He gave a message right now.
Dr. Jawar Rathod is here.
Okay, so we can start with Dr. Jawahar.
Yeah, then you start. Please start. Please start. It's okay.
Dr. Sushant
Yes,
Srivastava,
ma'am. Yes, sir.
kindly start your presentation and stick to
Hello.
the
Yes, sir. Sir, I've put
instructions.
yes, I've put the timer. I'll start, sir. Yeah.
Hello.
So can I start, sir?
Yes, kindly start.
Yes. A very good morning to everyone. Today I'm presenting a paper on functional outcomes of surgically treated tibial plateau fractures using three-dimensional printed models versus radiographic assessment, a randomized control trial.
Just click on
Not,
it.
yeah. Okay. So tibial plateau fractures are one of the most common intra-articular fractures and one of the most challenging fractures to treat. The aim of the treatment for these fractures is restoring the congruency of the articular surface, maintaining the overall joint stability, achieving correct load distribution, and gaining optimal joint function. Now, every fracture has a specific classification which helps into the assessment of that particular fracture. Every fracture fixation currently is having individualized surgery procedures. A new modality of having a 3D printed model in the preoperative planning has been there in the world. And currently, there are very few studies where we have used 3D printed model for a particular fracture. So this is the novelty of the study. The basic aim was to compare the functional outcomes using the Hospital for Special Surgery's knee score in tibial plateau fractures, which were made using a 3D printed model versus a normal radiographic assessment. We also compared the operative time, the intraoperative blood loss, and the number of intraoperative fluoroscopy images which were taken. Now, the important thing here is we use the 4.1b and 4.1c AO classification for the tibial plateau fractures, with the age group of 18 to 65 years and patients willing for surgery as the inclusion criteria. The exclusion criteria were fractures type 4.1a, patients who were pregnant, compound fractures of tibial plateau, and fractures with neurovascular injury. There were 15 patients in each group. Group A, patients were operated with just preoperative 3D models, and Group B, the patients were operated with a normal preoperative radiographic assessment. Now, what do I mean by preoperative radiographic assessment is that each patient had a 3D CT scan, which was done using a Toshiba Actimon machine. Now, first, the image which was there was taken and converted into a DICOM file, which was then processed to a Mimic software, and a virtual 3D model was prepared. From that, STL file was made, and then a full-scale 3D model was prepared. Now, over here, as we collected the operative time, the intraoperative blood loss, the intraoperative fluoroscopy images, and also the HSS score at the suture removal, first month and the 6th month. This is the HSS score, which is completely of 100 points, having pain, function, range of motion, stability, flexion deformity, and muscle strength as the components. This is a case of the patient which was in the 3D model group, the pre-op X-ray. This is the CT scan. These are the CAD models which we had before making the 3D model, the FlashForge Creator 3D printing machine, and the 3D model. This is the 3D model which we can see right now. Just a videographic show to everyone as to how it looks, and we get a normal feel of the fracture configuration, and we can actually have a good preoperative assessment on this. This is the post-operative image, post-op, immediately, and then 6 months. This is the flexion, which can be seen in a proper no extension lag. This is the case 2, which was done with a normal 3D CT scan only, preoperative X-ray, the CT scan, the post-op X-ray immediate, and the 6-month follow-up, and the clinical image. So now the parameters which we have, just running them quickly, the blood loss in the 3D model was 122.63 ml, and that in traditional model was 163 ml. The intraoperative fluoroscopy shoots were almost 17 in 3D model, and in traditional it were 24.67. Mean operating time in the 3D model was 100 minutes approximately. In traditional model was 115 minutes, and the HSS score was better in the 3D model. That is, it was 69.67 at the end of 6 months. These are the pertinent articles which I had found. There was a study which was done using 3D printing for both the internal and external fixation, and another study was done which used high energy tibial plateau fractures, that is type 5 and type 6 Ashka type. These are the two retrospective studies which were done. So concluding, we get a good comprehensive understanding of the fracture using 3D models. Patient specific, accurate preoperative planning can be done with surgical simulation. There is decreased intraoperative time, blood loss, and number of fluoroscopy shots, and optimization of functional outcomes for the patient is seen. Thank you.
On time. Judges, do you have any question, please? the judges don't have question, we can go to the second speaker.
Sir, I've got a question on the chat box. From where were the 3D models done? So the 3D models were done from VNIT Nagpur, where we had a memorandum of understanding with them, and we had got the 3D models printed from there, from the Department of Biomedical Engineering.
Sumer, questions are not to be taken from the chat box. Questions are to be asked only by the judges.
If there are no questions from the judges, we'll move on to the second speaker, Dr. Akanksha Sarda. And you upload your slides. You can start your presentation from now.
Good morning, everyone. Myself, Dr. Akanksha Sarda, is here to present a paper on radiological and functional assessment in moderate to severe COVID-19 patients post-recovery. The novel coronavirus pneumonia COVID-19 initially broke out in Wuhan, China in early December 2019 and has rapidly spread across the world since then. The entry of the virus in humans is mainly facilitated by the ACE2 receptors expressed by the type 2 pneumocytes, which could arise into systemic inflammatory syndrome or the cytokine storm. However, the knowledge about the sequelae of SARS-CoV-2 infection remains limited. Previously, clinical radiographic and autopsy reports of pulmonary fibrosis were common following the SARS and MERS. Severe or persistent lung damage due to various infections or chronic granulomatous diseases or connective tissue disorders also lead to pulmonary fibrosis. Lung injury by virus and the resulting immune response and attempts at healing leading to interstitial organized pneumonia could later fibrose or even show resolution of the normal lung parenchyma. It has rarely been reported whether the COVID-19 survivors would develop fibrosis or not, and also the resulting functional impairment and management for the same. We therefore stress upon the post-COVID sequelae by assessment of the functional tests and the CT scans. All the patients in the study were identified by the RT-PCR for the SARS-CoV-2 and were categorized as moderate to severe based on the CT thorax findings of scores more than 8 by 25, CORADs more than 4, or RR more than 30 and SpO2 less than 92% on room air. It's a cross-sectional study and 20 consecutive eligible patients were enrolled. The medical records of the patients were seen and accordingly the tests were done. All the examination and the follow-up CT scans were done, and the main features analyzed were ground glass opacities, consolidation, interstitial thickening, bronchiectasis, crazy paving, pleuroparenchymal bands, and fibrotic bands. The findings were analyzed using the CT severity score ranging from 0 to 25 based on the involvement of the lung parenchyma and the CORAD score, of which the CORADs 4, 5, and 6 are strongly suggestive of COVID-19. 20 COVID-19 survivors completed the study. Their mean age was 52.3, and of these 80% were males and 20 females. Most common comorbidities seen were systemic hypertension and diabetes mellitus. The patients had no pulmonary disease on the day of onset, and all of them received the standard therapy as guidelines for severe COVID-19 and moderate COVID-19. None of them received mechanical ventilation. As we can see here, the mean CT severity score on the first visit was 18.25, which gradually reduced to 12.9 on the first month visit. The common findings which were seen were GGOs, consolidation, interlobular and intralobular septal thickening. However, we can see here that on follow-up, the GGOs were reduced from 90% of the patients. There was mild regression in 5%. Also, in a few, we can see the bronchiectasis, emphysematous, and traction bronchiectatic changes. Spirometry was completed in 18 patients and remaining 2 could not effort. As we can see here, in severe restriction was seen in 5 patients. Normal functions were seen in 3 patients, as well as the significant desaturation of more than 3% on 6-minute walk test was seen in 8 patients. Negative, strong, and significant correlations were observed between the CT scores at first visit and visit after 1 month with TLCs, FE1, FEC, and DLCO. Correlation of CT scores with 6-minute walk distance in meters was also negative. However, it was weak and non-significant. Though the correlation of the CT scores at the FE1 by FEC ratio was found positive, fairly strong and significant at first visit, but it was weak and non-significant at subsequent visits after the 1 month. Many patients recovered after the outbreak of SARS. However, they had lung function impairments, as shown by the previous study by Jenny C. NJI. Patients who recovered from SARS had DLC impairment on follow-up study, and the exercise capacity was also quite lower. According to the previous report, 33 patients had radiological CT abnormalities and had impaired DLC at 6 months post-recovery. Although the question still remains about the sequelae from COVID-19 virus infection. In a previous study by Yumia Zhao et al. In 2020, lung function anomalies were noted in TLCs, FE1, DLCO. Also, they showed that the GGOs have reduced from before, but persistent residual GGOs on follow-up CT scans with significant negative correlation between DLCO and chest X-ray. Whereas in our study, the FE1 and FBC, TLC, DLCO were all reduced, with the GGOs were reduced from before, but however persistent. Also, negative, strong, and significant correlation was seen between CT scores and TLC, FE1, FVC, and DLC on follow-ups. Thus, in conclusion, the researchers demonstrated significant radiographic and physiological functional abnormalities in high proportion of COVID-19 patients post-recovery. As we can see here, the follow-up CT scans of A and C of the onset scans of 65-year-old male and females respectively, and the follow-up scans showing the reduced GGOs and fibrosis is predominant. Abnormalities in DLCO indicated pulmonary fibrosis or a late phase in the course of the recovery, which correlates with the CT scan findings. This impaired lung function could last for months or years. The density of the radiological abnormalities also reduced from before, suggesting the radiological abnormalities from SARS-CoV-2 can get better over time. In our study, we had initiated antifibrotics in some the patients, and significant radiological resolution was also seen in them during follow-ups. This signifies that antifibrotics needs to be analyzed and a proper RCT should be conducted. As 45% of the patients in our study showed fibrosis, significant radiological and physiological abnormalities existed in a high proportion in the survivors of COVID-19 patients. Hence, regular scrutiny, early rehabilitation, and assessment of the role of antifibrotics is must for any persistent or emerging long-term sequelae. Thank you.
Okay, completed on time. Do we have questions from the judge? From the judges? I will request the judge to kindly unmute himself if he wants to ask some questions.
Dr. Rathod, please unmute yourself.
Dr. Rathod, please unmute yourself.
Hello?
Hello.
Hello, hello. Am I audible?
Yes,
Yes,
sir.
now you are. Dr. Rathod, you are
Akanksha, it
audible.
was a wonderful presentation. Yes.
Yes.
Akanksha, it was a wonderful presentation. You told in
Yes,
your
sir.
presentation that the radiological abnormalities persisted in approximately 33% of cases, right?
Yes, sir.
Hello?
Radiological
Hello?
abnormalities
What is your
persist.
observation?
Yes, sir.
What is your observation in only mild score cases, like 2, 3 score in mild CT score? What was your observation?
So my study was based on patients of moderate to severe category of COVID-19 patients. However, in our clinics, we have seen patients of mild to COVID-19 patients on recovery, but their GGOs were resolved, sir, from before. As we have seen in my study also, the GGOs have reduced from before, but they were persistent. They have reduced to the scores of around 3 to 4 of the scores was reduced on the follow-up scans.
Okay. I just wanted to know myself. Anyway, it was a wonderful presentation.
Yes, sir. Thank you, sir.
Thank you.
Can we have the next speaker, Dr. Aditi Agrawal? Dr. Aditya Agrawal, kindly share your slide.
Dr. Aditi Agrawal is for poster, sir.
Okay. Who is the next candidate? Abhishek.
Okay, ma'am.
Make it full screen, please.
Who is in the sequence? Is it Abhishek or Jasmine? Yogani?
Abhishek, sir.
Kindly, Abhishek, kindly upload your slide.
Is this Jasmine's presentation? Then you please stop sharing.
It is Jasmine's presentation, sir.
Please stop sharing so
Okay.
that Abhishek can start his presentation. Jasmine?
Jasmine
Are you
will be
audible?
followed by Abhishek, sir.
Okay.
Good morning, ma'am. Am I audible?
Yes, you are.
Good morning, respected judges and delegates. I am Dr. Jasmine Mulani from Department of Biochemistry, GMC Nagpur. I am pleased to share my research titled Serum Prolactin, a clue to breast malignancy. Prolactin is a
Dr.
polypeptide.
Jasmine,
First, kindly share your slides. Screen share your slides.
Make it full screen. Yes.
Okay, ma'am. So, serum prolactin, a clue to breast malignancy. Prolactin is a polypeptide protein hormone which is synthesized by the lactotropes of the anterior pituitary. As we know, it has a vital role in maintenance of lactation, but many recent studies have revealed its importance in mammary tumorigenesis. But still, there is paucity of such studies in Indian population. So this study aims to fill this void. The study aims to evaluate and compare the serum prolactin levels in patients of breast malignancy and benign breast diseases. It was a cross-sectional observation study with comparison done over a period of 24 months at GMC Nagpur. We had cases of patients with breast malignancy and the patients with benign breast diseases served as controls. The diagnosis was based on clinical features, FNSC, and tissue histopathology reports. We included here female patients of malignant and benign breast diseases of more than age group of 18 years. And we excluded pregnant and lactating women, male patients, and the patients who are on drugs which can affect the prolactin levels, and age group of less than 18 years. We carried out the test by using the chemiluminescence immunoassay method, which was done on Siemens advs-N2. The normal serum prolactin levels are 3 to 29 nanograms per ml. Results, the mean age in patients of breast malignancy was found to be approximately 50 years, which was comparatively higher as compared to the patients of benign breast diseases, that is approximately 33 years. This difference was statistically significant. So the same can be seen in the butterfly graph. So the patients, about 33% patients of breast cancer had a strong family history of breast cancer as compared to the patients of benign breast diseases. So this difference was quite significant. We estimated serum prolactin levels in about 120 female patients with breast diseases. out of which 60 patients were of breast malignancy. And we found that about maximum patient, 93% patient had an elevated serum prolactin levels, whereas in the remaining 60 patients of benign breast diseases, the serum prolactin levels was found to be normal in about 87% of patients. So comparing this to this was found to be statistically very much significant, that 93% patients of breast cancer had elevated serum prolactin levels. The mean serum prolactin levels in patients of breast malignancy was found to be higher, that is approximately more than 100, as compared to the patients of benign breast diseases, that is 16. So this difference was quite significant. We plotted an ROC curve, that is receiver operating characteristic curve. That is, the more the area under curve, the higher is the accuracy of the test. And for this, the area under curve, or for this serum prolactin, we found it to be as 0.9, which indicated an excellent accuracy for the test. We used an Jordan's index, which was found to be 0.8, corresponding to the serum prolactin level of 40 nanograms per ml, which indicated a higher accuracy. And at this highest accuracy, the sensitivity was 88% with an highest specificity of 95%. So the new cutoff value for serum prolactin level, it demonstrated a greater accuracy and higher specificity, which helps to differentiate between the patients of malignant breast diseases and benign breast diseases. So we are coming to conclusion. The patients with breast malignancy had a relatively increased age and frequent family history of breast malignancy as compared to the patients of benign breast diseases. And to the best of our knowledge, for the first time in medical literature, a new cutoff value with an improved diagnostic accuracy, that is 40 nanograms per ml, as compared to the current standard cutoff value, which is 29 of the serum prolactin, which helps to differentiate between the breast malignancy and the benign breast diseases. And this can be used in conjunction with clinical history and other tests. So patients with breast malignancy tend to have increased serum prolactin levels as compared to the patients of benign breast diseases. And the elevated serum prolactin levels in patients with breast diseases, it can be a clue for the possible underlying breast malignancy, and it can be used as a potential ancillary test in the diagnosis. As such, the exact role of prolactin in breast carcinogenesis is not known, but still a future research is recommended for understanding its potential role as a tumor marker. Thank you.
Thank you, Jasmine. Questions from judges?
It's not audible.
I request the judges to kindly unmute themselves.
Hello.
If there is no questions from the judges, we will move to the next speaker. Abhishek Ikka. You can start your presentation now.
Good afternoon, everyone. The topic of my presentation is on study of hemodynamic variations following spinal anesthesia in patients on beta blockers or calcium channel blockers. Introduction. Spinal anesthesia is the most commonly used technique all over the world for lower abdominal, perineal, and lower limb surgeries. The most common complications of spinal anesthesia are hypotension and bradycardia, which are encountered after spinal anesthesia, which are mainly attributed to sympathetic blockade or activation of the basal gyrus reflex or blockade of cardiac filter fibers from T1 to T4 and also due to unopposed parasympathetic nervous system activation. Antihypertensive drugs like beta blockers and calcium channel blockers are used to control blood pressure preoperatively. Commonly encountered are hypotension and bradycardia, which are seen after spinal anesthesia in patients taking morning dose of beta blockers or calcium channel blockers due to effects of these drugs on the sympathetic nervous system and cardiovascular system. The study was designed to compare the incidence of hypotension and bradycardia following spinal anesthesia in hypertensive patients on regular medication with standardized doses of beta blockers or calcium channel blockers. The standardized doses of both the drugs for beta blockers, it was taken as 50 mg of atenolol, and for calcium channel blockers, it was taken as 5 mg amlodipine. Review of literature was done. The aim of the study was to compare the hemodynamic changes after spinal anesthesia in patients taking morning dose of beta blockers and calcium channel blockers. The primary objective was to study the incidence of hypotension and bradycardia. Secondary objectives was to assess the adverse effect of the drugs. It was a prospective comparative observational study. Intergroup comparison was done by student unpaired t-test, and categorical variables were compared by chi-square test. Inclusion criteria were all the patients which were undergoing elective lower abdominal surgeries under category ASA grade 1 and 2 between age 18 to 60 years and on treatment with either beta blockers or calcium channel blockers, taking at least 2 weeks prior to surgery and also having taken on the morning of surgery. Exclusion criteria were patients unwilling for consent of the study, diabetic patients, patients with bleeding disorders, pregnant women with uncontrolled hypertension, patients with bradycardia less than 60 per minute, and duration of surgery more than 90 minutes. Patients were divided into 2 groups, atenolol and amlodipine groups. All the patients were preloaded with tringer latex solution, 10 ml per kg. Baseline hemodynamic parameters are noted. Spinal anesthesia was given with 25 G spinal needle in left atrial position at L3, L4 level with 3.5 milliliters of hyperbaric bupropion solution. Time of completion of the subarachnoid block was taken as 0 minutes, and sensory level was assessed by pinprick at 5 minutes and 15 minutes after the blockade. Hypotension was considered to be when the mean arterial blood pressure was less than 70 and was treated with injection methamphetamine. Bradycardia was said to be when the heart rate went less than 60 per minute and was treated with atropine 0.6 mg intravenously. Patients were categorized according to the age and weight and accordingly into the 2 groups of atenolol and amlodipine. Also, gender-wise distribution was assessed. The vital parameters were noted accordingly. Coming to the actual study, the graph shows the difference in the 2 groups between the atenolol and amlodipine group. Parameters were noted at various time intervals. Similarly, mean arterial blood pressure at various time intervals was noted and graphically represented. Patients requiring vasopressor support and anticholinergic support were also assessed. Out of the total atenolol patients, 4 patients required vasopressor support and 13 patients of amlodipine group required vasopressor support. Coming to the conclusion discussion, in our study, we compared different effects of the calcium channel blockers and beta blockers after spinal anesthesia. Fall in the mean pulse rate was seen from 0 to 25 minutes after spinal anesthesia in both groups, but more fall in pulse rate was observed in the atenolol group compared to the amlodipine group, and the difference of fall between the 2 groups was significant. Maximum fall in the pulse rate was in group atenolol at 15 minutes, and there was a gradual increase in mean pulse rate observed from 20 minutes. Incidence of bradycardia was noted in 16 patients of atenolol group, whereas in the amlodipine group, only 5 patients bradycardia was seen. Fall in the mean arterial blood pressure was seen significantly in the 0 to 25 minutes in the both groups. More fall was seen in the amlodipine group compared to the atenolol group. Conclusion of the study is that hypertension was more common in patients taking morning dose of calcium channel blockers whereas bradycardia was more common in patients taking morning dose of beta blockers. Hence, anticipation of such hemodynamic changes and timely treatment following spinal anesthesia is important in patients receiving antihypertensive drugs. There were some limitations to this study, which were that the control group was not taken. Study could not be applicable to obstetric and geriatric patients, and this was an observational study. And more randomized control studies need to be done to substantiate the results of this. Thank you.
Questions from judges? I can see Dr. Amol Singham has joined.
Move on to next candidate, please.
I can see Dr. Amol Singham has joined. I welcome him to the platform. And kindly, the next candidate is Dr. Priyanka Patil. Upload your presentation.
Thank you, sir. Thank you very much.
Welcome, Dr. Amol, sir.
Thank you, sir. Sorry, I was not able to join. Actually, I was not having my phone.
We are on the 5th presentation.
Okay, sir. Okay.
Start with the slideshow. Start with slideshow. Dr. Priyanka, start the slideshow and start slideshow. Okay, your time starts now. You can start your presentation. Hello. Hello.
Priyanka, start your presentation. Priyanka, unmute yourself. Please unmute yourself, Priyanka.
Priyanka, unmute yourself.
Audible, sir?
If you are audible, you have to be quick because you are.
Priyanka, mute the other laptop or mobile that you have nearby.
Yes, sir.
Please start.
Good morning, everyone. My topic for paper presentation is a newer approach for postoperative pain relief in patients of lower limb orthopedic surgery. Postoperative pain following major lower limb orthopedic surgeries is still a troublesome issue. Pain may produce effects like apprehension, sweating, nausea, tachycardia, palpitation, tachypnea, hypertension, hypotension. So aggressive pain management is mandatory. Conventional modalities of post-operative pain management are non-opioid analgesics, IV analgesics with opioids, epidural analgesia, continuous infusion through catheter, but they have their own limitations. Nowadays, newer approaches in post-operative pain management are upcoming. It includes peripheral nerve blocks. We have studied the lumbar plexus block, which has anterior and posterior approach. Anterior approach consisting of femoral block, which is also called as 3-in-1 block, and posterior approach with psoas compartment block. These are the surface landmarks showing femoral block and psoas block. Aim is to assess the efficacy of femoral block and psoas compartment block in achieving the post-operative pain relief in lower limb orthopedic surgery. Primary objectives are the onset of sensory block, onset of motor block, total duration of post-operative analgesia, and secondary objectives are time for breakthrough pain and first rescue analgesic requirement, quality of the block, hemodynamic stability, complications. This is the review of literature done. Materials and methods. It is a prospective observational study. Hospital ethics committee permission was taken. Written informed consents from patients were taken. Patients were selected by random allocation by CHIP methods. Two groups were involved. Group A consisting of 40 patients for femoral nerve block and Group B consisting of 40 patients for psoas compartment block. Inclusion criteria was ASA grade 1-2, undergoing elective orthopedic lower limb surgeries, BMI less than 30, normal clinical biochemical, radiological and hematological parameters. Exclusion criteria includes patients with hypovolemia, coagulation disorder, serious cardiorespiratory comorbidities like ASA grade 3 and 4, infection, refusal to propose method, and daycare surgery. Study was carried out within the institute and data collection was done with number of patients coming for pre-anesthetic checkup after the confirmation of diagnosis from orthopedic specialties. Multipara monitors and recording of baseline values like ECG, SpO2, NIPP was done. Routine conduct of spinal anesthesia using 0.5% heavy bupivacaine in L2, L3 and L3, L4 space with 25 gauge Quincke spinal needle. Block was performed after spinal level resided with 30 ml of 0.25% injection ropivacaine using nerve locator stimuplex needle. We studied the time of onset of sensory block by assessing by pinprick and cold application every 2 minutes till the onset. By assessing time of onset of motor block assessed every 2 minutes till the onset, and quality of sensory and motor block assessed every 5 minutes after the onset is established. Quality of block was assessed at the onset, time of first rescue analgesia given, and number of supplemental analgesics. Both the groups were evaluated for time of first rescue analgesic drug administration according to the VAS score above 6, quality of post-operative analgesia, and side effects like hemodynamic instability. Data was expressed with mean and standard deviation. Quantitative analysis was compared with independent sample. Chi-square test was used and p-value of less than 0.05 was significant. Results were assessed on the basis of demographic data, which included age, height, weight, sex ratio, which in both the groups, which was insignificant. Then, according to the post-operative hemodynamics parameters like systolic diastolic BP, heart rate, and respiratory rate after 2 hours, 6 hours, and 12 hours in both the groups, which was insignificant. According to the VAS score and the onset of block, which included sensory and motor onset, in this Group A, that is femoral block, was faster in onset, and that was the study was significant. For the total duration of post-operative analgesia in hours, Group B had more duration of analgesia as compared to Group A and was significant. Quality of block, which has Group B has excellent analgesia and quality of block and was significant. Time of rescue of first analgesic was more in Group B, that is psoas block, and the study was significant. Conclusion was the psoas compartment block offered better pain relief, better quality of analgesia than femoral block during post-operative period, and the difference is statistically significant. Number of analgesic doses required decreased significantly in psoas compartment block as compared to femoral block. Early mobility rehabilitation can be achieved as hemodynamic stability is maintained in both the blocks. Facilitated early physiotherapy following lower limb orthopedic surgeries operated under spinal anesthesia. These are the references. Thank you.
Presentation open for questions by judges.
Hello. Hello, am I audible?
Yes, yes, sir.
My question is, hello.
Priyanka, are you able to help here?
Priyanka? Hello.
Pardon?
Okay, Priyanka, am I audible?
Yes, sir.
Okay, my question is, what was the end point of your study?
It was studied that's a femoral block. In
What
femoral
was
block,
the end point of study? At what point you ended your study? You started your study after the spinal anesthesia regrade from some level. Okay, patient started pain, then you started your study. What was the end point of your study? You said in your conclusion that number of analgesic doses required were less in one group compared to other group. So what was your end point of study?
sir, at the end, duration of analgesia after giving of first rescue analgesic.
Okay, then how you are going to conclude that patients with psoas compartment block required less number of analgesic as compared to patient belonging to femoral nerve block group? Because that was your end point of study. You have given a rescue analgesic and you have concluded your study.
Yes, sir. Sir, in psoas compartmental block, the
Okay,
analgesia was for a longer duration as it is a deep-seated analgesia.
Okay. Agreed. I'm not asking about technical, scientific specification about that. I'm asking about you have not studied that number of rescue analgesic required were less in one group as compared to other group. Still, you concluded that. Secondly, what about your early mobilization? Have you studied in patient in both the groups that patient is having early mobilization in one group as compared to other group? Still, you have concluded that.
Yes, sir.
Your objectives were different and your conclusion was different. You do have 6 objectives, primary and secondary, and your conclusion was altogether different. Otherwise, nice presentation. Okay, that's all from my side.
Can we have our next speaker, Adil, Dr. Adil Javre?
Good morning, sir. Is my screen visible to everyone?
Yes, it is. Put it on slide share.
Yes, sir. Good morning, everyone. Today, I would be presenting a paper presentation on the topic, the prevalence of osteoporosis in adult populations visiting a tertiary care center in central India. Introduction. According to WHO, that is World Health Organization, osteoporosis is defined as a disease which is characterized by low bone mass and microarchitectural deterioration of the bone tissue, leading to enhanced bone fragility and a consequent increase in the fracture risk. As we can see from the diagram, there is a healthy bone and there is an osteoporotic bone. In healthy bone, the normal bone cells have the normal architecture, but as in the case of osteoporotic bone, there is microarchitectural deterioration. Therefore, it causes the bone fragility and therefore an increase in the fracture risk. Osteoporosis is mainly associated with a multifactorial etiology. Around 50 million people in India are either osteoporotic, that is, they have a T score lower than -2.5, or they have low bone mass, which in orthopedic terms is also known as osteopenic, having a T score between -1 and -2.5. So as we can see from the scaling, the normal individuals have a T score of greater than -1. The people who are osteopenic, that is having low bone density, have a T score between -1 to -2.5, and people having osteoporosis have a T score of less than -2.5. 1 in 3 women over 50 and 1 in 5 men over 50 suffer from osteoporosis in India. The materials and methods which were used for this study it was an observational cross-sectional study which was carried out on a total of 210 patients in a tertiary care hospital over 3 months, from a period of August 2019 to November 2019. Universal sampling was carried out for all the participants. Subjects were generally differentiated according to an age cutoff, that is 40 years. They were analyzed via questionnaire and bone mineral density, that is BMD testing, using dual energy X-ray absorptiometry scan, that is DEXA scan. Bone mineral density testing was done via portable peripheral dual energy X-ray absorptiometry machine at the wrist of each patient. Ethical approval was taken from the Institutional Ethical Committee of the Tertiary Care Hospital. The variables of the study which were studied in this paper presentation are the age, smoking, alcoholism, menopause, hyperthyroidism, hypothyroidism, and diabetes. Total 200, and the result which was obtained was total 210 participants were screened with the help of peripheral dual energy X-ray absorptiometry, that is DEXA scan. The mean age for subjects was 48 years. The following things were observed. Out of total 210 patients, there were 138 patients, that 64.2% of the population, who were osteopenic, having a T-score of between less than -1 to -2.5. 59 individuals, that is 28%, were osteoporotic, having a T-score less than -2.5. And 13 individuals, that is approximately 6% of the individual, were normal, having a T-score greater than -1. Age. The following was calculated for the age. Out of total 210 patients, they were divided into less than 40 years and greater than 40 years. Total 41 individuals were less than 40 years, and total 169 individuals were greater than 40 years. So out of total 41 individuals less than 40 years, they were divided into being osteoporotic, osteopenic, and normal. So 2 were osteoporotic, 31 were osteopenic, and normal were 8 individuals. Out of the total 169 individuals which were greater than 40 years of age, 57 were osteoporotic, 107 were osteopenic, and normal were 5 individuals. So it showed, so as we can see from the p-value, the p-value of being osteoporotic was 0.00001, and being osteopenic was 0.002. So it showed a significant association between either osteoporosis or osteopenia in adults above 40 years of age. Similarly, patient having the etiological factor of smoking or tobacco chewing, out of total 210 patients, 61 were smokers and 149 were non-smokers, divided into being osteoporotic, osteopenic, and normal. 10 were osteoporotic, 43 were osteopenic among smokers, and 49 were osteoporotic, and 95 were osteopenic among the non-smokers. So smoking and osteoporosis showed a significant association. Among the people who were alcohol consumers, 34 were alcohol consumers and non-consumers were 176. So osteoporotic were 3 individuals, osteopenic were 28 individuals, and normal were 3 individuals. Therefore, showing a p-value or a significant value of 0.03 among osteoporosis and alcoholism. Therefore, alcohol consumption and osteoporosis showed a significant association. In females who were menopausal, 89 were menopausal and 17 were non-menopausal who visited the OPD. So 47 among the menopausal women were osteoporotic, 35 among the menopausal women were osteopenic, and 7 were normal. So it showed a significant association between osteoporosis and menopause. As we can see from diabetes, hyperthyroidism, and hypothyroidism, all these were also considered as etiological factors, though their significant association was not much as mentioned for the above 4 factors. So as we can see from the statistical study which we conducted, the main 4 variables which were important for osteoporosis from this pie chart diagram can be seen as menopause being the number 1, contributing to 52.8%, age greater than 40 being the second factor, contributing to approximately 34%, smoking being the third factor, contributing to 16.4%, and alcoholism being the fourth one, contributing to 8.82%. So discussion, various factors have been known to cause osteoporosis, some of them being age, smoking, alcoholism, diabetes, and thyroid hormones. Participants above the age of 40 had a higher prevalence of osteoporosis and osteopenia. In our study, out of 169 participants who were above the age of 40, 67% were osteopenic and 33% were osteoporotic. Out of the 186 patients which were surveyed, 36 patients were smokers, that is tobacco chewers. They found out that smoking, tobacco chewing had a detrimental effect on bone quality, with 50% patients being osteopenic and 8% being osteoporotic. In our study, out of 61 patients who were smokers or tobacco chewers, 16% were osteoporotic and 70% were osteopenic. Chronic heavy alcohol consumption also compromises the bone health and increases the risk of osteoporosis. In particular, heavy alcohol use decreases the bone density and weakens the bone mechanical properties. In our study, out of 34 alcohol consumers, 82% were osteopenic and 8% were osteoporotic. Bone mineral density was seen to be the lowest in females above the age of 46 years who were menopausal. In our study, out of the 89 menopausal women, 39% were osteopenic and 52% were osteopenic.
Last minute.
In our study, we found out that the prevalence of osteoporosis or osteopenia to be more in males as compared to that in females in all age groups. Males in the age groups of 50 to 59 years seem to be affected the most. Various risk factors were assessed with age, smoking, and alcohol consumption being the most attributable factor. Females above the age of 60 years showed a higher prevalence of osteoporosis, with menopause being the most common attributable factor. Hence, from above, it was seen that the development of osteoporosis in Indian population in central India had a multifactorial etiology with age, smoking, menopause, and alcohol consumption having the greatest contribution as etiological factors. So these are the references from which the paper presentation.
Okay, thank you very much.
Thank you so much.
The presentation is open for questions by judges.
Hello.
Hello.
Hello, Adil.
Good morning, sir. Good morning, sir.
Hello, Adil. It was a wonderful presentation. Good presentation.
Thank you, sir.
Actually, Sumer sir, do you have any question? I don't have any question.
Okay, then we'll.
Okay, I do have one question. Am I audible?
Yes, sir.
Yes.
You are audible. Yes, sir.
Okay. Dr. Adil,
Yes, sir.
I just want to know what was the rationale of this study? What was the aim behind doing this study?
Sir, the aim behind doing this study was we had to find out that whether osteoporosis is single factor etiology or a multifactorial etiology. If it is a multifactorial etiology, like then among the risk factors, which factors had the highest prevalence of causing osteoporosis? And then as a result, at the end of the study, we found out that menopause was the first factor, followed out by age greater than 40 years being the second, smoking being the third, and alcoholism being the fourth.
Okay, so you wanted to know which is the most common factor which will have osteoporosis. Okay?
Yes, sir. The increasing the risk of osteoporosis.
But what about a patient who is smoker plus alcoholic? What are the chances that patient will develop osteoporosis?
Sir, if a patient is a smoker and alcoholic,
according to your pie diagram, it was
Yes,
individual patient. Okay.
Yes, sir.
And
It
the
was
chances
individual.
that patient is smoker, these are the chances patient might develop osteoporosis. Okay.
Yes, sir.
But what about combination of the two things, smoking plus alcohol, or smoking plus menopause, diabetes plus menopause? Have you studied those things?
Sir, not mentioned in the study, sir, as the presentation was going too long. So, but as we had observed, sir, in our clinical study, sir, we studied that also. So, sir, if a patient had a risk factor of smoking, and if a patient had a risk factor of both smoking and alcoholism, then, sir, it was found to be approximately, sir, 1.5 fold as compared to the normal risk factor.
Okay, that was your aim.
Yes, sir.
You presented in that thing. Okay, the aim was that thing, but your presentation was only the factor having percentage of developing osteoporosis.
Yes,
okay.
sir.
In your last slide, you said male belonging to age of 50 to 59 years and female more than 60 years, they do have chances of developing osteoporosis. Okay.
Yes, sir.
Have you studied those things? But in your study, you have not mentioned the data was less than 40 years and more than 40 years. So if you have not studied, how you are going to mention that it is 50 to 59 for male and it is more than 60 for female?
Sir, we had not mentioned in the presentation, sir, but sir, greater than 40, it was like irrespective of the gender, and less than 40, sir, it was irrespective of the gender, which was mentioned in the presentation.
No, what I mean to say was, whatever was your aim, those aims should reflect in your conclusion.
Yes, sir.
The conclusion was altogether different. It was 50 to 59. You are not mentioned anywhere in your presentation that it was 50 to 59 for male and more than 60 for female. Have you mentioned those things?
No, sir. At the end, sir, it wasn't mentioned.
So make it a point that whenever you are presenting, your aim should reflect in your conclusion. Whatever the points you are keeping in your aim or objectives, primary, secondary, it should reflect in your conclusion.
Yes, sir.
Okay.
Yes, sir.
You might have
Thank you so much, sir.
Okay. He might have studied his confounding factors in his original study, which is presented in the presentation. Okay, we'll move on to the next speaker. Is Dr. Prerna Devtale. Devyani, is it Prerna Devtale or Shubhra Joshi?
It is Prerna, sir. Prerna.
Do we have Prerna? She's not here. Should we move on to the yes? Should we move on to the next speaker? Shubhra is available.
Shubhra, yeah. Please move on to the next speaker.
Shubhra.
Hi, sir. Am I audible?
Yes, yes, you are audible. Kindly share your screen with your slides.
Yes, sir. So can I start?
Start your presentation.
Good morning, everyone. My name is Dr. Shubhra Joshi, and I am a resident of the Department of Community Medicine, GMC Nagpur. My paper presentation topic is stress and anxiety related to pandemic among the healthcare professionals of Central India. Introduction. The first case due to SARS-CoV was detected in Wuhan, China on 31st of December 2019, and it was soon declared a public health emergency of international concern on 30th of January 2020. This pandemic was uncharted waters for all of us currently alive. The uncertain prognosis, scarcities of resources led to the worst possible work environment for all the healthcare staff working in this pandemic. Thus, the overburdened healthcare delivery system led to the mental fatigue and emotional distress of all the healthcare workers. With this rationale, this current study was conducted with the objective of to study the prevalence of stress and anxiety related to pandemic amongst the healthcare professions in Central India. Methodology. Study design was a descriptive cross-section study. Study setting was a dedicated COVID hospital. Study duration was of 6 days from 12th April to 17th April. And the study participants were the medical faculty from all departments of a tertiary care center. The sampling method was convenient sampling, and the sample size such selected was 237. The study tools used were the perceived stress scale and the generalized anxiety disorder 7 scale. Ethical clearance was obtained from IEC. Online semi-structured questionnaire with a consent form appended to it was circulated with the study participants. Statistical analysis were done using API info software, and the statistical tests supplied by chi-square, Pearson correlation coefficient, and multivariate logistic regression analysis. The results, with an N is equal to 237, the females were 120 and males were 117. The mean age of participants was 34.8 plus minus 10.76. Experience in years was less than 1 year for 66 participants and more than or equal to 48 for 7 more than or equal to 7 for 48 participants. Sleep disturbance was seen in 117 participants and appetite changes were seen in 95 participants. From the general anxiety disorder scale, 26% of the participants had mild anxiety, 12% had moderate, and 8% had severe anxiety. From the perceived stress scale, as measured from the perceived stress scale, showed that 30 of the participants had low stress, 128 suffered from moderate stress, and 25 of the participants had high stress. There was no significant influence of gender on the generalized anxiety disorder, stress, sleep, and appetite differences, with all having a p-value of more than 0.05. Age seemed to have an influence, wherein the elderly age group people
Hello, you have lost your connectivity. Dr. Shubhra.
Hello.
Hello, we have lost your connectivity. Can you read out your slides?
Sir, is it okay now?
No, we are not able to see your slides. Kindly share your screen.
Yes, sir. So is it visible now?
Yes, yes. Continue.
So as I was saying, the experienced individuals got adjusted to the workplace and showed less chances of work-related stress. This was a graph which was plotted to measure the correlation between perceived stress and anxiety disorder. We found a positive correlation, with moderately positive correlation between this perceived stress and anxiety disorder. Multivariate logistic regression was used to study the combined effects of all the variables with generalized anxiety disorder. Herein, the age or experience were seen to be masked with a p-value of more than 0.05,
but sleep and appetite had a high significant role for GAD occurrence. In conclusion, the present study arrived that the nearly half of the healthcare profession.
Hello, you are not audible. No, we lost your connection.
Sir, is it visible now?
Yes, yes. Kindly
In
continue.
conclusion, yes, sir. In conclusion, the present study showed that nearly half of the healthcare professionals detected to have generalized anxiety disorder of varying severity. The younger and less experienced participants were affected more. So we can infer that various counseling and support sessions could help the younger healthcare professionals stay at a mental ease, and these corrective measures, when applied at initial levels, could lead to a healthier workforce which stands strong to fight the COVID-19 battle. These are my references, sir. Thank you.
Okay, session is open for questions from judges. Hello. Question from judges.
Hello.
Hello. Good morning, sir.
Hello, Shubhra.
Yes, sir.
Your
Good
presentation.
morning,
Yes, your presentation was nice. Although to me the sample size looks very less. Actually.
Yes, sir. Yes, sir.
We all know there is relatively lot of stress involved in handling this pandemic. Otherwise, a nice presentation.
I just have one question from Shubhra. You have used multivariate regression logistic in this in your study. Can you tell me when do you use this statistical analysis?
So when there are multiple variables and
What is the importance of using multi-logistic regression? What is the importance?
So that is used to correlate the affecting capacity of the multiple variables to the ma'am, sir, it is the where.
Okay, we'll go to the next one. Just.
Hello.
Hello.
One question from my side.
Yes, sir.
Okay, what was your inclusion criteria?
Sir, inclusion criteria. So we had a. So what we had was this. Hello.
Hello.
Hello. Sir. Hello. Hello.
You're audible.
So we had conducted training sessions for all the medical faculties in a college, and therein, sir, all of the.
I do have a problem that when you are saying that healthcare worker includes everyone, okay, right from nursing staff to resident, to consultant to the people, okay. So which part of the healthcare worker you were included in this study, resident or consultant? Because they do have a different level.
Yes, sir. So, sir, all of them were included because residents, consultants, all of those who were supposed to be working in the COVID wards, they were called for training sessions, and all of them were then included. Amongst them, those who gave the consent for this study, they were included.
So, what is my question is, the stress level of a resident will be different. Okay, the stress level of a consultant will be different. How you are going to correlate those things during your study?
Yes, sir. Sir, actually, that was not done in this study, but we could do that by correlating that with the age and experience of the patients. Like we had not particularly taken into consideration the various designations of the faculty. But there was a point wherein the experience of the medical faculty was taken into consideration. So with the people who had more experience, they had less stress as compared to those who had less experience. Sir.
Excuse me. What I want to say is the stress level of a resident is to keep the notes. Okay. राउंड देना है, ये सब चीजें। कंसल्टेंट का स्ट्रेस लेवल है पेशेंट ठीक होना चाहिए, नर्सिंग स्टाफ का है कि उसके नोट पूरे होने चाहिए, उसको मेडिकेशन देना है। तो ऑल द स्ट्रेस लेवल विल बी डिफरेंट एट डिफरेंट लेवल, so you should differentiate those things, then only we can reach to a conclusion that having experience of 10 years will have a less stress with, or rather having experience of 1 year will have a more stress.
Yes, sir. Okay, sir.
It should be differentiated. It is not a generalized stress level for everyone in this situation.
Right, sir.
Okay, thank you.
Yes.
Thank you, judges. We'll move to the next speaker, Dr. Pritam Sangma. Kindly upload your slides.
Hello. Hello.
This is Dr. Pritam Sangma.
Yes, sir. This is
you can start your presentation.
Is my presentation visible?
Yes, you are visible and you are audible. Kindly
Thank you, sir. Good morning, everyone. Myself, Dr. Pritam Sangma, and I'll be presenting a paper on role of placental grading in predicting the intrapartum fetal status in the term patients. Normal fetal growth and survival depends on the proper development and function of the placenta. It serves to maintain a maternal-fetal interface for exchange of blood gas, nutrients, and waste materials. For understanding the true clinical significance of placental calcifications on pregnancy and fetal well-being is a challenging issue for obstetricians. So identifying placental structural abnormalities should increase attention to maternal conditions, fetal well-being, and also the fetal development. Our study evaluates the role of placental calcifications and its impact on pregnancy outcomes among the low-risk pregnancy patients. Our aims and objectives were to assess the placental grading according to the Granum calcification in term patients with ultrasound, to correlate the placental grading with intrapartum fetal well-being and prenatal outcome. And we have included term ANC patients with gestational age between 39 to 41 weeks with no maternal obstetric risk factors, and we have excluded patients with non-PIH, gestational diabetes, and other high-risk obstetric factors, and also the postpartum patients. And our study was a prospective observational study conducted from June 2020 to August 2020 in GMCH Nagpur. And we have included 30 term ANC patients in our sample and were subjected to placental imaging. And they were classified into two groups. One, group A, having a grade 2 placenta consisting of 16 patients, and group B, having grade 3 placenta consisting of 14 patients. And following which the patients were allowed spontaneous or induction of labor, and the outcome were assessed in the form of number of patients undergoing normal vaginal delivery or cesarean section, number of patients having meconium stent liquor, conversion from normal vaginal delivery to cesarean section in view of fetal distress. The immediate perinatal outcome was also assessed by calculating a number of low birth weight days and NICU admissions in the initial 48 hours. And we have used GE Logic S8 ultrasound machine, and probe used was trans-abdominal ultrasound probe of frequency 1 to 5 megahertz. And following were our observations. And if we see the age group distribution, we can see that the group 1 patient having group 1 patient in the group 1 are in the age group of 22-26 years, and group 2 were in the age group of 27 to 31 years, and rest of the patients were in the other age groups. And maximum of the patients were primary gravida, and 11 out of 16 in group 1 underwent normal vaginal deliveries, and 7 in group 2, and 5 in group 1 underwent cesarean sections, and 7 in group 2. And there were various indications for cesarean sections like fetal distress, cord around the neck, non-progression to labor, and others. And out of which 5 patients from group 2, the indication of cesarean section was fetal distress, and 2 patients from group 1, the fetal distress was the indication for cesarean sections. And the rest of the patients had other following indications for cesarean sections. And 2 in group 1 had a fetal distress out of 16, and 5 in group 2 also had fetal distress out of 14 patients. And 2 patients had oligohydramnios in group 1, 4 patients had oligohydramnios in group 1, and 7 patients also had oligohydramnios in group 2. And 2 babies were small for gestational age in group 1, and 6 babies were small for gestation in group 2. And 1 patient in group 1 had NICU admissions, and 2 patients in group 2. And a brief discussion about the diagnosis of placental calcification. Ultrasound examination is considered the gold standard in diagnosis of placenta calcifications. And Granum grading is recognized sonographic method used to assess the placenta calcifications. So grade 0 consists, in grade 0, there will be relatively straight chorionic plate and homogeneous ecotexture of the placenta. And in grade 1 placenta, it will be characterized by an undulatory chorionic plate and scattered echogenic areas. And grade 2 placenta is recognized with small areas of echogenic areas along the basal layer of placenta and coma-like echogenicity. Echogenic densities that originate from the chorionic plate, and grade 3 placenta presents with echogenic indentation extending from the chorionic plate to the basal layer and dividing the placenta into a discrete component which is called which resembles like a cotyledon. And placental calcification commonly increases with gestational age, becoming typically apparent after 36
Can
weeks
you
of
summarize
gestation.
it?
The following were our question, and then there were many studies present, like earlier studies were also present on this calcification, on this study, like on the calcification of placenta. However, there were some conflicting results. Hence, we needed to do a new and focused study on this almost same topic. So, in conclusion, of after the studies, we have concluded that the proper assessment of the association between the placenta calcifications and the pregnancy outcome can be useful for evaluating the high-risk cases. Literature dealing with the topic is lacking and conflicting, but the report regarding the increased risk of adverse maternal and fetal or neonatal outcome in the presence of placenta calcification cannot be ignored. Hence, more attention should be paid in identifying and reporting the grade 3 placenta from radiological perspective, and more close attention should be in intrapartum fetal monitoring is warranted from the obstetric point of view also, so as to minimize the complication of both mother and fetus. And these were the references I have taken. Thank you.
Over to the judges for questions.
Hello, Pritam.
Hello, sir. Yes, sir.
Am I audible, Pritam?
Yes, sir. Yes, sir.
Actually, there are many risk factors. Okay, to predict the maternal as well as fetal risk, but you have only taken the only one criteria, that is appearance of placenta on the ultrasound.
Yes, sir.
So can you elaborate on this? Why the single factor, single criteria is so important? You have given so much of importance to the appearance of placenta.
Actually,
any comment on this?
There had been an increasing case where we can find that the placenta calcification has been not taken into much consideration in our diagnosis. So, but there has been an outcome that that matches with the ultrasound findings, and then the perinatal outcome, which suggests that there could be some relations. Hence, we have focused on this single factor for the time being.
And what if the patient is suffering from other risk factors like the
Those
pregnancy
risk
induced
factors were
hypertension?
excluded, sir. Actually, we had.
Yeah, I have seen that, but you should have compared with those.
Yes. So presently, like we were focusing on this single factors. So hence we have not compared this factor with the other factors. So we were solely focused on this.
Okay. Any
Hello?
other questions from?
Hello?
Hello, sir.
Okay, my question is, why you have not done any statistical analysis? You have, in your observation, you just mention percentage. Why you have not compared all those things by calculating p-value?
It was given, actually, I couldn't mention because of the time constraints. It was given.
No. Whether it is a significant or non-significant, it should be statistically said. Okay, but in your observation, I have not seen any p-value calculation between 2%. By the way, to calculate percentage p-value, which test you are going to apply?
Okay. Chi-square, sir.
Chi-square, good. Okay.
Thank
but
you,
you should do it in your observation only. Then you can say confidently that it is significant or insignificant.
Yes, sir.
Okay.
Thank you,
The
sir.
novelty of your study was?
Pardon, sir?
What was the novelty of your study?
So, in order to prevent the risk involved, like in the outcome, like risk involved in the classifications, and in order to prevent and closely monitor the outcomes.
Okay. We'll have our next speaker, Dr. Pratik Gaikwad. Kindly upload your slides. Dr. Pratik Gaikwad.
Yes, sir.
Kindly slide.
Am I visible, sir? Am I audible and visible?
Yes, you are audible and visible. You can start your presentation.
Good morning, all the faculties and my fellow speakers. I am Pratik Gaikwad, Ortho of Department of Orthopedics of NKP Sims LMH. My topic for the paper is functional outcome after open reduction and internal fixation of type 2 and type 3 Mason's radial head fracture, a midterm follow-up study. Starting with the background, the open reduction internal fixation of the radial head fracture is often difficult to achieve, and radial head resection has been the accepted treatment. The objective for my study was to, in this study, we compared the result of different approaches used in radial head resection with those of ORIF in patients with comminuted radial head fracture. We used a Herbert screw, T plate, and L plate for osteosynthesis using the ORIF. In this study, we used 21 patients with a Mason type 2 and Mason type 3 radial head fractures. All the patients were above the age of 18 years. 14 patients underwent radial head resection using ORIF with Herbert screw and K wire. 4 patients had osteosynthesis with L plate and K wires, and 3 with mini T plates. Functional outcomes were assessed with the help of Broberg and Morris rating system at 1, 3, and 6 months post surgery. Continuing with the explanation, the radial head is crucial to the stability and the function of both the elbow and the forearm. Radial head fracture are 1/3 of all the fractures of the elbow. The most common mode of injuries fall on the outstretched arm with the elbow in pronation and the partial flexion. There is a dilemma regarding the use of conservative treatment versus the surgical therapy for the radial fracture. Conservative treatment has its own demerits of prolonged immobilization, need of constant compression by the patient, and frequent visit to the hospital. In addition, loss of reduction in close treatment can result in malunion and non-union. Early mobilization in conservatively treated fracture could result loss of reduction and poor outcomes. In radial head fractures, excision is recommended when the fragment is larger than 1/3 of the radial head. Although this creates scenario of instability, motion deficit, proximal migration of the radius, and the distal radioulnar joint dysfunction. With the advent of mini fragment plates and the headlet screws that are Herbert screws, the orthopedic surgeons are now trying to improve upon the advantages of conservative management to the advantage of the operative osteosynthesis. Now, the excision of the radial head is commonly done procedure for the type 2 and type 3 Mason's fracture. The operative management can help in early mobilization and improve patient comfort. Studies have demonstrated that the replacement of the radial head with the metallic implant improves stability, but there is residual element of stiffness after fixation as the anterior elbow capsule is prone to the adhesion. This is most clearly seen with associated ligamentous instability and emphasizes that rigid implant do not exactly reproduce the dynamics of the intact or the well-constructed radial head. Implanted radial head doesn't replicate the structural anatomy of the anatomical radial head. Therefore, the reconstruction of the native radial head is desirable in particular in young high-demand patients. The various materials used in the studies where this is a retrospective study of 21 cases of the Mason type 2 and the Mason type 3 radial head fractures carried out in the Department of Orthopedics at Tertiary Care Center from June 2019 to June 2020. The exclusion criteria for Mason's type 1 and type 4 radial head fractures were the type 3 fractures associated with ulnar collateral ligament injuries, patients who are not willing or fit for the surgery, fractures older than 15 days, and compound fractures of grade 3. In this procedure, basically, there are two important procedures initially used for radial head fractures. First is the conservative treatment. We just give slab and do cast after the swelling subsides. And the second is the radial head arthroplasty. In this procedure, we are just conservating the anatomical radial head with the use of Herbert screw, L plate, or T plate. 14 cases were treated by ORIF with Herbert screw, 6 patients by ORIF with mini plate, and 1 patient were treated by ORIF with a locking plate. Post-operative management, we did check radiographs were taken after the surgery. The operated extremity was given a above elbow slab for 1 week. Limb elevation was given on a pillow. First dressing was done on the second post-operative day. Second dressing was done on 7th post-operative day. Patient was discharged after 11th post-operative day after removal of sutures. Patient's guarded mobilization at the elbow. Follow protocol were followed at first, third, and 6th month, and after every 6 months, active assisted elbow flexion, extension, pronation, supination was started on day 1 with full range of motion attained by 6 weeks. Basically, we use Broberg and Morris functional rating score. It includes motion, strength, stability, and pain. Along with this, we also used in assessment, we also assessed using grip strength, range of motion of the elbow, and the forearm were also measured. For measurement of range of motion, a standard long limb goniometer were used. In statistical analysis, methods were employed. All the analysis were performed on GraphPad Prism software. Descriptive statistics, including means and standard deviation, were calculated and different groups were compared. Mann-Whitney U-test was used to evaluate the significance of intergroup differences, and the p-value of less than 0.05 was taken out. While discussing the results, various factors were considered. First is age and gender differences. In our studies, 10 patients were in the age group of 21 to 30 years, 4 in the range of 31 to 40 years, 2 in the range of 11 to 20, 2 in the range of 41 to 50, and 3 patients in the range of 61 to 70. There were 9 males and 12 females in the study sample, which is not significant in the difference. Type of fracture and the surgery performed. The maximum number of patients were in the type 3 Mason's type 3 radial head fractures, and 7 were in the type 2 fractures. 11 cases were treated by ORIF with Hubbard screw, as I mentioned earlier. 3 patients effect of type of surgery on the elbow motion. Motion of the elbow was assessed by goniometer at first, third, and 6th month post-surgery using 3 different approaches, that is T-plate, L-plate, and the Hubbard screw. We have noticed that motion of the elbow was improving every month and was better at 6 months than 1 or 3 months at that point of time. This is a graph showing effect of flexion, pronation, and effect on flexion, pronation.
Kindly summarize your overtime. Kindly summarize your overtime.
Hello. I'll complete it faster. I'm very sorry. The results, another criteria for result was the effect on the strength. This is a graph showing the effect of strength using T-plate, L-plate, and the screws. Effect of type of surgery in the pain. The T-plate surgery group, the 1 patient experienced moderate pain. In L-plate surgery group, all patients experienced moderate pain. In Hubbard screw group, at 1 month, 9 patients showed moderate pain on activity and 3 showed mild pain and 2 showed no pain. Effect on stability, effect of type of surgery on the stability. All the patients were stable irrespective of the type of surgery performed. Now, overall Broberg and Morris functional rating score. This is a representation showing the overall outcome using the Broberg and score at 1 month, 3 month, and the 6 month. This picture represents the effect of different surgery approach following radial head fracture and functional assessment using Broberg and Morris rating system. Score at 3 and 6 months was compared to that of 1 month, and less than 0.01 comparison between 1 and 3 months, and p-value of less than 0.01 between 1 and 6 months. Concluding with the study, ORIF of the type 2 and type 3 radial head fractures have good functional outcome. Careful patient selection, intraoperative technical details, and addressing the associate involvement of lateral ulnar collateral ligament tear can also give good results. Long-term follow-up is required to see further the comparison with the radial head resection and radial head arthroplasty. We found that surgery using T-plate or L-plate or Hubbard screw has similar outcome of recovery from the radial head fractures. These are the references. Thank you.
Over to the judges.
I guess this is a comparative study.
No, sir, it is not a comparative study, sir. We didn't compare. Actually, we just found the outcome of 3 different types of osteosynthesis methods, sir.
Okay, but you have calculated, you have compared these 3 techniques. Okay.
Yes, sir.
Of radial head operation. Okay.
Yes, sir.
So how you have calculated sample size? It is a retrospective study, agreed. But how you calculated your sample size? Because to reach to a conclusion, you need to have a proper sample.
Yes, sir.
What was the method of calculation of your sample size?
Sir, actually, we didn't want to actually we wanted to compare between the osteosynthesis method, the radial head resection, and the arthroplasty.
You have calculated p-value. Okay.
Yes, sir.
So you have compared these things. Okay. When you have compared, you should have a proper sample size. So what was the formula by which you have calculated sample size?
Was it a proportional formula or was it a mean central deviation formula? What was the central tendency formula? What formula did you use?
No, sir, I couldn't answer this.
Okay.
Okay, a few more questions from the judges and we move to our next speaker. Dr. Anant Sakshi Kalra. Kindly upload your slides.
Good
You
morning,
can.
everyone. Am I audible?
Yes, you are audible. Kindly upload your slides. Share your screen.
Yes, sir. Is my screen visible?
No, now you are visible. Put it on slideshow.
Yes. Is it visible?
Yes, you are visible and audible. You can start.
Good morning, everyone. Today, my topic of presentation is CT angio versus digital subtraction angio for diagnosis of intracranial vascular pathologies. CT angio is a rapid, minimally invasive and convenient method. So it is the initial diagnostic modality. However, DSA has better resolution and there is no interference from the surrounding bony structures, but it is an invasive modality. What were the aims and objectives of the study? We wanted to study the sensitivity and specificity of CT angio and compare the results of CT angio with DSA and to evaluate the discrepancies, if there are any, between the two modalities. What were the inclusion criteria? Any patient who was suspected to have intracranial vascular pathologies which were referred to our department, or any patient who were diagnosed to have SAH, intraventricular or intraparenchymal hemorrhage on a CT plain head. Exclusion criteria were the same as we take for any contrast CT scan. Materials and methods. The study was done in GMCH radiology department over a period of 2 years and 100 cases were included. We used Philips DSA biplanar machine and Philips CT 256 slices. Now the protocol of CT angio was, we did a plain scan and then we did a contrast scan using 50 ml of contrast at the rate of 4 to 5 ml per second, and bolus tracking was used, and various reconstruction images were formed from the baseline images. In DSA, we took the retrograde approach from the right femoral artery and took various standard views like AP, lateral, and Townes view. And we took oblique and other additional views considering the vascular anatomy of the particular patient. Also, 3D images were taken with a 240-degree rotational run with the contrast of 70 to 80 ml per study. What for the observation? The mean age of presentation was around 54 years. Most of the patients were male, that was 62%. The patients presented with various symptoms, but the most common presenting symptoms were headache, hemiparesis, and loss of consciousness. Now, this was our data. 67 of the 100 patients were normal on both CT angio as well as DSA. 18 patients had aneurysms, which were diagnosed on DSA, but on CT angio, there was 1 false positive and 1 false negative. Considering AVM, there were 2 false positive and 1 false negative on CT angio. CCF, both were diagnosed on DSA as well as CTA. AV fistula, there was 1 true positive and 1 false negative on CT angio, while dural AVF was not diagnosed on CT angio, but it was diagnosed on DSA. This was the stats that we got. The sensitivity and specificity of CT angio is pretty high, but considering all the vascular malformations, sensitivity is comparatively lower than the DSA. Now, for aneurysm, sensitivity and specificity both are pretty good, which were as consistent with the other studies, the previous studies. While for other vascular malformations, sensitivity was not very high for CT angio, and we had to do DSA for them. So out of 18 aneurysms, 14 were reported without discrepancy on CT angio, while in one patient there was additional aneurysm which we did not get on CT angio. There was discrepancy in the size of one aneurysm. Less than 3 mm aneurysms cannot be detected on CT angio, which we missed. And there was one false positive, which was just a turn in basilar artery, but we reported as aneurysm on CT. And there was one which discrepancy got resolved after reviewing the senior radiologist. In vascular malformations, out of 10 AVMs, 9 were diagnosed on CT angio, but 1 was missed. But there were 2 AVMs that we reported on CT angio, but on DSA, they turned out to be dural AVFs. So what is the problem with CT angio? It cannot detect anything less than 3 mm of aneurysm. There is overprojection of bony or calcified structures. So aneurysms less than 3 mm cannot be detected. While DSA, it gives pretty good results, but it is operator dependent. Now coming to a few cases, this was a patient, 30-year-old male having various dilated channels on the scalp, and on CT we found various transosseous arteries. On DSA we found multiple dural and pial AV fistulas. Another patient of 35-year-old male patient, on both CT angio and DSA, AVM was found. Another patient, 54-year-old female with headache and 1 episode of seizure. We found a PCOM aneurysm on both DSA and CT angio. Just DSA gave a better resolution, and we could see how to approach the lesion for embolization. In conclusion, CT angio has a high sensitivity. It is the preferred initial imaging tool, but DSA evaluation is needed if you have to look for anything other than aneurysm like AVM, dural AVF, or AVF. These were my references. Thank you.
Over to judges for questions.
Hello.
Hello, sir.
Okay. Define sensitivity and specificity.
Sir, sensitivity is how many patients actually had true. It's false. Like if you are ruling out, sensitivity is to rule out the false patients, and specificity is to rule in the true positives.
Is that true or it is reverse?
Sensitivity is a ruling out and specificity is ruling in.
Sensitivity is true positive rate and specificity is true negative rate, according to me.
Okay.
Okay. So, in conclusion, you said CT angiography is more specific and more sensitive.
So it is sensitive, but specificity decreases if you go for anything other than aneurysms, because in AVFs. Yes, sir.
But first point in your conclusion was, just go to previous slide.
Yes, sir.
What do you say?
So it has a high sensitivity and specificity, but if aneurysms less than 3 mm are considered, you cannot see them on CT angio and you have to do DSA then.
No, but you mentioned in your aim that it is less than 3 or more than 3 mm of aneurysm that you are going to diagnose with these things. You just said that you are going to check only specificity and sensitivity to diagnose cerebral aneurysm.
And sir, if there is any discrepancy in the results, so this was the discrepancy.
Okay, this was the discrepancy in the results.
Yes, sir.
Okay. That's all from my side.
Other judge?
No questions.
Dr. Anand Deshmukh, kindly upload your slides. Sakshi, you can stop your
Yes,
screen sharing. Sakshi, please stop your screen. Dr. Anand Kalra, kindly upload your slides. Share your screen. Start on slideshow. Okay, you are visible and hello.
Hello. Am I visible?
You are visible and audible. Yes, you are visible and audible now. You can
Good morning,
start
sir.
your presentation. Good morning. You can start your presentation.
Good morning, sir. My name is Anand Deshmukh. I'm resident of GMC Nagpur. My topic of presentation is endovascular management of intracranial aneurysms. With the introduction, there is a 3 to 5% of all acute strokes, there is a chance of the spontaneous SAH. The estimated worldwide incidence of the SAH is 9.1 persons per 1 lakh persons per year. Male to female ratio is 1.2, as it is more common in the females, and the factor associated with the increased risk of aneurysms are the black race, hypertension, smoking, then alcoholism, and there is sympathetic mimetic drugs, and aneurysm larger than 7 mm. The early detection and treatment can prevent the aneurysm rupture and can address the sequelae to initial ruptures. After international subarachnoid aneurysm trials and borrowed rupture aneurysms trials, the endovascular managements are a primary treatment at the present scenario. My aim of the study is to study the safety and efficacy of the endovascular management of the intracranial aneurysms, coiling of the intracranial aneurysms, and to observe the procedural and intermediate post-procedural complication and its management. In this study, we have used the inclusion criteria with the patients having the intracranial aneurysm on the CT or the 4-vessel DSA with suitable anatomy, and the exclusion criteria being the deranged coagulation profile, unfit patient with the pre-acidic checkup, the pregnant ladies, then allergic patient to contrast media, and the deranged KFTs, and the patient which we're not giving the consent for the procedure. The patient study is conducted at the Department of Radiology at GMC Nagpur. The sample size being 30 cases. The machine uses Philips Lurex for FD biplanar DSA machine and CT Philips DSA machine, CT machine. The methods is a patient with the intracranial aneurysm were assessed with by preoperative CT angiography or the DSA, and embolization of the aneurysm done with the detachable coils SOS. Then a post-operative follow-ups being done at the 1 month and 6 months for the well-being of the patient. In this observation, the study conducted nearly 30 patients, included 30 patients. The most common age group being the 51 to 60 years, and most is more common in the females, as I said before. The mean size of aneurysm in our study was 6.1 mm, largest being 8 mm and last smallest being 1.6. As seen in the pie chart, the risks, then aneurysmal locations are ACOM, the aneurysm present at the ACOM arising from the ACOMs are more in 26%, ACA and ICA junction is 23%, MCA 16.6%, ICA and PCOM junction is 16%, vertebral basilar junction is 13%. The wide neck, there is the wide neck aneurysm is considered when the aneurysm with the absolute neck more than 4 mm and neck diameter more than half the parent vessel diameter. The aneurysm may be of 3 types. They are single lobe, bilobe, and more than multiple lobe. The most common being the single lobe, they have 50%, and bilobe is 36%. The 4 types of this, there were 4 types of the aneurysms. Most common one, saccular one, and then the fusive, followed by fusiform, dissecting, and mitotic types. Conclusion: majority of the subjects were female. The hypertension, tobacco use, and alcoholism were the most common acidity risk factors. The ACOM aneurysm is the most common site. ACOM is the most common site for the aneurysm. Then anterior circulation is more commonly involved than posterior circulation. Aneurysm of anterior circulation, aneurysm of any size can rupture, and therefore aneurysm of the ACA rupture at the smaller size compared to the other vessels. The adequate occlusion of the aneurysm can be done using the endovascular coiling in more than 90% of the cases, and acceptable with the acceptable rate of complication. And the balloon-assisted coiling is more time consuming, but it is with less complications. Although endovascular management is costlier, but it is it is more with the improved survival and survival rate and decreased dependence. Here are the few cases. Here is the contrast filled out pouching arising from the left MCA which left MCA, which is coils with the SOS interdiaphragmatic coils. Here is a second patient, is 55 years old, female, presented with the intraparenchymal bleed in the left frontal lobe, with the contrast field outpouching noted arising from the left ACA. With again, this is a case of presentation showing the SOS coiling of the aneurysm. Here is a, we can see there is a wide naked contrast field outpouching noted in with the help of TSA arising from the right ICA PCOM junction, and which is coiled with the help of balloon assisted technique with the detachable coil. This is another case of the aneurysm with the 30 years old female with a subarachnoid hemorrhage in the basilar systems. This is a contrast field outpouching noted in the 3D VRT images. We can see of the DSA. We can see there is a contrast field outpouching noted arising from the large PCA, suggestive of a large PCA aneurysm. We can see there is also SOS coiling is done.
You are in the last minute.
So this is a bilobed aneurysm with coiling is with the detachable coiling is done. These are my references. Thank you.
Thank you very much. Over to the judges for question.
Hello.
Sir.
Okay, I would like to congratulate you for successful treatment of all the cerebral aneurysm by your technique. But my question is, go to your conclusion side. In this slide, I'm like having some problem with your fourth conclusion. Have you done in your study this comparison?
Which, sir? Balloon assisted coiling.
Fourth point.
Adequate conclusion of aneurysms.
You have compared two techniques for coiling, okay? But in your study, I was not able to see any of this comparison in your observation, brother.
Have you highlighted this in your review of literature or in your observations comparing the balloon with the balloon technique with your technique?
So balloon technique is more time consuming, but there is, as we are faced with the less problems, it's true, sir.
Have you shown some table literature in your that's what the judges
So because slide will be too lengthy, that's why I not added that.
No, but whatever you are concluding, that should include in your observation. Otherwise, how I can I will know that it is more time consuming. Have you compared the time required for both the procedures?
Sir. We have compared time for the with balloon assisted coiling and without balloon assisted coiling.
Yeah, I agree. You have compared that time, but it should reflect in your observation. That then only I will happy with your conclusion that you have done it and you have said it. Otherwise, it is like you are just like written, but you have not done it. Okay.
Okay. Okay.
That's all from my side.
From the other judge?
No, sir, no question.
Okay, then we'll move on to our next presenter, Yash Dhawani. Kindly, Yash Dhawani, kindly upload your slides.
Yes.
Unmute yourself, Anand.
So is the slide visible?
Yes, you are visible and audible. You can start your presentation.
Good morning, sir. I'm orthopedic resident in Lata Mangeshkar Hospital. I'm presenting a case series of a newer technique of a close reduction of primary anterior shoulder dislocation. It is a different approach. Has been proposed by Dr. L. Prakash. I've just did a case series on the paper of considering the 20 patients. Abstract, a new maneuver of anterior shoulder dislocation has been advocated in the case series of 20 patients, which did not require any anesthesia, analgesia, pre-medication, assistance traction. It is an effective and easy to do maneuver and has a success rate of 19 out of 20 patients. Literature has described many methods for the anterior shoulder dislocation, but this stands in unique in view that it is painless for patient. Introduction: the glenohumeral joint of the shoulder is the most commonly dislocated joint in the human body and accounts for 45% of all dislocations. Acute dislocation is a surgical emergency and demands urgent relocation. Anterior dislocation of the shoulder is commonly seen in accident, emergency, and trauma clinics and accounts for 95% of the shoulder of all the shoulder dislocations. These patients present in a manner that a trained trauma physician can recognize the presentation itself. The arm is usually held in abduction and internal rotation, and physical examination reveals loss of normal contour of the deltoid, and acromion is prominent posteriorly and laterally. Occasionally, such cases are missed or present with the fracture of proximal humerus, especially when they receive the treatment from the unqualified practitioners who commonly practice in rural areas. Owing to the paucity of the literature, no standard treatment protocol exists in neglected anterior dislocations of the shoulder, though most such chronic cases are managed by the open reduction. Acute treatment of the dislocated shoulder in the closed reduction, which should be performed as soon as possible, either on the field or in the emergency department. Aims of the study were to study the efficacy of the newly proposed L. Prakash method in reduction of anterior dislocation of glenohumeral joint of shoulder, to determine the pain associated with this method, to determine the age and sex distribution of anterior shoulder dislocation, to determine the time taken for reduction, to determine the number of attempts required by this newer method, and to study the complications associated with this method. So the method, this study was conducted in 20 patients presenting in the emergency department at tertiary care hospital over a period of 3 months. The diagnosis was confirmed on clinical examination and X-ray after obtaining the brief history. A thorough neurovascular examination of the involved extremity was carried out. A written informed consent was taken from the patient before attempting the reduction. In this maneuver, the surgeon either stands by the side of the patient at his back or at his back, while the patient will sit on the chair with the backrest and pushes his back against the chair so that it fixes scapula. The traction has no role in this method, and this is the key point of this method, that all the methods proposed earlier had traction as the important component in the reduction. But now in this technique, as there is no traction, there is a minimal pain in the reduction. The forearm is held with the elbow and the wrist. Gentle adduction of the arm is given by drawing the elbow towards the flank, that is midline, while the forearm is supinated, and the arm is subjected to the gentle external rotation very slowly over 2 to 3 minutes. This maneuver is carried out. It is a less aggressive maneuver as compared to the other maneuvers, as this is carried out over 2 to 3 minutes. So it allows the adequate relaxation of the soft tissue around the shoulder, and relocation is very less painful as compared to the other. The most important step is to remember that keeping the patient engaged in conversation so as to relax the patient and divert the attention and avoid the undue and voluntary muscular spasms. Automatic reduction has been observed in almost all the cases without any additional maneuver, which is felt as a clung and patient tells the sudden pain relief. The limb is then internally rotated so that the fingers touches the opposite shoulder, and the sling is given to the patient in this position for coming 1 month. So this is the maneuver. This is the clinically how the maneuver is performed. Observation: it was noted that all the patients were males, mostly dislocation resulted due to the sustaining the fall, industrial injuries, and less likely to the vehicle accidents. 19 out of 20 patients were successfully treated with this method, which presented with the acute dislocation of shoulder. The age distribution of the patient as observed was between 22 to 65. The sex of all the patients presented to me were all the males. The time since dislocation was 15 minutes to 30 days. The time taken for the reduction was 2 to 5 minutes. The number of attempts, all the 19 patients in which the successful reduction was possible were reduced in single attempt, and no complication was noted as there was no traction and to the neurovascular structures around the shoulder. This is the pre-reduction X-ray and the post-reduction X-ray of the patients. Discussion: more than 50 to 60% of the dislocation of the large joint involve the shoulder, that is glenohumeral joint. Up to 90 to 96% of shoulder Up to most of the dislocations can be reduced in the emergency department using the simple methods. The ideal method should be simple, easy, quick, effective, atraumatic, pain-free, and require little assistance or medications, and cause no additional injury to the shoulder joint and musculoskeletal structure or neurovascular structure. All the previously proposed methods had traction as an important component. Now this method don't have any traction as an important important component. This method is one of the most effective and efficient for treating acute shoulder dislocation. In this study, we determined that the average time required for successful reduction was 3 to 5 minutes. Almost all the patients had significant VAS score improvement immediately after the reduction was achieved. None of the patients who were successfully treated required any analgesia and anesthesia. This method is different from the other methods published because the exact combination of the movements to be performed in the erect position without any traction, anesthesia, analgesia, leading to the 100% successful reduction has not been previously described. These are my references.
What are the judges for the question?
Hello.
Yes, sir.
Okay, my question is, in your title, you said a method to reduce shoulder dislocation without any anesthesia or analgesia.
Yes, sir.
Okay, which pain scale you used during reduction?
Sir, VAS score.
VAS score, how you are going to elicit VAS score?
Sir, actually the patient of dislocation presents with extreme pain, and as soon as the reduction is achieved, there is almost no pain. There is significant reduction in the VAS score.
You need to use a scale to say that this technique is without anesthesia or analgesia. So you need to have a scientific scale.
Yes, sir.
So VAS scale is, you need to show a scale to a patient and you need to ask whether he's feeling pain. But during procedure, do you feel VAS scale is feasible?
No, sir. Actually,
So which scale you are going
pre-reduction
to
and
use?
post-reduction we can.
तो पोस्ट रिडक्शन तो कैसा है यार, पेशेंट को जब दर्द होता है तो पेशेंट पोस्ट रिडक्शन तो बोलेगा ही ना पेन नहीं है करके. Agreed?
Yes, sir.
During reduction, you say it is a painless procedure or it doesn't require any anesthesia or analgesia.
Yes, sir.
Okay, so which pain score? Have you heard of Wong-Baker pain score of face pain scale?
No, sir.
Then you need to do this. When your title is anesthesia and analgesia, na, you should apply or you should focus more on an analgesia required for reduction. Okay.
Yes, sir.
And you don't say, you are not mentioned any role of muscle relaxation or repeated shoulder dislocation during this thing. Have
Sir,
you said
these
this?
all were primary shoulder dislocations, and the one patient in whom the reduction was not possible presented late, actually after 1 month. So that was the only failure of this method.
No, it is agreed. I'm not I'm not like criticizing your method of reducing it. I'm just wanted to know, when you are labeling it as a painless procedure, you should have some scientific background. Secondly, according to me, repeated shoulder dislocation will have a different result other than primary shoulder dislocation. This should be mentioned in your study.
Yes, sir.
And pain scale, okay?
Yes, sir.
So Wong-Baker face pain scale should have applied during reduction. So you reach to a conclusion, okay?
Yes.
Okay, thank you.
Thank you, sir.
One thing I would like to make a point that whenever you are making your aims and objectives, kindly be careful in selection of your words, whether you are using determine, whether you are using estimate, efficacy, because it reflects what your study is about and how is the method is going to be applied.
Yes.
Okay. So, any questions from the other judge? Okay, we'll move on to the next speaker, Dr. Balaji Bharte. Kindly stop your screen share, Yosh. Dr. Balaji Bharte.
Good morning, everyone. Myself, Dr. Balaji Bharate, junior resident in orthopedics department.
Kindly share your slides. Slide share. देखो उसमें share screen लिखा होगा.
Yes, sir.
Share screen.
1 minute. It is visible, sir?
Yes, now it's visible. Put it on slideshow.
Good morning, everyone. I am Dr. Balaji Bharate, Junior Resident Department Orthopedics, Lata Mangeshkar Hospital. I am today present a paper of changing technique paracentral pin insertion in placing the distractor pin in anterior cervical discectomy and fusion ACDF in 25 consecutive cases. Introduction: ACDF has been considered as a gold standard for symptomatic cervical disc degeneration, cervical myelopathy, cervical vertebra fracture, and prolapse intervertebral disc. The procedure is usually done by placing the distracted pin in central position. In this study, we show the surgical and functional outcome of using a new technique by placing a distracted pin in paracentral position while doing ACDF surgery. The ACDF is a gold standard numerous cervical pathology. In this technique, we differ from other technique is the central pin placement. How this technique is differ from other technique? In this diagram, we show this is the C4 vertebra, this is C5 vertebra. In central pin insertion, we insert the pin in central position. In paracentral position, these two vertebra, we insert the pin in paracentral position. The material and methods. We study the 25 consecutive cases. Single and double level ACDF surgery is included. Pathologies like cervical radiculopathy and cervical myelopathy needing anterior approach we included. Cases of traumatic spine and infective spine were excluded. Patients were evaluating the parameter like operative time, blood loss during surgery, post-operative dysphagia, and ODI score. In this technique, both technique, central pin and paracentral, there is a equal distance we can measure by the rural. In this, measure in intraoperatively. This is the clinical image of paracentral approach. This is the C4 vertebra. First diagram, we see the C4 vertebra, C5 vertebra, and this is the second diagram. We can see the paracentral pin insertion. Advantages of paracentral pin insertion technique over routine central pin insertion technique. First, we reduces the blood loss. As paracentral pin insertion technique has some drill hole made for distraction is the same that would be the used for screw fixation, thereby reducing the blood loss that would be otherwise occur because of additional drill hole created in the center of vertebra for distraction in routine technique. And next advantage is it reduces the surgical time. As there is no need for additional center hole creation for distraction of the vertebra, there will be reduce the surgical time. It acts as a medial retractor. As the paracentral pin insertion act as it is placed, it reduces the retraction generally used in central pin insertion. While wide exposure, because of pin are in paracentral, the exposure of the disc is better, which is help us in better decompression as compared to the central pin placement. In this technique with the same hole, first we use the paracentral hole. This hole, the same hole can be used for the plate placement. It reduces the post-operative dysphagia as paracentrally inserted pin act as retractor and reduces the work for assistant. A result: 25 cases were operated within this technique. There are no pain-related complication. Blood loss and surgical time was less as compared to the cases done with central pin placement. Average blood loss in this technique is 50 to 100 ml. Incidence of dysphagia was less. Then ODI score show comparable improvement with patient done by paracentral pin incision. The male-female ratio in our study is 15:10. Surgical time for this surgery is 120 to 150 minutes. Here we see the preoperative and postoperative diagram in which 25 patients, the 15 patients have the symptom of radiculopathy and 10 patients have the symptom of myelopathy. After postoperative, there will be a maximum patient have recovery and there is a reduce the symptom of radiculopathy and myelopathy patient. ODI score. We pre-oply and post-oply, we divide the patient in different ODI score in which the maximum patient are in between 61 to 80% patients. Some of the patient between 81 to 100 patient and some patient have 40 to 60% pre-operatively. After post-op, ODI score is measured and there will be major improvement in pain intensity, sitting capacity, walking capacity in the post-operative patient. And there will be major improvement in this patient. Discussion. The anterior cervical discectomy and fusion is currently the most commonly selected surgical procedure for the treatment of cervical disc herniation or degenerative because it is effective at achieving immediate stability, restoring the normal lordotic curve, and increase the fusion rate. It also safer as compared to posterior approach of cervical as there is a high risk of spinal cord injury in posterior approach as compared to the anterior approach. Anterior cervical discectomy and fusion is an established procedure for the patient with cervical radiculopathy and degenerative disc diseases. Many technological modification and post-operative degenerative changes have been reported since the technique was originally described by Smith and Robinson. Routine way of doing ACDF is the is placement of distracted pin in the central position, following which another hole are made for the plate insertion. The paracentral pin placement has not been described in literature previously. While comparing this standard technique with observed many advantages as described above, while function outcome are compared in both the technique. The conclusion of my study is the use of paracentral pin insertion in SADF surgery is found to be effective technique in terms of reduction of medial distraction, thus reducing post-operative dysphagia, reducing blood loss during the surgery, reducing surgical time, better exposure for the disc, reduce the fatigue of the assistant. The functional outcome operated by this technique is comparable to the standard technique. Thank you, sir.
Thank you, Dr. Balaji. Over to the judges for questions.
Hello.
Hello, sir.
Again, in your observation, you have not compared anything and you have concluded like more of a theoretical type of conclusion, not your study outcome conclusion. Whatever the conclusion you have drawn is more of a theoretical type rather than your study outcome.
Sir, I have the many
compared ODI amongst two groups.
Yeah, sir, two groups. Sir, we study only the paracentral pin insertion group.
Okay, but we express ODI as percentage. Now, have you have you compared the percentage of ODI?
Yes, sir. I have sir 25 out of 25 patient with pre-op and post-op leave. We compare the ODI score pre-op leave. Maximum patient have sir ODI score between 60 to 80%. And some of patients have ODI score between 80 to 100%. And this patient, after the surgical treatment, the ODI score of this patient will be reduced to 21 to 40%. Some have reduced to 0 to 20%. After post-op and pre-op, sir.
Okay, what about blood loss?
Sir, blood loss in this surgery, sir, approximately 100 ml blood loss, sir, average surgical time.
It is a theoretical concept. Whatever I'm telling you is, have you measured the blood loss during the surgery to reach your conclusion? It is between or it is 50 plus minus 10 ml. This type of statistical analysis I need to have while concluding something. Otherwise, it is theoretical concept. No? It is 50 to 100 ml of blood loss.
Sir, maximum patient the blood loss is 60 ml or 50 ml, sir. In some of the patients,
what I want to say is you should measure it and then you should conclude it.
Okay, sir. Okay, sir.
You have not measured it. Okay.
Okay, sir. I have just 25 patient average blood loss. ऐसा क्या सर मतलब टोटल 25 केसेस के हिसाब से
हाँ तो एवरेज ब्लड लॉस कितना था आपका it should not be like 50 to 100 ml
it was sir 80 ml sir 80 ml sir 75 plus or minus 10 ml sir yes sir
80 ml was fixed
yes sir
80 ml was fixed for every case
no sir 75 ml plus or minus 10 ml sir every cases
okay you have not mentioned that
okay sir okay sorry
what do you understand by standard deviation? You said plus minus 10 ml. What is your understanding of that?
Sir, मतलब
you said 75 plus minus 10.
Yes,
so
sir.
What I expect minimum blood loss कितना हुआ होगा और maximum blood loss कितना होगा?
Minimum 65 होगा sir, maximum 85 होगा sir, plus or minus 75 के sir.
Plus minus 10 ऐसा नहीं होता boss. Plus minus 10 मतलब 20 होता है वो. So it is 55. Okay?
Okay sir, okay sir.
हाँ, उस टाइप का calculation आता है वो.
Okay sir.
Okay.
Okay.
Questions from the other judge?
No, sir. No.
Just, that plus minus 10 is your precision of study. Okay.
Yes,
now we're coming to our next speaker.
Thank you, sir.
Nikhil Halman. Kindly stop your slide sharing, Balaji.
Yes,
next speaker is Kaustubh Patil. The sequence is using Kaustubh Patil. Is Kaustubh Patil here?
Sir, he is actually JR3, sir. He is there for his prelim exam, sir. One for his prelims.
Next, Nikhil Halmare.
Nikhil Halmare.
Yes, sir.
You can present your program. Nikhil, kindly upload your slides.
Sir, am I audible, sir?
Yes, you are audible, but you have not started your slides.
Good morning, everyone.
Your slides are not visible. Put it on slide. Open it in the
click cross screen click.
Open your slides. Yes, now you are visible.
Visible, sir?
Yes, you're visible now. You can start your presentation.
Yes, sir. Good morning, everyone. I am Dr. Nikhil Halmari, Junior Resident, Department of Orthopedic at Incubation Institute of Medical Science Research. Today's topic for my paper presentation is outcome of iliacal ring fixation in the infected non-union of the femur fracture. Sir, 1 second. The aim of my study is to determine the outcome with the use of iliacal external fixator in infected non-union of the femur. And the material method used for this study is type of study is a single center retrospective study at the Teaching Medical Institute. Patients who were treated with iliacal external fixator for infected non-union of the femur fracture from 2015 to 2018 were assessed. And in this study we use the achievement of union and association for the study and application of the method of iliacal to outcome assessment. In this study, 10 patients, 9 male and 1 female of infected non-union femur fracture were included. In between the age group range from 7 to 65 years, and median age group was 43.5 years. Procedure for iliacal fixation is under all assertive procedures. Spinal anesthesia, patient were operated. Iliacal frame was constructed as per the radiographical and clinical finding preoperatively, and then adequate debridement at the non-union site, and with the bone ends were freshened. And is there any hardware like plating or nailing is done previously and then removed. Then a thorough lavage for canal was performed, and the defect was assessed for size, and docking at the site was done. In defect is less than 2.5 centimeter, and if defect is more than 2.5 centimeter, the acute docking is not performed. Then we done the single corticotomy done if the defect is less than 5 centimeter in gap union, and if defect is more than 5 centimeter, diaphyseal or double watermark at the metaphyseal was done. Initially, few cases bone transfer was done over the intermediately thin nail to guide the transport and achieve proper docking. And after post-op, in immediate post-op period, limb raising was done, and neuromuscular integrity was in the operated side checked with antibiotic administration based on the culture and sensitivity report, and check the frame stability manually by ensuring the appropriate fitting at the nut bolt and proper tension on the wire. This slide is showing one of the case study clinically and radiographically course of the complete union outcome in the one study patient. Radiograph A shows the sharp femur fracture with and B showing the previously treated with the plating with insert cement bead insertion. Here we operated the iliacal ring fixation with the corticotomy distraction, and with the for bone translation and alignment we use the bone over nailing. And this radiograph D showing the after removal of reserve string and regeneration of consolidation and non-union achievement. And clinical radiograph showing the heel infected operative side with the complete length of leg length discrepancy. Result of my study is median consolidation period was observed to be 8 months, and the median union time was 11 months. In this study, 8 patients were achieved complete union of the femur fracture. 3 patients had a pin track infection, and 1 had a developed infection. The median follow-up period was 24 months. Serial radiographic evaluation done on follow-up visits shown a cure of infection. Infected markers were evaluated in the next 2 follow-up visits, were found to be within normal limit. Clinical evaluation showed a good range of motion follow-up and had a good functional outcome. At final follow-up, 70% had excellent and 7% had a good result. Discussion Here in the study, the infected femoral non-union fracture, the iliaceal fixation is advantageous over the other modalities. The advantages include the percutance fixation application with minimal blood loss, three-dimensional deformity correction, leg length discrepancy correction by distraction of stenosis and bone transport, and high stability allowing early motion and weight bearing. But disadvantage is that only is the method includes the limitation of the non-compliant psychological impairment in the patient in the cost apparatus and non-learning curve. Those related extra fiction devices such as pin track inspection at the time of wire insertion was. In the study, we use the criteria excellent, good, fair, and poor on the basis of the assessment for the study and application of the methods for Iliazarov bone result and functional criteria. This is just chart showing the my study results with the other study that done on infected non-union femur fractures. Number of patients was 10 in femur fracture. Bone result excellent in 7 cases, good in 1, and fair in 2. And in functional results are excellent in 5, good 3, and fair 2. Conclusion. Here study concluded that infected non-union femur fracture is a disaster situation affecting the quality of femur fracture. Radical debridement with external fixation using iliaceal fixator remain the mainstay of treatment. With such a bone union was achieved in over 80% of the cases. The iliaceal technique observed an effective solution by which limb salvage, union, and eradication of the infection could be achieved in most of cases in spite of the high complication rates. Meticulous debridement, stable fixation, correction of the association deformities, and shortening and early functional limb use are the key functional management. Iliaceal fixation to be the most reliable and outstanding method in providing excellent good bone and functional result in the infected non-union femur fracture. And these are my references. Thank you, sir.
Okay, over to the judges.
Hello.
Yes, sir.
Your study was prospective study or retrospective study?
Sir, retrospective studies.
So how you did your follow for 24 months for a patient?
Yes, sir. Monthly
In
follow.
retrospective study, according to me, you will get a patient and retrospectively you are going to analyze whether the procedure was done.
Sir,
You have explained the operative procedure also.
So we have total data, sir.
No, in retrospective, what my concern is, in retrospective study, you are going to get a patient who will
Yes,
have a union of your femur after iliaceal fixator. And then retrospectively, you are going to analyze things. But in presentations, you have prospectively analyzed all the things. You mention your operative procedure, you follow the patient for 24 months, and you are saying that is a retrospective study. How it is possible?
Sir, we study in half period of the follow-up, before and after.
No, still not agreed with your retrospective type of study. Secondly, what was your objective, primary objective? You said your aim was outcome. What was your primary objective?
Sir, generally comparative studies, sir, between other modalities and iliaceal fixation in between.
No. Go to your second slide. You said your aim was to compare the outcome. Okay. But what was
Yes,
your
sir.
objective? How you are going to compare your aim to determine the outcome of use of iliaceal external fixator? Okay. But
yes, sir.
On what objective you are reaching to your aim? What was your primary objective? What were your secondary objectives?
Sir, advantage means blood loss, patient mobility, bone results, and functional results, sir.
According to me, your primary objective was to see whether the bone is united or not. Secondary objectives were like compare complications, surgical time, surgical procedures. Okay, you should mention all these things. But it is not a retrospective study according to your presentation. But you mention in your presentation that it was a retrospective study. That's why I was concerned.
Yes, sir.
That's all from my side, sir.
Question from the
No, sir.
Yes, sir.
So basically, I wanted to say that this is an unrespective cohort study, but we have to be very specific on the new studies. Okay, going to our next speaker, Dr. Mansi Dalvi. Kindly stop your share screen.
Yes, sir.
Dr. Mansi Dharan, kindly upload your slides. Hello. Hello. Am I audible? Mansi, Dr. Mansi, kindly upload your slides.
I can hear you, sir.
Devani, is Mansi Dalvi or Harsha? Devani, are you there?
Yes, sir, I'm here. If we don't have Mansi, then Rasika is next. Rasika is next.
Okay. Rasika. Rasika, are you there? Okay.
Rasika, are you there?
Yes,
Hello?
she has uploaded your slides. Kindly put your slides on slideshow. Yes. You are not audible.
Hello, sir. Am I audible?
Yes, now you are audible as well as visible. You can start with your presentation.
Good morning, sir. The topic for my paper presentation is role of endovascular techniques in the management of visceral artery pseudoaneurysms. Now, visceral artery pseudoaneurysms, they are very infrequently observed, but nowadays they are frequently being diagnosed because of the imaging modalities which are being used routinely, like CT and CT angiography. Now, the aims and objectives of my study, they were to assess the sites of various visceral artery pseudoaneurysms and to evaluate their incidences at various sites. And secondly, it was to study the role of interventional radiology, specific coil embolization in the management of abdominal artery pseudoaneurysms. The methods and materials used. Now, the study was conducted on 15 patients in the Department of Radiology at GMCH Nagpur for a duration of 15 months. The machines used were 256 slice CT Philips machine and Philips bioplanar DSA machine. The patients were, the inclusion criteria used was any of the patients diagnosed with visceral artery aneurysms on CT imaging were taken for angiography. And the patients were followed up post-operatively with follow-up CT scans after 2 to 4 weeks. Now, this was the observations which was done. This was our first aim, which was to study the various sites and incidences of visceral artery aneurysms at various sites. Now, the most common site of aneurysm found, it was splenic artery pseudoaneurysm, which was, as we can see here, it was 60%. Then the next common was gastroduodenal artery aneurysm. The least common was found to be, in our study, the least common was found to be superior mesenteric artery aneurysm. And others included left gastric artery, common celiac and hepatic arteries. Also, we found out that the most common occurrence of pseudoaneurysms was seen in the age group of 20 to 40 years. And after treatment, that is endovascular treatment of visceral artery aneurysm, it was successful in approximately 14% of patients, in approximately 14, that is 94% of patients were included. All the procedures were performed under conscious sedation, for which femoral artery was used as a preferential access. The coil embolization was used as a management for aneurysm, exclusion in 93% of the patients. Complete exclusion of flow within the aneurysm sac occurred in 87% interventions with the follow-up imaging, but because of the coil and glue artifact in follow-up imaging, it complicated the CT evaluation in follow-ups. Now here I have some cases. First was a case of 30-year-old male, which was a known case of chronic pancreatitis and came for recurrent hematemesis. His CT abdomen, it was suggestive of a partially thrombosed pseudoaneurysm of splenic artery. Now on DSA, we had selective cannulation of the splenic artery was done and angiogram was taken, and after which the coiling was done using the embolization coils. Here we can see in the first 2 images were pre-embolization, pre-coiling, and in the third image we can see the successful exclusion of the aneurysm sac. Then this was a case of 31-year-old known case of chronic pancreatitis with pancreatic pseudocystin complaining of hematemesis. On CT, he was found to have a gastroduodenal artery pseudoaneurysm, which was taken for and super selective cannulation of GDA was done. The angiograms were taken and coil embolization was done successfully. It was here in this case, it was done using a sandwich technique from distal to proximal portion of the GDA. Now this is another example showing a 16 years old male on USG. He was a known case of road traffic accident, and on USG he was found to have a hepatic artery pseudoaneurysm, which was subsequently seen on CT imaging, and as taken for embolization, the imaging shows pre-embolization angiogram and the post-embolization hepatic angiogram, which shows a complete occlusion of the aneurysmal sac in the left hepatic artery. Another case, which was a case of splenic superior mesenteric artery aneurysm. Now this was a case of 50-year-old male who came in the emergency department with blood in stool since 15 days. And on CT, we were able to see on the arterial face, there was active contrast extravasation in the jejunal loops from the branches of the superior mesenteric artery. Then on DSA, the multiple bleeders were identified along with the pseudoaneurysm, and coiling was done. To conclude my study, we evaluated all the important sites of the pseudoaneurysms, abdominal artery pseudoaneurysms, and the visceral artery aneurysms can be successfully treated with the endovascular technique with low perioperative morbidity, and the aneurysmal exclusion can be achieved in the aneurysms with coil embolization in most of the cases. Though abdominal aneurysms are rare, true aneurysms are often incidentally discovered, but pseudoaneurysms are more frequently encountered. The most common non-traumatic abdominal visceral aneurysm being the splenic artery aneurysm. Now, the endovascular intervention or open surgical repair, it is necessary for the treatment of all the pseudoaneurysms, basically more than 2 centimeters or more in size. And the most frequently used materials we use are the coils, which come in a wide range of sizes and shapes. And these are some of the references for the study. Thank you, sir.
Thank you, Rasika. Over to the judges.
My question is, how you can discuss after your conclusion? The first slide should be of discussion, then last slide should be of conclusion. Whatever you are concluding, that was after your discussion. It is not that you are concluded first and then you are discussed.
Okay, sir.
Okay.
Yeah, sir.
And you said, just go back to previous slide. With low perioperative morbidity, what low perioperative morbidities you are expecting? Or what perioperative morbidities you are expecting after your radiological intervention procedure? In whole of the presentation, you have not mentioned those things, and you have concluded those things.
Like the patient compliance was better because of the as compared to open surgery, the coiling, it is a less invasive procedure.
No, but in your study, have you compared those things with open surgery, or it was just a previous references or previous data, and then you compared that data with your study? What you have done?
Okay, yes, so perioperative morbidity is not compared as such.
What you have written in your conclusion, na? So in case series, whenever you are discussing or whenever you are writing a conclusion, you should write about whatever you have done and whatever you got. Okay.
Okay, sir.
Or otherwise, you should specifically mention that in previous literature it was there, and I compared my results with the previous literature, previous available literature. Okay.
Okay, sir.
Okay.
Questions from the other judge?
No, sir. No, sir.
So we'll have our next speaker, Dr. Srijit Saha. Rasika, kindly
Hello.
stop your screen share. Srijit, so kindly upload your slides.
Hello.
Yes, you are audible. Kindly upload your slides. Start
Yes,
the slideshow.
Is my slides visible, sir?
Yes. Start the slideshow from beginning. Now you are audible and visible. You can start your.
Good morning, sir. Good morning, ma'am. Today. Hello. Hello. Okay. Today, my topic of presentation is on the most trending topic that is in the current scenario. My topic of presentation is the role of computed tomography scan in evaluation of neurological manifestations in COVID-19 positive patients and its correlation with the D-dimer value and the Glasgow Coma scale. I am Dr. Srijit Shah, junior resident from Department of Radiodiagnosis, GMC Nagpur. Now, as we know that the COVID-19 has taken up the scenario of a global pandemic, and many studies have been done regarding the spectrum of the chest imaging features of COVID-19. But however, till date, only a few case reports have been described regarding the COVID-19 associated neuroimaging findings. And also we know that D-dimer values, D-dimer levels are associated with patients having ischemic strokes. But unfortunately, there is only a little research on the association between the plasma D-dimer value and acute ischemic stroke in COVID-19 positive patients. And we know that COVID-19 is a prothrombotic state. Our study aims to investigate the incidence and spectrum of neurological findings in hospitalized COVID-19 patients, and they are correlated with the D-dimer values and the Glasgow Coma scale. There were certain inclusion criteria. The patients were positive for COVID-19 by the RT-PCR testing, and swabs were taken from the nasopharyngeal or the oropharyngeal secretions. The patients had some acute neurological symptoms during their hospital stay, likely like the altered sensorium, the loss of consciousness, or any other neurodeficit. And the patients underwent CT scans during their hospital stay. As our study was, as the patients were sampled in convenient sampling, there was no such exclusion criteria. We did a retrospective observational study for a period of around 7 months from April to October in our own institute, Government Medical College, Nagpur. 774 patients who were RT-PCR positives were assessed for the neurological symptoms, and only 116 met the eligibility criteria. They were subjected to non-contrast CT scan and were analyzed. The plasma D-dimer values of these patients were recorded during their admission, and the GCS scoring was also done for these patients. The GCS was divided into 3 categories: mild head insult, which was 13 to 15. GCS 9 to 12 was categorized as a moderate head insult, and below 9 was severe head insult. So here is our observations. Most of the patients, 60%, were male. Around 83% of the patients were more than 50 years of age. And we also recorded the comorbidities of these patients, hypertension being the most common comorbidities. It was around 55 patients, followed by diabetes, coronary artery disease, malignancy. In some patients, there was HIV or other hemoglobinopathies. Now, the clinical features, the neurological symptoms varied from altered mental status to neurodeficit, most common being the altered sensorium, followed by neurodeficit, loss of consciousness, and in some cases, seizure, ataxia, or hypoxia. So when we did the CT scan, certain findings were revealed. The most common finding was normal. That is 50% patients had negative CT scan finding. The most common positive finding being the acute infarcts. It was 17.2%, followed by chronic lacunar infarcts, subacute infarcts, and in some cases, there was intraparenchymal hemorrhage or subarachnoid hemorrhage. Now, when we compared the GCS score with these patients, in the normal patients, most of them has GCS scores between 13 to 15. They were within mild head insult. But in cases of acute stroke, subacute, in cases of intraparenchymal hemorrhage, their GCS were less than 13, that is moderate or severe head insult. In cases of chronic lacunar infarct, most of the patients had mild insult, and it was a chronic case, and most likely it was not due to sequelae of the COVID. Now, the mean plasma D-dimer values of these neurological finding, patients with neurological findings were done. It was seen that it was highly raised in cases of infarcts and hemorrhages, while the patients who had negative CT findings had normal D-dimer values. The normal D-dimer value being 0.5 mg per liter. Here are some of the pictorial representations. The image in the left showing subacute infarct in the right MCA territory. The image in the right showing the acute infarct in whole of the right cerebellar hemisphere. This image showing a mixed density intraparenchymal hemorrhage in the thalamocapsular region with mild in left side with mild surrounding edema. This image showing diffuse subarachnoid hemorrhage with intraventricular extension. So if we see the results at a glance, 12.5% of the patients were suffering from neurological symptoms, out of which the most common was acute infarct. Other findings were subacute infarcts, chronic lacunar infarcts, intraparenchymal hemorrhage. And it was seen that plasma D-dimer value was significantly higher in patients with acute infarct as compared to patients who had negative CT findings. Also, the patients with positive neurological findings were presented with the lower GCS than patients who had negative neurological findings. So coming to the discussion, we demonstrated that the neurological features of a hospitalized patient with COVID-19 were variable without specific pattern but dominated by the acute infarcts. The cause of neurological symptoms may be critical illness or from direct CNS invasion of the COVID virus, or there may be also a cytokine storm that is related to the prothrombotic effect of the inflammatory response that is causing the trigger for the ischemic strokes. We also saw that as compared to the Wuhan cases, there was lower prevalence of the CNS symptoms, but the higher prevalence of acute ischemic infarct. The GCS was a good predictor of neurological outcome. Patients with positive neurological finding having a poorer GCS, and also D-dimer value was raised in the patients with positive neurological findings. Certain theories have been postulated, like it was raised D-dimer was reflecting the ongoing thrombus formation and may be a marker of systemic hypercoagulability. Some postulated that the D-dimers stimulates monocyte synthesis and release in pro-inflammatory markers like interleukin-6 that may be contributing to the stroke severity. And also some postulated that D-dimer may be one of the acute phase reactants. That is, it less likely, but D-dimer may be an effect of the COVID virus. Raised D-dimer may be an effect of the neurological symptoms rather than the cause of the neurological symptoms. So coming to the conclusion, the neurologists and radiologists should be familiar with the broad spectrum of neurological findings in COVID-19 patients. Proper intervention and prevention of further neurological complications is possible if CT scan is performed in proper time, and a raised D-dimer value may give us a hint of the ongoing or the impending neurological insult which, before its clinical or radiological manifestations. Lastly, I want to thank all the residents of the Department of Radiodiagnosis for helping me carry out this study. Here are some of my references. Thank you.
Srijit, over to the judges.
Hello.
Hello.
In your first slide, you said that there is no as such, till date, there is no as such study that correlates neurological symptoms, okay, with association with raised D-dimer. But if D-dimer is raised, we know it is because of clot.
Yes, sir.
And more of the things you said, in patient with raised D-dimer, there was a ischemic changes in brain.
Yes, sir.
But that is an established fact.
Sir, actually we know that D-dimer is raised with acute in patients with infarcts. So we wanted to see also in this case was there, but we incidentally found that it was not only raised in cases of infarcts, but also in some normal patients, D-dimer was raised, and also in some patients with other neurological findings like like the SH, the D-dimer was raised. It was not only in cases of acute infarct.
Okay. Now I got it. That there is increased D-dimer. There is not always association with infarct. It might be due to other cases also.
Yes, sir. The D-dimer
may suffering from COVID-19.
Yes, sir. The D-dimer may not be directly related to the effect like hemorrhages. There may be some other comorbidities, but it was an incidental finding.
Okay, but you are not correlated the other comorbidities like hypertension and diabetes you mentioned, but you have not correlated the finding the patient having comorbidity with raised D-dimer with changes in brain. Have you?
No, sir. I did not correlated that. I just did a study that how many of these patients had the comorbidities, but did not.
To conclusion that a patient with comorbidity will have higher chances of neurological deficit
Yes,
with increased D-dimer.
Yes, sir.
Okay, that was a good study, but I think you should correlate this comorbid condition like diabetes and hypertension with that thing. So the outcome will be more better.
Okay, sir.
Other judge?
No, sir, no.
So we'll go to our next speaker, Dr. Harshal Holkar. Can you stop sharing, Shrijit? Dr. Harshal Holkar, kindly upload your slides.
Yes, sir. Am I visible?
Yes, you are visible and audible. Start from your slides show. Put it on slideshow. Yes, now you can start the presentation.
Good afternoon, everyone. Myself, Dr. Harshal Holkar, from the Department of Radiodiagnosis. I am the junior resident 2. Today, I will be presenting the role of magnetic resonance imaging in evaluation of orbital pathologies under the guidance of Dr. Aarti Anand ma'am, Dr. Amit Disawal sir, and Dr. Prajwalit Gaur sir. Introduction. The orbital lesions forms the wide range of pathologies that create the challenge in diagnosing and management of the treatment. The high resolution of the soft tissue details provided by the MRI has allowed us for the better resolution of the lesions, especially in cases where the history and clinical evaluations are insufficient, where the MRI plays a crucial role. MRI is also important in detecting the extent of orbital pathologies. The aim of our study is to examine the MRI characteristic of common and the rare diseases arising from or extending into the orbit, and also aids the radiologist to correct the diagnosis of orbital lesions. The aims and objectives of this study is to evaluate the role of MRI in diagnosing the various orbital pathologies, to determine its frequency of the various diseases, and to determine and characterize the lesions. This study is conducted in the Department of Radiodiagnosis. We studied the 100 patients for the duration of 1 year by using the 1.5 Tesla Philips MR Jiva machine. The inclusion criteria of our study is to examine the patient with the signs and symptoms of the orbital pathologies, which are most of these patients are referred from the ophthalmology department. The patient with the abnormal CT scan or the abnormal B scan findings. The protocol of our study is pre and post contrast imaging taken in the axial, sagittal, and coronal plane in T1, T2, fat sat and non-fat sat imaging. We took the follow-up of this patient by the post of histopathological finding in the surgical cases, and by the clinical examination and post-op, and by the follow-up MRI and the CT scan in the non-surgical cases. These are our observations. We have found that the mean age of incidence of the orbital pathologies is in between the 20 to 30 years of age, which contributed to the 24% of cases. The most of this 58% patients were the male, and the 42% patients were the females. The most common presenting symptoms were the proptosis, followed by the pain and watering, and then followed by the diminution of vision. In our study, we have found that the infective and inflammatory etiology causes contributing most of the cases, contributing 35% of cases, followed by the neoplastic and etiologies of 31% patient, then followed by the other like congenital and vascular causes. 51% of we have found that the 51% pathologies located in the extraconal compartment, and 31% pathologies were found in intraconal compartment, and the 19% pathologies included in contributed in both intraconal and extraconal compartment. 74% cases had primary orbital pathologies, and the 26% cases had the secondary orbital pathologies. These are some of the representative cases I will be discussing. 19-year-old female complained with the painful movement of the left eyeball with the diplopia since 15 days. This is the T2 weighted, T1 weighted axial and core post-contrast imaging showing the there is enlargement of the left medial rectus muscle, which also includes its tendinous insertion, which shows the altered signal intensity and shows the post-contrast, vivid post-contrast enhancement. This is the case of orbital pseudotumor. Hello.
Yes, yes, you're audible and visible. Continue.
Orbital myocytic pseudotumor is an inflammatory condition, inflammatory non-neoplastic condition, which includes the inflammatory cell and myocytic myofibroblast spindle cell. Is usually a unilateral condition, and the presence of bilateral masses suggests that underlying systemic disease. On MR imaging, there are usually isointense to hypointense lesions related to the muscle on T1 imaging, and hypointense lesion on T2 weighted imaging. The main characteristic finding of the orbital pseudomyocytic tumor is the involvement of muscle belly as well as the tendon insertion. This is the differentiating point between the orbital myocytic pseudotumor from the Graves ophthalmopathy, because because inflammatory pseudotumor mimic the malignant tumor both clinically and radiologically. The radiologist must be familiar with the entity and avoid the unnecessary radical surgery. Now the second case is 68-year-old female, a known case of hyperthyroidism with left-sided evisceration is already done. This is the T2 and T2 weighted axial and coronal imaging showing the bilateral rectus muscle appears bulky and enlarged with the spindle shaped, with altered signal intensity and relatively normal normal tendinous insertion. There is an increase in intraorbital fat with also leading to the proptosis. The oblique muscles are spared. Now this is the case of Graves ophthalmology. This is the most common cause of exophthalmos in adults. In Graves ophthalmology, the characteristic finding is that the muscle belly is involved with the sparing of the tendinous insertion. This is the most commonly involved muscle is the inferior rectus, followed by the medial rectus, and the oblique muscles are least involved. Now the third case is the 48-year-old male presented with the painless progressive proptosis of the left eye since 3 months. This is the ultrasound B scan finding showing the anechoic vascular cystic lesion in the left orbit. This is the this is the T1, T2, and the flare imaging shows the hypointense lesion on T1 and flare sequences, and the hyperintensity on the T2 sequences involving the retroorbital intraconal compartment of the left orbit. This is the T1 fat set, and this is the T2 post-contrast imaging, and this is the spectroscopy imaging showing the pyruvate peak at 2.4 ppm and the lactate peak at the 1.3 ppm retrospectively. This was the case of intraorbital highlighted disease. Intraorbital highlighted is a rare manifestation. Though the in-depth data is not available on the general characteristic of the specific finding of the intraorbital hydrated, but the MR imaging along with the spectroscopy is highly suggestive of the nature of the cyst and its relationship surrounding the structure. The significant pyruvate peak at 2.4 parts per million and elevated lactate peak signifies that that it is the in vivo marker of the hydrated disease. Now another case is a 4-year-old male presented with the white reflex in the right eye since 2 to 3 months. This is the non-contrast bone window, and this is the contrast soft tissue window showing the heterogeneous enhancing lesion with the coarse foci of calcification. The patient were followed by the MRI imaging. This is T1 and T2 weighted image shows the altered signal intensity involving the right eye globe, which shows the hyperintense on T1 and hypointense on T2. And the lesion also shows vivid post-contrast enhancement. So this was the case of retinoblastoma with the optic nerve invasion. The retinoblastoma is the most common malignant intraocular tumor in the childhood, in the age group below the 5 years of age. The most common characteristic finding of the retinoblastoma is the presence of calcification, and it is hyperintense on T1 wetted imaging, hypointense on the T2 wetted imaging. The another case was the 55-year-old female male presented with a blurring of the vision since 8 to 9 months. This is the MR T1 and T2 wetted images shows the well-defined intraocular lesion in the right eye globe with hyperintense T1 and hypointense T2 lesion, and which shows the post-contrast enhancement. So this was the case of choroidal melanoma. The summary and discussion. The maximum number of patients were fell under the age group of 20 to 30 years of age, with the 24% of the 25% of the incidence. The incidence of orbital disorders steadily increases from the third to the fifth decade, which is the similar trend found in the previous study, followed by DeLong. The 58% patients were the male and 42% patients were the female included in our study. And then in the present study, the most common orbital lesions is the inflammatory infective, followed by the neoplastic. Our results were similar to the previous study conducted by the Arvind. In the present study, 51% lesions were located in extraconal compartment, and 30% lesions were present in the intraconal compartment, and 19% of the lesions were included both intra and extraconal compartment. These results were similar to the previous study conducted. Another conclusion of our study is that the MRI should be the imaging modality of choice in suspected orbital lesions, because the MRI provides the better soft tissue resolution and localization and characterization of the lesion. It has a lack of ionizing radiation. MRI is the better imaging modality to detect the optic nerve disease, is CNS extension, cavernous sinus extension. It has a better temporal resolution, but the disadvantage of the study is that it is inferior in detection of the in the trauma cases, as we cannot as it has a poor bone resolution. These are some references. Thank you.
Sure, over to the judges.
Hello.
Yes, sir.
Okay, first I would like to congratulate you for diagnosis of such rare cases by using MRI. Just go to your slide of aims and objectives. Now the second point is to determine the relative frequency of various diseases affecting orbit.
Yes,
in your study, what things you have done to reach to the conclusion of this aim?
Sir, we are just stating that the MRI is the better has a better role in detecting and characterizing the orbital lesions as compared to other modalities.
No. The frequency of various diseases. Okay, so various diseases, have you differentiated those in category of infective, then
Yes, sir.
neoplastic? Then you should mention those in your aims and objectives.
Yes, sir.
Intraconal, extraconal, intraorbital, extraorbital. You're not specific with those things, na? The frequency of diseases, which, whatever the classification or whatever the things that you have in your mind, you should write down in your aims and objective only.
Okay, sir.
Okay, and you said it is better modality over other techniques. So have you compared
yes.
those techniques with this MRI technique?
Like, sir, CT.
No, but have you compared?
No, no, sir. I did not compare here.
But you are like reaching to your conclusion by references of previous studies. So have you mentioned those studies in your discussion?
No,
तो
sir.
CT के लिए जो studies लिए थे आपने discussion में mention नहीं किया है.
No, sir.
Taking references from such studies, you should mention those in your discussion only. Okay, or review of literature, you can say.
Okay, sir.
Otherwise, it was a good presentation.
Okay, sir. Thank you, sir.
Questions from other judge? It seems there are no more questions. Varsha, if you can please leave the share screen. Dr. Arpit, kindly upload your slide. Harsha, please stop the share screen from your end. Stop the share screen. Dr. Arpit, तेरे खाते आर्मी लोड
Good afternoon, sir. This is Dr. Arpit Dakhatia. Am I audible?
Yes, sir. Yes, you are audible and visible. You can
Okay,
start.
sir. Okay, sir. So I'm Dr. Arpit Dakhate, junior resident, second year in GMC Nagpur, radiology department. And my topic of presentation is a role of chest radiography for evaluation and severity scoring in non-COVID-19 pneumonia. So we all know that at the end of 2019, this novel COVID virus, that is SARS-CoV-2, expanded globally from China, and the first case in Nagpur was found in January 2020. And the radiology being one of the important investigations in the COVID-19 pneumonia. So the radiology is indispensable. We all know that the gold standard for COVID-19 pneumonia is the HRCT, but we should not ignore the role of chest X-ray. So the most Indian centers are employing chest radiograph as the first line method, as HRCT is not available everywhere, and the chest X-ray is readily available, inexpensive, and it has low radiation dose and the less chances of cross infection, as well as we know that the COVID patients are most of the severe COVID patients are bedridden. So this is the chest radiography can be used bedside also. The aim and objectives for my study were the analysis of radiographic features of COVID-19 pneumonia upon initial presentation to the emergency department, and exploring the prognostic utility of chest radiograph by means of semi-quantitative severity scoring system, such as modified REL scoring for patients with COVID-19 pneumonia. We have included RT-PCR positive patients in our study, and we those who were RT-PCR negative for COVID-19, we have excluded those patients from our study. The material, our study was the retrospective observational study. We have conducted this study from May 30, 2020 to August 30, 2020 in Government Medical College, Nagpur. We have included 1,000 RT-PCR positive patients who were subjected to chest radiographic evaluation. And on radiographic evaluation, we have found that the chest radiograph showed multiple radio opacities. We have seen multiple radio opacities. And we focused on the specific distribution of the disease, such as whether it is peripheral or it is central. We have focused on the laterality of the disease, such as whether it is unilateral or bilateral, and some other associated pulmonary pathologies like pleural effusions and pneumothorax. So radiographic scoring, modified radiographic scoring score was 0 to 4. 0 to 4 score was assigned to each and every lung. So the total score was from 0 to 8. 0 means the no involvement. 1 means up to 25% involvement. Means 25% to 50%. 3 means 50 to 75%, and 4 means 75 to 100% involvement of the lung. Now, this is the chest radiograph. What we can see in the chest radiograph is the involvement of the bilateral lung fields, and there is involvement of 25 to 50% involvement of the mid and lower zone of the right as well as the left lung, which is peripheral in location. So the ultimate modified score, REL score, was found to be 4 in this case. Now let us come to the observation and results of our study. We have found that the 61% of our RT-PCR positive patients were males and 39% were females. 34% were in the age distribution of the 37% in the age distribution of the 41 to 60 years, and 34% were in the 21 to 40%. The 58% patients were symptomatic and 42% RT-PCR positive patients were asymptomatic. Now, out of 1,000 patients, 423, that is 42% were asymptomatic, and out of symptomatic patients, fever was the most common symptom in the symptomatic patients, and cough and dyspnea were followed by cough and dyspnea. And the comorbidities with RT-PCR positive patients were the hypertension and diabetes mellitus, hypertension being the most common, and other like chronic renal disease, COPD, and CLD. Now, out of asymptomatic patients, 289 patients were had some change. They did not had any changes on chest X-ray, and 134 patients had, that is 31% had some X-ray changes. Out of symptomatic patients, 75% patients had had no changes in the had chest X-ray positive, and 24% patients were X-ray negative. And on X-ray, the alveolar opacity was the most common finding, followed by the consolidation and mix, that is alveolar opacity, consolidation, and the diffuse digios, and other findings like pleural effusion, nodules, pneumothorax, emphysema were found. This is one of the case of SARS-CoV-2 pneumonia. What we can see in the first image that is the bilateral alveolar opacities in the mid and lower lung zone and right upper zone, which is peripherally, predominantly peripheral. And what we can see in the image B is the consolidatory patchy area in the right middle zone and left lower zone. This is another case of SARS-CoV-2 pneumonia. What we can see in the image is the image C is patchy consolidation in the bilateral lower and mid zones, and in the image D is the diffuse radiopacities in bilateral lymph fields with dextrocardia. The frequency of lung involvement in COVID-2 pneumonia is bilateral, predominantly bilateral, and which is seen in the 77% of cases, and predominantly unilateral in the 23% of cases, and left lung being the most commonly involved, more than the right lung. Now, the zones affected in the what we found is there are two zones which are most commonly involved in the COVID-2 pneumonia, and followed by the four zones, and followed by the one zone. This is the
Summarize,
distribution.
Arpit.
This is the distribution of opacities. We found that the peripheral distribution is most common, followed by the perihilar, and both. This is the REL scoring. We have found that in symptomatic, asymptomatic patients, the score was found to be in between the 0 to 2, while in the symptomatic patients, the score most commonly found in between the 3 to 4. And there are very less patients in which we have found that the score between 5 to 8. Now, discussion. The chest. We all know that the chest radiography is widely utilized as a screening tool for detecting COVID-19 infection. However, its prognostic utility has not been validated in patients with COVID-19, and the profitability of the REL scoring to aid in clinical management has been demonstrated by other several studies conducted like OZD and Fabio, Cesare, and Terence. It is thus recommended to expand the use of radiographs beyond its present applications, especially in resource-limited regions. That the value is diminished by risk of radiation exposure to the patient, risk of COVID-19 transmission to uninfected healthcare workers and other patients, the consumption of PPEs, and need for cleaning and downtime of radiology rooms in resource-constrained environments. CT must be reserved for additional specific situations, since CT is the gold standard, but it should be reserved for additional specific situations, like in case of clinico-radiologic discordance, clinical deterioration, and acute complications such as severe acute respiratory failure and pulmonary embolism, like CTPM. And CT has high sensitivity, that is around 97 to 98%, but it has a very low specificity in detecting typical feature of SARS-CoV-2 pneumonia. My conclusion is that the chest radiography in association with REL scoring can be utilized as a screening tool for detecting COVID-19 infection. And also the portable X-ray machine are very useful and very handy, and the bedridden patients can be also, so radiographs can be taken at the patient's bedside, minimizing the risk of cross-infection. The limitation of this study was, being the retrospective, we did not had the non-COVID-19 control group, limiting the evaluation of sensitivity and specificity of chest radiography. The intervals between the serial chest radiographs and RT-PCR testing were dictated by clinical need, and hence were not uniform. A radiologist experience in evaluation of radiographs over HRCT holds an important count and could be subject to bias. Follow-up evaluation was not done, truncating the correlation with the disease course. Further research can be directed in this field to effectively overcome the above drawbacks, and more robust guidelines can be formulated for radiograph-based scoring. These are some of my references. Thank you.
Arpit, go to the judges.
Yep. It was a nice presentation.
Thank you, sir.
Okay. My first question is, when do we have a limited resources? Or rather, you have assessed 100 radiographs, or you assessed 100 patients. What you have done?
1,000 cases, sir.
Oh, 1,000 radiographs only with positive
Yes.
RT-PCR.
Yes, yes.
So you mean to say in every patient with positive RT-PCR, you will get radiological changes? Is that so?
No, sir. I have included in my study now.
You are included in your study that 1,000 patients with RT-PCR positive,
yes,
with some radiological finding.
Yes,
those
yes.
only. Na?
So
Okay.
Sir, out of those 1,000 RT-PCR positive patients, almost, sir, 75% were symptomatic, and 68% were asymptomatic. So in case of
my question is,
yes,
those 1,000 patients with RT-PCR positive test were all having changes in X-ray.
No, sir, no.
So in your data analysis,
around symptomatic patients, there was 75% of symptomatic patients, and 68% of asymptomatic patients had the chest X-ray findings.
दो चीजें अलग है बॉस. सुनो, पहले क्या है, 1,000 पेशेंट लिए और हर एक पेशेंट को रेडियोलॉजिकल चेंज था नहीं, या फिर तुमने वैसे ही पेशेंट लिए जहां 1,000 पेशेंट को रेडियोलॉजिकल चेंज था और फिर देन यू असेस क्लिनिकली दैट दो पेशेंट इज हैविंग रेडियोलॉजिकल चेंज बट द पेशेंट इज असिम्प्टोमेटिक. दीज आर टू डिफरेंट थिंग्स.
Yes, right.
है ना? So how many percentage of the patient suffering from COVID-19 do have a radiological change? हर एक पेशेंट को तो नहीं होगा.
55%, सर.
नहीं, have you done those things? मतलब नॉर्मल एक्सरे भी रहता है ना पेशेंट का, जरूरी थोड़ी है हर पेशेंट में चेंज ना.
राइट सर.
हाँ, तो नॉर्मल एक्सरे के बारे में आपने एनालाइज किया डेटा कि 1,000 पेशेंट का मैंने एक्सरे देखा है, तो उसमें मुझे यू गॉट दैट 65% ऑफ द पेशेंट डू हैव सम रेडियोलॉजिकल चेंजेस.
यस.
एंड 35 पेशेंट वेयर रेडियोग्राफिकल कोई सिम्टम्स नहीं थे उनमें. अग्रीड?
राइट सर.
हाँ, तो जो 65% पेशेंट का एनालिसिस किया है तुमने, जो बाद में ओपेसिटीज है, कंसोलिडेशन है, प्लूरल इफ्यूजन है.
यस सर, यस सर.
वो रिमेनिंग 65, तो डेटा एनालिसिस तुमने सिर्फ 650 पेशेंट का किया है या 650 रेडियोग्राफ्स का किया है, नॉट 1,000 रेडियोग्राफ्स.
यस सर.
और मुझे क्या लगता है कि व्हेन यू आर इन अ टीचिंग इंस्टीट्यूट, अकॉर्डिंग टू और रादर मेरी जितने, आई एम नॉट अ रेडियोलॉजिस्ट, बट मुझे इतना लगता है कि हर एक पेशेंट का सीटी होता ही है.
यस सर, ऑलमोस्ट ऑल
ना. तो जिस पेशेंट का रेडियोग्राफ हुआ है और जिस पेशेंट का सीटी हुआ है, it will be better if you reach to a conclusion that CT should be limited to few situations only. Okay, so right. Whatever we are like diagnosing, it will be on radiograph only, no need of CT. ये कब करोगे आप? जब CT और रेडियो को कंपेयर कर पाओगे.
राइट.
हाँ, और फिर बोलोगे कि CT से बहुत ज्यादा मुझे एडिशनल इन्फॉर्मेशन नहीं मिल रही है, so that's why I kept that CT for a limited cases only.
राइट सर.
है ना, मतलब अकॉर्डिंग टू मी दैट्स व्हाट आई थिंक।
ओके।
और जहाँ अपन जिस मतलब अपनी जो हेल्थ केयर सिस्टम है उसमें यार सिटी स्कैन हर जगह रहता नहीं है, तो ये
हाँ
स्टडी
सर।
बहुत ज्यादा काम में आएगी अगर तुम मतलब एक्सरे को ही प्राइमरी डायग्नोस्टिक टूल दोगे इन केस ऑफ कोविड-19 की
हाँ सर।
कोविड-19 सिचुएशन। ओके
यस सर। यस
ओके थैंक यू।
सर।
Question from you, sir. Question from the other judge.
Hello, sir. Am I audible?
Yes, yes, you are audible.
Sir, I would like to actually I differ on this slightly because there is no comparison of CT and X-ray chest, especially in a COVID positive patients. Because we have seen in many patients, the ground glass opacities are absolutely not seen on X-ray. However, they are visible on the HRCT, and that is why the HRCT is rampant in that nowadays. So the X-rays can be applied where there is no facility of CT scan, where X-ray can be done, and where the patient is not maintaining saturation. In such patients, the X-ray can be done. Otherwise, HRCT will only give you a clear-cut diagnosis because all the ground glass opacities, they are not just visible on the X-ray. This is my observation.
Agreed, sir. Agreed. Hello, Jawad sir.
Yes, sir. Yes.
Agreed, sir. First,
yes.
What I want to say is, I am fully agreed with you. HRCT is gold standard, sir. But in cases where HRCT is not available, we can compare whatever data we are having at GMC, HRCT, and X-ray. And if we can reach एक ही patient का X-ray क्या, एक ही patient का HRCT क्या, और अपन अगर if we can reach to a conclusion that X-ray is as good as HRCT, that's for our setup जहाँ पे हम लोग काम कर रहे हैं इंडिया में.
Yes, sir. Yes, sir. Yes.
Obviously, I fully agree with you. HRCT is gold standard.
Yes.
Okay, thank you.
I just shared my observations because we are observing so in X-ray and CT from so many days,
No,
especially
sir, you
in
are
COVID
expert in that.
positive.
बिल्कुल agree.
Yes.
You are expert. Okay.
Yes.
So in a situation where HRCT is available, you should use our facility. Now coming to our to the next speaker, presenter, Dr. Mansi Dalvi.
Yes, sir.
Mansi, can you put your slides in slideshow?
Yes, sir. Is it visible, sir?
Yes, it is visible.
Am I audible?
Yes, yes, you can start with the presentation.
Good afternoon, everyone. The topic for my today's paper is gasless laparoscopic appendicectomy revisited in the COVID-19 pandemic, our experience. This paper was guided by Dr. Wilkinson, sir. I'm a surgical resident too in NKP Institute of Medical Sciences and Research Center. Introduction. Appendicitis is one of the most common causes of acute abdomen. Open appendicectomy has been the treatment modality since its inception. Laparoscopic surgery was introduced by SEM in 1893 and was soon adopted as the surgical procedure of choice in mainstream surgery as it was proven to be superior to open surgery on multiple counts due to its minimally invasive nature and thus causing lesser postoperative pain and better cosmesis. While laparoscopic surgery gained popularity in the coming years, especially in abdominal surgery, soon the cons of the procedure also came to light. Multiple studies showed the effects of CO2 pneumoperitoneum employed in laparoscopic surgery due to increased intra-abdominal pressure in the pneumoperitoneum and high absorbability of carbon dioxide in the bloodstream, causing unwarranted changes in terms of hypercapnia, acid-base disturbances, gas embolism, etc. Gasless laparoscopic surgery was introduced in 1911 by Eruheim as a novel way to overcome the unwarranted effects of CO2 pneumoperitoneum. It employed the principle of mechanically lifting the anterior abdominal wall instead of CO2 in order to gain visibility in the abdominal cavity. While this procedure did not gain much popularity at the time, probably due to the use of bulky and improper abdominal lift instruments, leading to greater postoperative pain and discomfort. With the availability of better lifting devices now, the safety and feasibility of this procedure, especially in the current scenario of COVID-19, could be tested since laparoscopic procedures are being questioned for causing spread of the virus by aerosolization during the release of CO2 in pneumoperitoneum. Thus, the aim of the study was to test the feasibility and efficacy of the gasless laparoscopic procedures in patients with appendicitis, especially in the times of the COVID-19 pandemic. Materials and methods. We ordered a specialized device for the same. It consisted of a vertical metal crankshaft, which is attached to the operation table. And then below a horizontal rod was attached to the vertical crankshaft. At the end, there was this metal ring which went in the abdomen of the patient to mechanically lift the wall, the abdominal wall. The principle was for the metal ring to be placed intra-abdominally in order to lift the wall uniformly, unlike other lift devices, which consisted of hooking the skin, which caused a tent-like lift and caused trauma to the skin and lesser visibility of the surroundings. This is what the setup looked like. The metal ring is placed intra-abdominally and connected to the horizontal bar on the instrument, and it is cranked up and the abdominal wall is lifted along with it. And the laparoscopic instruments are placed into the abdominal cavity via the same incision. Statistical analysis. From April 2020 to August 2020, a total of 10 patients with the clinical and radiological diagnosis of acute appendicitis were subjected to the technique of gasless laparoscopic appendicectomy at a tertiary care center at Nagpur, India. Pediatric age group, obese patients with BMI about 25 were excluded. Patients with clinical and radiological findings of an appendicular lump were also excluded. Data involving patients' demographic, operative time, patients' BMI, conversion rate to conventional laparoscopy or to open appendicectomy, use of analgesia, post-operative pain, and intra and post-operative complications were recorded. Pre-operative and post-operative antibiotics were administered intravenously with second-generation cephalosporins for 72 hours. Results. A total of 10 patients underwent a gasless laparoscopic appendicectomy procedure. The mean age was 26.1 years and 6 patients were female and 4 were male. The average BMI was 22.6. None of the patients had any comorbidities. None of the patients had previous abdominal surgery. The mean operative time was 40 minutes. Out of the 10 patients, 1 had to be converted to an open procedure due to multiple dense adhesions around the appendix. None of the patients had any intra-abdominal complication. 1 out of 10 patients had a surgical site infection on post-operative day 6. Intraoperative fentanyl was needed in 3 patients. Post-operative pain analysis was done on day 1 and 3, and 8 out of 10 patients rated the pain at 2 on the VAS scale on day 1, while 2 patients rated it at 3. On post-operative day 3, 9 patients were pain-free and 1 patient rated the pain at 1 on the VAS scale. As I said, there were no intraoperative complications per se. Post-operative complication, there was surgical site infection on post-operative day 6 in 1 male patient, and 1 procedure had to be converted to open due to dense adhesions around the appendix. Concluding, our data suggests that gasless laparoscopic appendicectomy is a safe and feasible method of laparoscopic surgery with benefits of a lower pain profile and low rate of complications. It appears to be even more beneficial in its current scenario of COVID-19 pandemic due to its exclusion of usage of CO2 pneumoperitoneum, thereby reducing the risk of COVID transmission. It also provided the additional benefit of using continuous suction during blunt dissection since there was no question of a gas leak. Additionally, since it only requires regional anesthesia, it was safer for both the patient and the anesthetist. The shortcomings of the study were a small sample size. Only patients with low BMI were included, that is, obese patients were not included, and the possibility of excessive lift of the abdominal wall could cause pain post-operatively. While we conclude that this procedure is extremely feasible and safe during the COVID-19 pandemic, more randomized controlled trials are necessary to prove its efficacy and benefits over conventional laparoscopic surgery beyond a doubt. Thank you.
Thank you, Mansi. Over to
Hello.
Hello. Dr. Mansi.
Yes, sir.
All these procedures were done under regional anesthesia.
Yes, sir. Spinal anesthesia.
Okay. All these patients were COVID positive, or you just wanted to say that it will only reduce the aerosolization because of CO2?
Yes, sir. None of the patients were COVID positive. It was just a hypothesis that CO2 pneumoperitoneum, if we exclude, it would reduce the transmission rate.
But according to me, it will take more time as compared to your conventional gas CO2 laparoscopic surgeries.
No, sir. In fact, there was lesser time because even setting up the instrument also did not take time, and it went through a single incision. So what we could also, like, one of the other things that we could do was, once we dissected the appendix, so we could pull it out of the incision and then like excise the appendix that way. Like, it did not necessarily have to be a lap, so it was a midway between open and lap as such.
Okay, it was not 100% laparoscopic surgery, but according to me, surgeon will prefer CO2 pneumoperitoneum because they will have more space to manipulate their instrument, according to me.
Sir, actually, we did think of that, but the thing is, there was adequate visibility and space to for an appendicectomy, even with respect to conventional lab, and it was easier to manipulate the incisions also, instruments also, because the edge of the wound was itself, incision was itself used as a fulcrum, and we could manipulate the instruments also easily.
So next time I will ask my surgeon to do this type of retraction of anterior abdominal wall. We will see. I've not seen this procedure, but my second point is why you are worried of aerosolization because of CO2?
Sir, actually, even previously there was by the SAGES guidelines also, there was like laparoscopy procedures were put under question because it was suggested that during CO2 pneumoperitoneum creation, and when we release the pneumoperitoneum, there is aerosolization of the gas, and
So, a gas which is released from abdomen will it have more aerosol than gas which is expired via lung?
no,
COVID-19 patient who is present in operation theater, according to you, if he or she breathing spontaneously or on control ventilation will expire more aerosol as compared to whatever the gas you are taking out from your abdomen.
No, sir.
Don't you think so?
Yeah, of course, the gas released from the abdomen would not have so many virus or wouldn't cause so much of aerosolization.
Obviously, the anesthesia part, that the mechanical ventilated patient or continuous ventilated patient, that will generate more aerosol. So you should not correlate this thing because of low aerosolization. We are using gasless. Okay?
Yes.
I don't think so. Correct me if I am wrong, but I don't think so. It is a proper explanation of your COVID-19 pandemic scenario. The aerosol generated via lung will be more, always more.
Hello.
The aerosols which are generated by spontaneous ventilation or controlled mechanical ventilation will always more as compared to your CO2 peritoneum.
Yes, sir.
Okay.
Yes, sir.
Question from the other judge?
No, sir.
Mansi, can you stop the share screen?
Yes, sir. Yes.
Do we have Dr. Kaustubh with us? He had missed his because of exams. Is he available now? Dr. Kaustubh. If not, then we have completed all the list except him. Devani, have you completed all the presenters?
Yes, sir. Yes, sir.
Except Kaustubh, no? Because he is in the exams. I can't see him on the screen. So, Devani, shall we close the session?
Are we through with
Yes,
the
sir.
paper
I think we are
presentation?
done with the paper presentation.
So we will start with the poster.
Yes, please do, because we are running short of time. We have to start the other sessions also. Please start the poster presentation.
Thank you, judges, for judging our session, and let us know about the results.
Listen, the results shall be declared in the valedictory.
Yes, but they would show us they will give us the scores and
give them
results.
some time to compile. Sumer, please give them some time to compile.
Yes, that is what I'm saying.
We will
That after
compile it and
compiling, they will
give it to you.
Yes, that is what I mean to say.
Okay, sir. Okay, thank you, sir.
Thank you, sir. Thank you.
Thank you, judges. Please start the poster presentation, Sumer.
Do we have the judges for the poster presentation? First session, Dr. Gyan Shankar Mishra. Dr. Yan, are you there?
Devke Madam Mishra, sir, are you there?
Devke Madam is in the...
Yeah.
Yes,
Devke Madam is there.
Yeah, I'm there. We can start. I think we can start because we are really running short of time.
So for our first candidate is Dr. Zanshir Nazir. Nazar, is he there in the presentation?
Zashir Nazar.
Yes, sir.
Yes.
Good afternoon,
Yes, sir.
sir.
Good afternoon. So, you're audible. Put your slide on slideshow.
Yes, sir. So, shall I start?
Yes, yes, you can start your
Yes, sir.
presentation. You have to finish it within 3 minutes. Okay.
Yes, sir. Good afternoon, everyone. My name is Dr. Zansher Nazar. I'm reporting a case of textiloma presenting as a lump in abdomen. What is textiloma? Textiloma or gossypiboma is a mass comprising of cotton matrix within the body left accidentally during surgical procedure. Literature gives us an incidence of around 1 in 5,000 to 18,000 inpatient operations, but even this number is underreported. The most common found foreign bodies are surgical mops or small gauze pieces, but rare cases of hemostatic forceps and pieces of drainage tubes have also been reported. There have been few reports of transmural migration of retained foreign bodies. I am reporting a case of 29-year-old female coming with complaints of colic abdominal pain with lump in abdomen since 1 year. She also had on and off complaint of vomiting episodes since 1 year. She had also history of weight loss and loss of appetite since 1 year. Uh, Patient was admitted. Patient had a past history of admission to an outside tertiary care hospital and was diagnosed at abdominal tuberculosis with obstruction 12 years back and was operated for the same. No documentation of the surgery was available, and patient was also given 18 months of AKT therapy. On per abdomen examination, a vague lump of around 8 into 5 centimeter was palpable in umbilical and hypogastric region. Tenderness and guiding was present. Bowel sounds were present over the lump site. A midline vertical scar was present, indicative of previous surgery. CCT abdomen was suggestive of just bezoar and with likely intussusception. But psychiatric evaluation revealed no evidence of trichotillomania or any eating disorder. As there was no clear diagnosis, we decided to open the abdomen. On exploration of the bowel, signs of old bowel anastomosis were noted and a dilated ileal loop was identified. Longitudinal incision was given proximal to the dilatation. Uh, Contents of the ileal loop were removed, which were identified as two surgical mops. Ileal loop was closed, rest of the bowel was inspected, and the abdomen was closed. Patient tolerated the surgery well, and on 1 month follow-up, she even reported relief of symptoms and increase in appetite and weight gain. On discussion, the surgical swab or gauze are usually left in abdominal or pelvic cavity. But in our case, the mop was found inside the intestinal lumen. Mop can be detected on a plain radiograph due to presence of radiopaque line. But in our case, the radiopaque markers may have been degenerated since it was left 12 years back. So it was not seen. Uh, Prevention of this condition can be achieved by meticulous count of surgical material and thorough exploration of surgical site at the conclusion of the operation. This step should be done by the surgeon and the assistant as well to prevent such cases. Thank you, sir.
Thank you, Zanshir. Question. Over to the judges.
Just one question, Zanshir. The patient was operated 12 years back, right?
Yes, ma'am.
So what are the chances of textiloma being present there and causing symptoms after 11 years?
We are not definitely sure that it was a transmural migration, but there are some strong evidences because she did not had any symptoms for 11 years post the surgery, and the symptoms just started 1 year back. So we are suggesting we were of the opinion that it may be a transmural migration case where the mops were left intra-abdominally and may have migrated into the bowel loops, and the symptom then started presenting 1 year back.
Okay, thank you.
Okay, thank you, ma'am.
Dr. Gyan, any questions? Okay, no questions. You can stop sharing the screen, Zanshir. Next, over to the next presenter, Dr. Rahul Dhole. Kindly upload your slide. Dr. Rahul Dhole. Dr. Rahul Dhole. Devani, is he not there?
Fatima can present, sir, if Rahul Dole is not with us.
Fatima?
Yes, sir. Am I audible?
Yes, you are audible. Kindly upload your slide.
Yes, yes, sir. Is my screen visible?
Yes, put it in a full size.
Yes, yes, sure. Is this okay?
Yes, yes.
Yeah, okay. Should I start, sir? Okay. Good afternoon, everyone. Today I will be presenting an undiagnosed case of jaundice, who is the culprit, liver or RBC. It's an interesting case report of HbH disease. HbH disease is a type of alpha thalassemia, usually caused by deletion or inactivation of 3 alpha globin genes, leading to underproduction of alpha globin chains. They show varied clinical presentation. They usually present as asymptomatic, but may present as intermittent transfusion requiring hemolytic anemia. Alpha thalassemia is most common in Middle East, Southeast Asian, Mediterranean countries. In India, the prevalence is quite less, that is 12.9%, and out of that, HbH is just 0.01%. I hereby report a case of 25-year-old male presented with complaint of generalized weakness and jaundice since a month and had history of consumption of some Ayurvedic drug. On examination, he had pallor, icterus, and hepatosplenomegaly. He gave past history of jaundice since 2 years, and it was intermittent. And last episode was 3 months back. He didn't had any report with him. He was roaming with that history of jaundice. So we investigated, and in lab values, what we found was that the hemoglobin was 10 gram per dl, and he had a microcytic hypochromic blood picture with raised RDW, and retic count was 12%. The liver function test showed that he had a unconjugated hyperbilirubinemia. Rest of the parameters were just normal. So we saw the peripheral smear, and in the peripheral smear, we could see that predominantly microcytic hypochromic blood picture was seen. There were a lot of target cell, polychromatophils, and teardrop cells. And we did a retic count, and in retic count, we saw few golf ball-like inclusion. So we incubated further for 2 hours and 4 hours at 37 degree, and this is called as HbH preparation, and we could find beautiful golf ball inclusions in that. So we ran an HPLC on Bioret 10, and we got a M-shaped peak in less than 1 minute retention time. So to further confirm and quantify, we ran a capillary zone electrophoresis, and it showed a zone in zone 15. It showed a peak of 14.4%, hence confirming a diagnosis of HbH disease. HbH disease is a rare form of alpha thalassemia, usually presenting as non-transfusion dependent alpha thalassemia. The most common molecular abnormalities in India is alpha 3.7 and 4.2. It can be deletion type or mutational type, and age of presentation varies from childhood to adult patient. Usually, they are asymptomatic, but if they present, they can present with hemolytic anemia, splenomegaly, in some cases hepatomegaly, and mild jaundice. Very few case reports are there which show that jaundice was the initial presentation. As our case, in case of jaundice with unconjugated hyperbilirubinemia with a good CBC and peripheral smear finding, we should work up for hemolytic anemias, and Bioret D10 HPLC and capillary zone electrophoresis helps us in confirming the diagnosis. HbH comprises 1 to 40% of the total hemoglobin, and we should always look for HbF, which is usually increased to 1 to 3%, and A2 is reduced to 1 to 2%. So to conclude, jaundice can be the only clinical manifestation of hemolytic anemia, maybe the rare one like our case of alpha thalassemia. So high index of suspicion and at least HbH preparation and HPLC will clinch the diagnosis. Correct diagnosis will help in correct management and follow-up of the patient. Also, it is a hereditary disease, so prenatal testing is of paramount importance. And to take home, finally, often the culprit is not the one which appears. take a deep dive with your diagnostic armamentarium to know the real cause and offer effective management. Thank you.
Thank you, Fatima. Over to the judges.
That's a nice case, Dr. Fatima.
Thank you, ma'am.
But just tell me, did you map out his family tree to look for
Yeah.
the inheritance?
Yes, ma'am. Yes, ma'am. We did map out. There was no consanguineous marriage history, and even like his brother and sister did not give as such a history of jaundice or anything. But we have told him for family screening and have called the patient for the same.
I think it would be screening in the parents, na? Double heterozygosity should be looked for, if I'm not wrong.
Ma'am, in this case of alpha thalassemia, actually a lot of things are there because 3 chains, they can be either deleted or it can be mutated. So it can be not heterozygous. So one of the like father or mother can transfer this, and there can be some mutation, baseline mutation, which can occur in the body itself for the same for the individual person. So that is why, ma'am.
Yeah. Okay.
Thank you, ma'am.
Hello, am I audible?
Yes, yes, audible.
Okay. So there is a history of intake of Ayurvedic medications. So
Yes,
is there
sir.
any relation to this Ayurvedic medications
Yes.
with jaundice?
Yes, sir, definitely. These people usually he was a laborer by occupation, and these people usually roam around with jaundice for many years and remain undetected unless and until a good CBC and peripheral smear examination is done. And they tend to take all these Ayurvedic medications which affect the liver function further, leading to a false picture of non-hemolytic jaundice. So history of such medication should always be considered while doing all the detailed workup.
Okay, thank you.
Thank you, sir.
One more question, Fatima. Would intermittent periods of stress, like infections, like we have tropical fever, would it
Yes.
also cause hemolysis and icterus in these patients?
Yes, ma'am, definitely. But the chances in case of alpha thalassemia as compared to sickle cell disease or beta thalassemia is very less. They have less episodes. And ma'am, what happens? The mutational forms. One of the mutation is constant spring mutation, which is usually done on sequencing and further analysis. So that patients usually have more symptoms. They can be in stress or without stress. They usually have more splenomegaly, more hepatomegaly, and more of transfusions also, frequent transfusion, not compared to the beta thalassemia, definitely, but they have history of transfusions.
Okay, thank you. Thank you so much.
Yeah, yes, thank you, ma'am. I'll stop sharing. Thank you.
Thank you, Fatima. We'll
Thank
go
you,
to
sir.
the next presenter, Dr. Shruti Shetty. Kindly
Good
upload your
afternoon.
slide.
Am I audible?
Yes, you are audible. Kindly upload your slide.
Is my slide visible, sir?
Yes, it is visible.
Good afternoon, everyone. My name is Dr. Shruti Shetty. I'm junior resident in the Department of General Medicine, Indira Gandhi Government Medical College, Nagpur. The topic of my poster is paraquat poisoning with multisystem involvement, a case report. Self-poisoning with pesticides is a major public health problem with estimated 30 lakh deaths occurring in the Asia-Pacific region alone. Paraquat, also known as methyl vilogen, is known for its extremely high fatality rate of more than 50% due to its inherent toxicity and lack of effective antidotes. After absorption, this compound undergoes redox cycling, which leads to subsequent generation of reactive oxygen species and nitrite radicals. Redox cycling consumes NADPH, one of the cell's key antioxidant defenses. The resultant oxidative stress causes cell damage via lipid peroxidation, mitochondrial dysfunction, necrosis, and apoptosis. The toxicity is particularly more predominant in lungs in 2 key target organs, the liver and the kidney. This is because the paraquat is absorbed against a concentration gradient in these organs. Today, we'll be discussing about a 17-year-old female who presented in a casualty with a history of consumption of 30 to 40 ml of liquid paraquat formulation. She presented within 4 hours of consumption. On admission, the patient was conscious-oriented but dyspneic and tachypneic with a saturation of 90% on room air. She had extensive sloughing with edema and congestion of the oral mucosa. Grade 3 trismus was present. Bilateral lower zone crepitations and occasional rhonchi were heard on auscultation. Coming to the treatment modalities, following the assessment and stabilization of her airway breathing and circulation, she was given gastric lavage with normal saline and activated charcoal. The mainstay of treatment consists of antioxidant and immunosuppression. Antioxidant in the form of vitamin E 600 milligram per day, which impairs lipid peroxidation. Vitamin C 1 gram per day, which reduces the number of reactive oxygen species produced, and injection N-acetylcysteine. This replenishes cysteine, which is a very key defense antioxidant mechanism in our body. The second modality was immunosuppression in the form of short pulse therapy consisting of injection methylprednisolone 500 mg IVOD for 3 days and injection cyclophosphamide 500 mg IVOD for 2 days. The patient had acute renal failure with BOL of 184, creatinine of 7.5. Her CT also reported bilateral septal thickening in the lower zone. For this, she underwent 2 sessions of hemodialysis, and with supportive care over a period of 2 weeks, the patient significantly improved with her saturation, renal indices, and oral lesions, and was discharged after 14 days. In conclusion, the role of antioxidant, immunosuppressions, and hemodialysis in paraquat poisoning is inadequately studied, especially in those patients who present early. These agents have the most promising mechanisms to counter the principal pathophysiological events following paraquat consumption and are worth evaluating in large randomized controlled trials to guide the choice of dose, duration, and combination of these drugs. This will help us in
Shruti, you have lost your audio. Unmute yourself. Shruti, kindly unmute yourself. Shruti.
Is Shruti there?
Shruti, you have lost connectivity.
Hello, I'm extremely sorry for the issue I'm facing with the internet over here. Can I
Your
restart again?
Your last conclusion part. Only conclusion part is in.
In conclusion, I would just like to say that the role of antioxidants, immunosuppression, and hemodialysis in paraquat poisoning is inadequately studied. These agents have the most promising mechanisms to counteract the principal pathophysiological processes of oxidative stress that follows paraquat consumption. This is especially important in patients who present early, and we should evaluate in large randomized controlled trials to guide the choice of dose, duration, and combination of these drugs to formulate a proper treatment guideline or protocol to be followed in such patients. Thank you.
Over to judges.
Thank you, Shruti. If the patient is not able to tell you the poison that he has consumed, how can you diagnose paraquat poison?
Ma'am, actually, there are certain tests available to evaluate the total serum as well as urine excretion of paraquat compound present. But these tests are actually very difficult and are not available in cities like Nagpur. So that is one of the major drawbacks when it comes to paraquat consumption, or as the major drawback that comes with any compound consumption for that matter. So empirical treatment and maybe guiding estimating the patient's renal function test and her liver or the liver and lung involvement will maybe guide us in that paraquat consumption could have taken place.
Okay, thank you.
Thank you, ma'am.
Okay, Dr. Shruti.
Yes, sir.
What are the documented pulmonary manifestations in sequelae of paraquat poisoning?
So depending upon the duration of since following paraquat consumption, initially in the first 3 to 4 days, a patient is going to have alveolitis, which can also lead to pulmonary edema. And following and 3 to 4 weeks after consumption, there is evidence of fibrosis and sudden death in the patient that occurred due to acute respiratory failure, as has been studied in certain researches.
Okay, so if this patient develops fibrosis,
Yes, sir.
what are the proposed line of managements for such patients?
Sir, though there is no treatment guideline for modality for patients who develop fibrosis in paraquat poisoning present as of now. The only treatment which we have seen and also has taken place in pilot studies all around the world is early treatment and early diagnosis. Once fibrosis sets in, there is nothing that can be done. Even antifibrotic agents are not effective in paraquat poisoning patients. So then the only, like as we said, the golden period that the patient presents in is what is life-saving and what immunosuppressant and antioxidant therapy we are going to give to the patient.
Okay, thank you.
Thank you, sir.
Thank you, Fatima. Screen sharing. Now to our next presenter, Dr. Kalyani Reddy. Kindly upload your slide.
She's not going to present, sir. Next candidate is Aniket Chowre.
Okay. Aniket Chowre, kindly upload your slide.
Hello, sir.
You're
Hello.
visible.
Am I audible?
Yes, you're audible as well as visible. Can you enlarge your slide?
Yes. Yes, sir.
Okay, you can present on this one. It's not this. You can start the presentation.
Good afternoon. Shall I start, sir?
Start the presentation. Yes, yes.
Good afternoon, everyone. Topic for today's poster presentation is fungating dermatofibrosarcoma, a rare case report. Myself, Dr. Aniket Chowre, and this poster presentation is guided by Dr. Murtuza Akhtar and Dr. Mahendra Chauhan, sir. In introduction, dermatofibrosarcoma is a rare, locally aggressive, malignant cutaneous soft tissue sarcoma. It develops in connective tissue cells in the middle layer of the skin, that is the dermis. It begins as a minor firm area of skin, most commonly about 1 to 5 centimeters in diameter. It is slowly growing tumor and is usually found on the torso, but can occur anywhere on the body. It tends to infiltrate adjacent structures such as subcutaneous tissue, muscle tendon, and even bone structure. Metastasis, however, is rarely reported. Case report. A 50-year-old male patient presented with a complaint of mass over left gluteal region with no history of any trauma or insect bite. Vital signs were normal. On local examination, there was a pedunculated mass of size 18 to 5 centimeter over a left gluteal region, which was firm to hard in consistency with irregular margin. There was no significant inguinal lymphadenopathy noted clinically. Based on history and clinical examination, a provisional diagnosis of dermatofibrosarcoma was made. Sir, here are the preoperative photographs of specimen, that is raw area. Pedunculated mass is seen. After that, patient underwent a wide local excision and primary closure of skin defect by mobilizing the skin flap. Histopathologic report confirmed low-grade fibrosarcoma. Post-operatively, there was a wound gap, which was managed by regular tracing, and patient was discharged with a 15 days follow-up. Below images are the post-operative specimen. In discussion, dermatofibrosarcoma is a rare, slow-growing malignant fibroblastic mesenchymal skin tumor, which constitute less than 0.1% of all malignant neoplasm and 1% of all soft tissue sarcoma. Dermatofibrosarcoma usually appears as a violaceous pink or reddish-brown plaque that develops slowly, initially limited to the skin. MRI studies are also not specific since they may not always distinguish dermatofibrosarcoma from other soft tissue sarcomas. Therefore, histopathologic examination is the only definitive diagnostic method. Treatment of choice is wide local excision with negative margins of 3 to 5 centimeters from the tumor edge, including the skin and subcutaneous tissue and the underlying fascia. In case with possible bone involvement, the periosteum or even a portion of bone may also need to be excised to achieve negative resection margins. The rate of recurrence depends on the resection margins. in series where resection margins of 5 centimeter were used, recurrence rate were less than 5%. Reconstructive surgery may be required to restore tissue defective after excision using a local skin flap, skin graft, or myoglutinous flap. An alternative to wide surgical resection is Mohs micrographic surgery, which is considered by many as the treatment of choice for dermatofibrosarcoma. The technique consists of successive horizontal sectioning of 5 to 7 micrometer during resection and immediate frozen microscopic examination until a tumor-free margin is succeeded. There are a report of local cure rate of 93 to 100%. Conclusion: fibrosarcoma is a tumor of intermediate malignancy characterized by its aggressive local growth and marked propensity to recover after surgical excision. Further research will help in a better management and outcome for fibrosarcoma. Sir, these are my references.
Thank you, Dr. Aniket. Over to the judges.
Dr. Aniket, is there any role of radio chemotherapy apart from surgery? I mean, surgery would be curative?
Ma'am, surgery will be not curative, actually not curative if margins are not free, and there is a very low role of chemo and radiotherapy in this case.
Basically, a good surgeon would be able to take care.
Yes, ma'am. Yes, ma'am. Basically, important is clear margins.
Okay, Dr. Aniket, you have mentioned that the reports of local cure rates of 93 to 100%. So these are after surgery, right?
Yes, sir. After Mohs micrographic surgery, sir.
Okay. And in conclusion, right now you are mentioning that further research will help in better management and outcomes of fibrosarcoma.
Yes, sir.
So, yeah. So can you just delineate what should be the line of further research based on which this 93 to 100% cure rate can be further increased?
Sir, actually, it is a very rare tumor. So studies are not been published or they are not been research have not been done yet. Sufficient research have not been done yet. So there is need to or involve something else for a better treatment.
Like? Okay. Yeah, sure. Thank you.
Thank you, sir. Thank you, sir.
Thank you, Dr. Aniket. You can stop this screen share.
Thank you, sir.
Now go to the next presenter, Dr. Srushti Kalyan. Kindly upload your slide. Dr. Srushti
Hello,
Kalyan.
sir. Am I audible?
Yes, you are audible. Upload your slide. On share your screen. You are visible.
Hello, I'm Dr. Srushti Hatte. I'm from Department of Pathology, NKP SIMS. I'm presenting the poster on trichofollicular of left cheek, a rare benign tumor. Introduction. While the exact incidence is unknown, trichofolliculum are rare benign hematomas. It represents about differentiation of pluripotent skin cells toward hair follicle. It is a rare hair follicle and intermittent in differentiation. It usually presents as a solitary nodule approximately ranging from 2 mm to 1.8 cm in diameter in head, neck, and head and neck region, with central umbilication and wool-like wisp of immature cells coming out from it. It is characterized by proliferation of abnormal cytokeratin 15 positive hair follicle stem cells differentiating towards the outer root sheath to make hair follicle hair without proper differentiation. Case history: a 21-year-old male patient with complaints of nodule on right cheek. Right cheek from 3 months was about 2 cm to 0.9 cm firm, non-tender, with fine hair protruding from it. Clinical diagnosis of very trichoepithelioma was made. Excisional biopsy was performed. The nodule was removed and sent for histopathological examination. Gross appearance. This is a clinical presentation of a patient. The nodule is about 1 into 1 centimeter, and there is a white wisp of hair coming out of it. In microscopic examination, we can see there is the sections reveal skin. Epidermis shows hyperkeratosis. Basal layer is pigmented. And there are few hair follicles showing various stages of differentiation at the level of dermis. Upper dermis shows a dilated central hair follicle with keratin filled and giving rise to numerous hair follicles. These are numerous hair follicles in second picture. Intervening stoma shows fibrocollagenous tissue and mild mononuclear inflammatory infiltrate. The diagnosis was made. Pathological features are suggestive of trichofolliculoma. Discussion. Trichofolliculoma first described and measured. It is rare hair follicle tumor that manifests as a solitary skin colored papule or norule, often with central pore. The characteristic feature is tuft of fine white hair that projects from the pore. There are two types of trichofolliculoma: solitary, and there are two presentations of trichofolliculoma: solitary and multiple. Solitary trichofolliculoma occur primarily on face, while multiple are rare and been reported in upper extremities, scrotum, and penis. The three stages of trichofolliculoma include early, fully developed, and late stages. Another useful aid to diagnose for the diagnosis of trichofolliculoma is dermoscopy, showing peripheral dark brown projection resembling a crown and described as firework pattern. The characteristic histopathological feature of trichofolliculoma include squamous epithelium, line keratin.
Please conclude, Srushti.
Trichofolliculoma, although is rare in incidence, should be taken into consideration when we make diagnosis for trichoepithelioma, blastoma, and basal cell carcinoma and pilar tumor, because therapeutic management of prognosis are different from different tumor. So proper monitoring of lesions for abnormal growth and changes is necessary.
Over to the judges.
Yeah, clinically, can you distinguish this from more or not so benign lesion?
Yes, ma'am. It is a small. There are many benign lesions, but it is a small and only a wisp-like hair is coming out of it, and it is white and woolly in appearance.
Okay, thank you.
So what are your clinical differentials of this swelling in cheek where patient presents?
Trichoepithelioma, trichoblastoma, basal cell carcinoma.
Okay, thank you.
Okay, stop the slide sharing. Srushti. Thank you very much, Srushti. Now to the next presenter, Dr. Pratik Gaikwad. Kindly upload yourself, Dr. Pratik. Dr. Pratik, are you there? Srushti, make yourself in a mode. Pratik, are you there?
Yes, sir, I'm there. Shall I start, sir?
You are audible, but your slides are not visible. Do you share screen?
Am I visible,
Slides
sir?
are over. You are visible. Yes, now you are visible. You can start your presentation.
Shall I start, sir?
Yes, yes. Start your presentation.
Good afternoon, all the panelists and my fellow speakers. I am Dr. Pratik Gaikwad, JR2 from the Department of Orthopedics of NKP, Salve Institute of Medical Sciences Research Center. My topic for poster is box loop reconstruction for right elbow traumatic instability, a case report. The elbow comprises of a complex of a bony and ligamentous stabilizers that provide both primary and secondary concerns to the elbow instability. Elbow instability is nothing but the looseness in the elbow joint, which leads to catch, pop, or slide out of the normal position during any activity of an arm. Elbow instability may arise through chronic overuse syndrome or as post-traumatic sequelae. Patient with chronic instability classically present with pain, apprehension, or mechanical symptoms after movements that bring about joint subluxation. A careful history should include any activities, pain location, mechanical symptoms, associated neurological symptoms, any past athletic participation, decrease in athletic performance, prior elbow trauma, and elbow surgery. A focused physical examination with specific diagnostic maneuver and additional imaging may be helpful in confirming the diagnosis. Now, the elbow instability remains a challenging I'm very sorry. I'm very sorry. Elbow instability remains a challenging surgical problem. Most commonly, isolated reconstruction of medial collateral ligament or lateral collateral ligament are performed classically. But however, on some occasions, there arise a necessity that requires reconstruction of both the ligaments. As shown in the figure in the left hand side, there are two ligaments, the ulnar collateral ligament and the radial collateral ligament. Usually we reconstruct only one, but in some circumstances we have to reconstruct both the ligaments, and we are using a technique called as box loop reconstruction. In this method, we use method of reconstruction both the medial and the lateral collateral ligament using only one graft. This technique uses a design of a box loop whereby the donor tendon is passed through the humerus and the ulna through the two isometric points which we make on the humerus and the radius ulna, and it is passed through it, creating a loop like fashion. You can see the loop in this. Starting with the case report, a case report was done with one patient of 58 years old female who had a history of consecutive trauma 5 times in last 3 years, including one episode of dislocation. But the patient was unattended. She didn't receive any kind of medical help or specific orthopedic help. She was evaluated with radiographs and lab investigations, and MRI was suggestive of destruction of lateral collateral ligament and the medial collateral ligament with the loss of cartilage of the elbow joint. Now the decision was taken to operate her to reconstruct her ligament using single graft using two isometric points around the elbow. The MRI X-ray was done, and X-ray was suggestive of destruction of the cartilage as well as destruction of the articular congruity of the radial head. CT scan was done to get the 3D imaging, and MRI was done which was suggestive of damage to the ulnar and radial collateral ligament.
Please conclude, Pratik.
Pratik, kindly conclude. I kindly conclude your overtime.
Okay, sir. Post-op X-rays were done, and the X-rays were suggestive of a good articular congruity. Now the follow-up of patient was done at 0, 1 and 6 months. The range of movement of the patient was satisfactory and increased gradually. The weight bearing in right upper limb is not as the normal limb, but patient can carry out her personal work and care and is satisfactory with the procedure. Now the further comparative studies are required to evaluate the effectiveness of this procedure. This procedure is better in terms of the patient is not when patient is having monetary issues, because when the patient has a chronic instability, there is usually associated with radial head fracture, and the only option left is radial head arthroplasty, and the patient has monetary issues. This is a very nice procedure which can help the patient to regain her activity at least to carry out her day-to-day activity. Thank you.
Go to the judges. Go to the judges.
Okay, so what are the advantages over conventional technique?
Sir, I cannot hear you, sir.
What are the advantages? What are the advantages of this above conventional technique?
Sir, if you are just reconstructing only LCL or UCL, there may lead to valgus or the varus deformity depending upon the which ligament we are reconstructing, sir. If we are reconstructing only radial aspect and not reconstructing the medial aspect, there may lead to valgus deformity and vice versa, sir.
Okay, thank you.
Thank you, sir.
Is it one more question, just
Okay.
is it a routinely done procedure?
No, ma'am, it is not routinely done. The patient with elbow arthritis and elbow instability are usually counseled to do arthroplasty or the total elbow arthroplasty or radial head arthroplasty. But due to monetary issues, and there are very less institute which do total elbow replacement, and the follow-up of the patients doing and the prognosis of the patient doing elbow replacement is questionable. So I guess this is a better procedure, sir, ma'am.
Okay, thank
Pratik, thank you. Kindly stop the screen sharing. Next presenter, Dr. Ujjwal Urvan.
Shall I stop the screen sharing, sir?
Stop the screen.
Thank you, sir.
Ujjwal. Ojal, Avankar, kindly, are you there? Ujjwal?
Yes, sir. Am I audible?
Yes, you are audible. Upload your slide, and it is reminded to all the presenters, please be specific in your presentation that you have to present it within 3 minutes. Otherwise, it would automatically become invalid. Kindly present it within 3 minutes. Ojal, kindly upload your slide.
Good afternoon, everyone. Myself, Dr. Ojal Amankar. I am a second year junior resident in the Department of Pathology, NKP SIMS and Research Center, Nagpur. The topic of my presentation is Krukenberg tumor with primary in the appendix. And I'm presenting this poster under the guidance of Dr. Ann Wilkinson ma'am, Dr. Sadhna Mahore ma'am, Dr. Sabia Maimun ma'am, and Dr. Archana Joshi ma'am. Coming to the introduction, in 1896, the Krukenberg tumor was first described by Friedrich Ernst Krukenberg as an unusual metastatic tumor of ovary. Krukenberg tumors are uncommon and they only constitute 1 to 2% of all ovarian tumors. They are often found in bilateral ovaries and 26% are unilateral. In 1902, the Schlagenhofer stated that these ovarian tumors are metastases from a primary malignancy somewhere else, most common primary site being the gastrointestinal tract. Krukenberg tumors are mostly seen in 5th decade of life. The average age of presentation is 45 years. Case history, a 37-year-old female patient presented with chief complaints of burning micturition since 2 months, pain in abdomen on and off since 1 month, and loss of appetite with weight loss since 15 days. There was no other significant history. On per speculum and per vaginum examination, the provisional clinical diagnosis was bilateral pelvic masses under evaluation. USG abdomen and pelvis showed large masses arising in both right and left adnexa, measuring respectively 14.8 by 13 by 10 centimeter and 10.9 by 10.1 by 8.9 centimeter. Bilateral ovaries could not be seen separately from these lesions. Minimal ascites was present. Clinical differential diagnoses were put forward as bilateral ovarian neoplasm and bilateral broad ligament fibroids. A staging laparotomy was performed and total abdominal hysterectomy with bilateral salpingo-oophorectomy was done. There was an incidental finding of inflamed appendix, so appendicectomy was also done. Grossly, we received uterus with cervix with bilateral ovaries. The cut surface of right ovary showed solid white and cystic areas, and that of the left ovary showed yellowish homogeneous solid areas. And the appendix was edematous and dilated and measuring 5 by 2 by 1 centimeter and showed obliterated lumen. Microscopically, the ovary showed many signet ring cells along with intracellular mucin. Displacing the nuclei and pools of extracellular mucin were also seen. Appendix microscopically showed clusters of signet ring cells with intracellular mucin displacing the nuclei in the submucosa and extending up to the muscularis layer of the appendix. Here in the inside, we can see signet ring cells. So the diagnosis was put forward as mucinous adenocarcinoma appendix with bilateral Krukenberg tumor in the ovaries. Coming to the discussion, Krukenberg tumors are metastatic tumors with the most common primary being from gastric adenocarcinoma. The other primary tumors metastasizing as Krukenberg tumor are breast, appendix, colon, small intestine, rectum, urinary bladder, gallbladder, biliary tract, pancreas, ampulla of Vater, and uterine cervix. The tumor cells spread to the ovaries by direct hematogenous route or mainly through lymphatics. Interestingly, the metastases are never found in omentum. Appendiceal malignancies are rare and they are diagnosed in only 0.9 to 1.4% of appendicectomy specimens, of which mucinous appendiceal adenocarcinoma account for 5%. Ovarian metastases are encountered in 16.7 to 37% of appendiceal adenocarcinoma. And these are my references.
Thank you, Dr. Ojal. Over to the judges.
Okay, so any role of IHC in diagnosis of these tumors?
Yes, there is definitely a role of immunohistochemistry while diagnosing the primary. If on immunohistochemistry we get cytokeratin 20 positive, then the primary will be of colorectal origin, and if we get cytokeratin 7 and cytokeratin 20 positive, then the primary will be from gastropancreatobiliary origin.
For lungs?
For lung, we can do TTF1.
Okay, any role of ALK mutation?
Mm.
For lung malignancies?
I'm not sure about that.
Okay, sure. Thank you.
Thank you, sir.
Shilpa madam, any questions?
No question.
Okay, then we'll go to the next presenter, Dr. Ketki Mohite. Ketki Mohite. You are
Good
visible,
afternoon,
Ketki.
everyone. I am Dr. Ketki Mohite, second year resident of orthopedic in NKP SIMS. My topic for, is my screen visible?
Yes, you are visible and audible.
My topic of poster presentation is a rare case of ankylosing spondylitis with L1 burst fracture associated with intracanal spinal hematoma leading to complete paraplegia. Ankylosing spondylitis is a seronegative rheumatologic condition that predominantly affects the axial skeletal with male to female ratio of 2:1. The widespread inflammation leads to structural changes and formation of syndesmophytes, which fuse vertebral segments, resulting in ankylosed spine along with long bone mineral density associated with diseases, rendering the spine susceptible to fractures. Ankylosing spondylitis is strongly associated with HLA-B27 gene, and spinal fractures are up to 4 times more common in patients with AS than general population. The fracture in these cases have a high incidence of neurologic complications with spinal cord injury at initial presentation. Early surgical stabilization has shown to improve survival rates. The aim of present study is to describe the case of ankylosing spondylitis with acute L1 fracture with rapid deterioration of bilateral lower limb power as a result of intracanal hematoma and treatment of this case by spinal cord decompression and pedicle screw fixation. Case report. Study includes a 42-year-old male, a known case of ankylosing spondylitis with history of trivial trauma by fall at home. Patient presented with severe backache, inability to walk with neurological power of 3/5 in bilateral lower limb and bladder involvement on admission and on the day of trauma. The patient suffered sudden deterioration of power in the bilateral lower limb to 0/5 overnight. On radiological examination, it was found that the patient had L1 burst fracture, and on MRI investigation, the cause of the sudden development of intracanal hematoma was found, resulting in spinal compression, which led to the bilateral loss of power. The L1 burst fracture with intracanal hematoma was managed with spinal cord decompression for hematoma and pedicle screw fixation at the level of D10 to L4 for L1 burst fracture. Given are the X-rays, pre-op X-rays and immediate post-op X-ray and 6-month follow-up post-op X-ray. The results of the case, the results that we found was that the early stabilization and fixation with treatment for intracanal hematoma has resulted in good functional outcome. Patient regained complete power by the time of suture removal. Considering the poor hold of screws due to osteoporosis, patient was on teriparatide and calcium and vitamin D for 6 months. On 6-month follow-up, the patient had excellent recovery with complete regain of power in bilateral lower limbs and normal bladder function. To conclude, the long lever arm biomechanics in patients of ankylosing spondylitis make them prone to spinal fractures. In addition to this, osteoporosis is a major problem which can lead to fracture even because of trivial trauma. Most of these patients have an associated neurological deficit. A concomitant development of intracanal hematoma can lead to sudden deterioration of the neurology, early decompression of the hematoma, and pedicle screw fixation to stabilize the spine gives favorable results. Management of osteoporosis is equally important to prevent failure of implants. Thank you.
Thank you, Ketki. Over to the judges.
That's a nice case, Ketki. Looking at the neurological recovery, what was the time lag between patient's symptoms and the intervention, surgical intervention?
Ma'am, the patient was admitted on the day of trauma itself, and he was operated within 3 days in our hospital. And by the time of suture removal, that is on the post-op day of 15, the patient had regained full bilateral lower limb power, but due to the pain, he was walking with the help of a walker. But on 6-month follow-up, he was completely fine and he was walking on his own.
Which other vertebrae are at risk for? I mean, which other skeletal abnormalities can you get in these patients after?
In ankylosing spondylitis, the most common skeletal abnormality we see is kyphosis, and the most common segment of the spine of the vertebra to get fractured is subcervical vertebrae, and then after that thoracolumbar vertebrae.
Thank you, Ketki.
Thank you, ma'am.
Dr. Dhyan Shankar Mishra.
So can you highlight any respiratory involvement of ankylosing spondylitis?
Yes, ankylosing spondylitis patients are more prone for pneumonia and pulmonary fibrosis, which eventually happens in almost all the patients and thus increases the mortality in this case.
Okay. Can respiratory symptoms precede the vertebral symptoms or the spinal symptoms in ankylosing spondylitis?
So if there are any predisposing factors, then definitely respiratory symptoms can precede. But first, usually the presenting symptoms are that of spine itself because of new bone development and mineralization of the bone.
Okay, thank you.
Yes, thank you, sir.
Thank you, Ketki. We'll have the next speaker, Dr. Sagarika. Dr. Sagarika, are you there?
Yes, sir. So
Kindly
is my
share your screen. You are audible. Share your screen.
is my screen visible?
No, it's not visible. Share. Put it in share screen mode. There's a green arrow lower down.
So is it visible?
It started now. Yes, it is visible. So now you're audible and visible.
Good afternoon, everyone. Myself, Dr. Sagarika Tidge. The topic for my poster is diagnostic limitations of tubular carcinoma breast on fine needle aspiration cytology. I'm presenting under the guidance of Dr. Sadhna Mahore and Dr. Anjali Pachikar. Introduction. Tubular carcinoma of the breast is a distinct, relatively rare, low-grade neoplasm accounting for approximately 1 to 2% of invasive breast cancers. Sorry, just a minute. It's a variant of invasive ductal carcinoma that is well differentiated and characterized by an orderly tubule formation. Case history. A 40 years female came with the complaints of lump in left breast since 1 year. On examination, lump was hard, non-tender, slightly mobile with irregular margins and surface. FNSE was done. On cytology, smears revealed sheets, clusters, and microglandular arrangement of ductal epithelial cells showing mild to moderate anisonucleosis. Few scattered ductal epithelial cells with enlarged nuclei were also seen. Background showed neutrophils and red blood cells. This patient was later operated and the specimen was sent for histopathology. The MRM specimen received showed a tumor mass in the upper inner quadrant. On cytology, diagnosis of proliferative breast disease with moderate atypia was given. On histopathological examination, microscopy revealed irregular proliferation of small glands and tubules lined by columnar to cuboidal epithelium. Many ducts showed cribriform pattern and presence of comedonecrosis. The glands had angulated contours and widely open lumen. The epithelium showed mild anisonucleosis and pleomorphism. The tumor cells infiltrated the stroma. Adjoining breast tissue showed foci of ductal carcinoma in situ. The surgical margins and skin were free from tumor cells. 2 out of 9 lymph nodes showed tumor deposits. Diagnosis of tubular carcinoma of left breast with foci of ductal carcinoma in situ in the surrounding breast tissue and metastatic deposits in 2 out of 9 left axillary lymph nodes was made. Nottingham modification of Bloom-Richardson grading, grade 1 was given. A retrospective review of FNSE smears was done and they showed angulated sheets of cells. Discussion. Tubular carcinoma of the breast is a rare entity that can be easily misdiagnosed on cytology. It is composed of well-differentiated tubular structures with open lumina, typically 1 layer thick, surrounded by abundant stroma. Because of its non-aggressive histologic appearance and its low propensity to recur locally, spread to axillary lymph nodes and metastasize, tubular carcinoma carries a favorable prognosis. Its diagnosis is established based on histopathological examination, as the bland and orderly appearances of cells in FNSE samples leads to difficulties in cytodiagnosis. Hence, a cautious attitude towards the diagnosis of tubular carcinoma from FNSE samples is necessary. These are my references. Thank you.
Thank you, Sagarika. Over to the judges.
Dr. Sagarika?
Yes, sir.
Okay, what are the routine methods of screening of breast cancer?
Sir, cytology can be done, and after that, histopathological examinations of the specimen.
Okay,
And
breast self-examination, mammography, do they have any role?
yes, sir. Clinical examination and mammography also have a role. Sonomammography.
Okay, thank you.
No questions. No.
So, Sagarika, you can stop the share screen.
Yes.
Over to our next presenter, Dr. Devraj Shah. Devraj, kindly, yes, kindly share your screen.
Sure, sir.
You are visible.
Sir.
Large, yes. You can start the presentation.
Thank you, sir. Good afternoon, everybody, to my respected judges and to my beloved colleagues. Today, my poster presentation, the topic is prenatal diagnosis of congenital anomalies syndrome. It is a constellation of cases which was conducted in Department of Radiodiagnosis in GMC Nagpur. What is a congenital malformation? It is a congenital physical anomaly that is deleterious, a structural defect which is perceived as a problem. And what is a malformation syndrome is basically where one then more body part is involved. We have presented a selection of rare congenital malformation and syndromes in the form of pictorial essay. So the first syndrome is the short rib polydactyly syndrome. It is an autosomal recessive disorder, which is a rare group of severe osteochondrodysplasia. There are 4 types of short rib polydactyly syndrome. The type 1 being Sandino-Noonan type, the type 2 is Morzejewski's type, type 3 is Werman-Neuhoff type, and the type 4 is Beamer-Langer type. This is the Beamer-Langer type, and there is a typical triad of this. There is a short narrow thorax, and there is micromelia, and there is polydactyly. The next is the Currarino triad. The Currarino triad is basically also known as the ASP triad. A stands for anorectal stenosis, S stands for sacral agenesis, and P stands for a presacral mass. Here, the presacral mass may be teratoma, it may be a meningioma. Next is the Potter's syndrome. The Potter's syndrome, the name itself is the mnemonic, where P stands for pulmonary hyperplasia, O stands for oligohydramnios, T stands for twisted wrinkling skin, T stands for twisted face, E stands for extremity deformities, and R for renal agenesis. Next is the Michel-Gruber syndrome. There is also a triad present in Michel-Gruber syndrome, where there is occipital encephalocele. Here is the first pick. Then is bilateral enlarged kidneys. There may be cystic kidneys also, and there is post-axial polydactyly. The next condition is the prune belly syndrome, where the belly is pruned. So the triad in the first part of the triad is pruned belly. The second part of the triad is dilated pelvic calyceal system with renal dysplasia. And the third part of the triad is bilateral undescended testis. Next condition is achondrogenesis, where there is defect in the formation of cartilage and bone. And so there is a condition which is known as floating head appearance. In floating head appearance, there is demineralized spine, but there is normal head present. Next condition is thanatophoric dwarfism, where the thanatophoric dwarfism, thana means death and phoric means to beard. There are 2 types of thanatophoric dwarfism. The type 1, there is the telephone handle femur, and type 2, there is clover lip skull. The last 2 condition, the semilobed holoprosencephaly. There is a spectrum of semilobed holoprosencephaly, which is starting from allobed, then it is semilobed, and then it is lobed. Holoprosencephaly means whole of forebrain. Whole forebrain. Now, in allobed, there is fusion of both the anterior part of the forebrain and posterior part of the forebrain. In semilobed, there is fusion of only anterior part of the forebrain. In lobed, there are only subtle areas of fusion of forebrain. Here we can see fused thalamus and the fused anterior part of the forebrain. Next is the conjoined twins. There are 3 types of conjoined twins, where there can be ventral, dorsal, and lateral. Yes, ma'am. This is the last pick. And here we are seeing omphalophagus, where there is fusion of the abdomen. And so these are the congenital anomalies which I have presented in the form of pictorial essay. Thank you.
Thank you, Devraj. Over to the judges for questions.
Yeah, Devraj, those were very nice textbook pictures that you presented. Just one question: what is the most common congenital anomaly which you can encounter?
Most common congenital anomaly, ma'am, within this or just in basic?
These all seem to be incompatible with life, right? As you
Yes,
told
ma'am. Yes, ma'am. These are pretty uncommon, which I have presented in GMC Nagpur. We can in common we can see cystic hygromas. We can see normal polyhydramnias in polycystic kidneys or polydactyly. Or we also see some cases like multicystic dysplastic kidney or encephalocele. These are the common cases. These are the common anomalies which we see. We also see some cardiac anomalies like tricuspid retardation or other cardiac anomalies. These type of cases
ASD.
also come to our department.
Yes. Okay.
ASD, VSD.
Yeah. Thank you.
Sure, ma'am. Thank you.
Okay, Dr. Devraj, you seem to have presented a pictorial essay.
Yes, ma'am. Yes, sir.
So, are all these cases seen by you seen at your center?
Yes, these type of cases do come in GMC Nagpur. I'm JR2 at this moment, so my second year is getting to an end. So within the last 2 years, we have seen this type of cases.
So can you come to any conclusion after this pictorial essay?
Yes,
would you like to? Yeah.
The main thing is that if we are doing ANC USGs in a pretty good manner, then we can diagnose this type of lethal anomalies pretty early. And if we can detect them pretty early, now the MTP law has been changed and it has gone to 24 weeks. So if we can detect these anomalies, lethal anomalies before 24 weeks, then it would be helpful for the obstetricians to know these things and they can go for the MTP, because these are pretty much lethal anomalies, and so the pain.
Oh, okay, thank you.
Yes, thank you, sir.
Thank you, Devraj. Coming to our next presenter, Dr. Kunda.
Yes, sir.
Participants are requested to not overshoot their timings as we are running behind schedule. So please stick to your timings, okay?
Good afternoon, everyone and respected judges. I am Dr. Kunda Shahane, Consultant Fetal Medicine at Mayflower Clinic, Nagpur. I am going to present poster on choroid plexus cyst and its significance. As a part of introduction, choroid plexus cyst is a soft marker. It may be unilateral, bilateral. When it is isolated and not associated with any other abnormality or soft marker, it is considered to be non-significant and it resolves in a due course of time with a good prognosis of pregnancy. But when it is associated with other soft markers like cardiac or extracardiac soft markers, then further evaluation is needed to rule out the chromosomal abnormality. So interpretation is very, very important whenever we come to know that any soft marker is present in the second trimester anomaly scan. To discuss with the case details, this is my patient, 32 years old, primary gravida, referred at around 18 to 19 weeks of gestation with unilateral choroid plexus cyst. After thorough examination on ultrasound, on fetal echocardiography, it was muscular VSD was present around 2 mm. So fetal echo showed this finding, and this is also a soft marker. So combination of soft marker in this case need to evaluate this fetus for the chromosomal abnormality. So in this case, I have done amniocentesis for fetal microarray, and fetal microarray report here, it shows abnormality in the chromosome on the chromosome 22. It was showing the 1000 kb extra gain on chromosome 22. So it was expressing in the abnormal form prognosis, like it may be expressed in the form of Noonan syndrome, it may express in the enzyme deficiency, it may be lethal in the neonatal neonatal period and in the childhood period. So counseling was done related to abnormal chromosomal pattern in this fetus. So to conclude and the results, in each and every pregnancy with the presence of choroid plexus cyst, fetal echo is to be done, and it is suggested to rule out the cardiac soft markers. So final evaluation is done in such cases for ruling out the chromosomal abnormality. Thank you.
Thank you, madam. Thank you, madam. With this abnormality and the underlying congenital abnormalities, would MTP be advisable in this patient?
Yes, MTP, the prognosis with the chromosomal congenital anomaly, the prognosis will be bad. So we can give the informed choices to the couple, because the prognosis, we should counsel them that the baby will not be good. If it is a legal limit, nowadays it is 24 weeks by the government. Previously it was around 20 weeks. So before 20 weeks, we want all the evaluation. But in some cases, if the prognosis is poor, the court can give a special permission for termination of pregnancies like this, and if the couple wants to abort, terminate such pregnancies. Thank you, ma'am.
Dr. Gyan, any questions?
Thank you. It is a nice case.
Then we'll go to the next.
Stop share.
Kindly stop sharing the screen. Dr. Kunda, kindly stop sharing the screen.
Hello, everybody. Should I start now?
You are the next.
Yeah. Hello. Good afternoon, everybody. Myself, Dr. Pawan Shahane. Good afternoon to all the colleagues and the respected judges here. I am presenting a poster about redo vaginoplasty in case of a amenorrheic patient. The patient, this is a case study, case report. What happens in vaginal agenesis? It's a condition where the vagina is not developed, causing primary amenorrhea. And vaginal agenesis, it can be proximal, it can be to a distal level. But these cases are commonly associated with some other abnormalities. We have to search for those abnormalities like kidney abnormalities, skeletal abnormalities, or maybe chromosomal associations, or uterine abnormalities or ovarian abnormalities. In these patients, they present with a amenorrhea, primary amenorrhea with a hematocolpus. But in our case, a 22-year-old unmarried girl, she presented with secondary amenorrhea. She gives a history of 7 years back. She was having vaginoplasty done, and for 2 years she had menses also. But suddenly those menses stopped. Their parents were not that much educated, and she was the girl. She is also not aware, and they neglected the things for 5 years more. And when it's time for her marriage, they come to know that okay, something is wrong with her. The menses are not coming, and simultaneously vaginal opening is not there. So then they visited us, and on examination we found that though it is a secondary amenorrhea, but still the vaginal opening is not there. Even the dimple is not visible clinically. So we have done a 4D ultrasound, and it shows ballooning of the cervical canal and some small part of the proximal vagina. There was a thick non-communicating tissue we can see on the ultrasound here in these lateral pictures. And then we planned for the surgery. It was a difficult surgery actually, because this is the second surgery for her. So still we planned for the reconstruction. There are multiple ways of reconstruction in these patients. We choose the commonest method which gives consistent and good results, that is McIndoe procedure. Here we have done the reconstruction by dissecting the supposed to be a dimple. It was not there, but we catheterized the patient. The balloon is there inside the bladder. We put a finger in the perrectal area so that both the areas will be safeguarded. And in between these two areas, we started dissecting the thick fibrous tissue, and then we get a good play. We doesn't get a good plane, but we reach to the that uterus and the cervical canal there. And we confirmed then immediately after giving in, we found that around 50 ml of blood, chocolate colored blood, was drained out, and we confirmed the uterus cervical canal with the uterine sound. In this way, we dissected the vagina properly to a size of around 2 inch of breadth, and this area we do the split skin thin graft, which is put on a condom, which is a condom mold, which is prepared previously, already prepared, and we kept a skin graft over it in a reverse manner. We inserted this mold with the skin graft and sutured it on all the canals, all the walls, and such created the canal. The routine dressings and all those things we maintained. Eventually we removed that mold and we shift to our new modified mold. In this mold we have used a plastic mold with a silicone coat, so it will be sturdy because of plastic and softer because of the silicone coating. Simultaneously at the distal end we kept a hole so that all the material which is draining from the uterus, that can be drained without removing the mold. So this surgery is done. In the conclusion, I would like to mention that this 4D pelvic ultrasound is helpful in diagnosis and planning of this management part. Vaginal raw areas that can be better covered with split thickness skin graft, and post-operative care and maintenance of this vaginal tract is more important, so as to avoid any stenosis like that. Yeah, any other complications. Thank you.
Thank you, Dr. Pawan. Over to the judges.
Thank you, Dr. Pawan. Just one question. What are the chances of her having undergoing a recurrent surgery? I mean, this is the second surgery. Third would be.
This is her second surgery, and that's why we some techniques are there which have more chances of stenosis. But if we put a skin graft there, so the skin graft will contract, but we have already made it more adequate, so even after contracture still that there won't be any stenosis. So we have to make it a big size in the surgery only, and if the healing is proper, skin graft is take up is proper, then the canal is usually maintained. Patient has to use that the silicone mold for maintaining the canal like that only till she gets married.
Thank you.
Yeah.
Okay. Just one question from here. Now this was the case of vaginal agenesis that was previously operated. So are there any documented evidences that other anatomical defects or endocrinological disorders are associated with vaginal agenesis, or is it just a cosmetic defect?
No, sir. Vaginal agenesis is actually her ovaries, uterus are totally normal. In most of the patients, they have these things normal. They have regular menses. Chances of getting pregnancy is also normal in those patients. So the vaginal reconstruction is must for them. And some of these patients, they might have some other abnormalities, not in her case, but some of the patients might have.
Okay, thank you.
Yeah, thank you, sir.
Thank you. Can stop the share screen.
I request everyone to be very brief in their presentation. Otherwise, we may have to, postpone this session sometime later, because we have an oration session which cannot be postponed any further. So I request all the participants to kindly please make it brief so that all of us can finish within time. I also request the judges, please mute your meeting, sir.
Dr. Pawan, kindly unmute yourself.
I also request the judges to have only one question per presenter, please.
Yeah, okay. Okay, got it.
Okay, we have the next presenter, Dr. Prachi Sancheti.
Yes. Hello, can I start?
Yes, you can start. You are audible and visible.
I'm Dr. Prachi Sancheti, consultant pathologist, a specialty laboratory for histopathology, cytology, and immunochemistry at Dhantoli, Nagpur. I'm presenting this case for the rare occurrence of myiasis in seborrheic keratosis. Now, myiasis is a parasitic infestation of fly larvae or maggots, as we know them, that feed on tissue, and commonly it is seen in tropical regions, especially in debilitated or mentally deranged patients with poor hygiene. Now, cutaneous myiasis may be caused by dipterous fly, that is two-winged fly, that lay their eggs in necrotic or infected tissues, although some species can also affect unbroken skin, and it may complicate pre-existing dermatosis, ulcers, or wounds. However, maggots infestation of neoplastic skin lesions has only rarely been reported. So in our case, it was an 80-year-old female debilitated due to old age and poor nourishment with neglected hygiene, presented with a pigmented nodular swelling on the right thigh, which was quite of long duration. However, there was a recent history of foul-smelling discharge from the lesion, and on clinical examination, a pigmented nodular swelling was seen on the medial aspect of the right thigh. On close inspection, it was found to be infested with maggots, and it was excised and sent for histopathological examination. So what I received was a nodular swelling arising from the skin, and you can see that there is a burrowing ulcer in the center, and which has been infested by maggots. On histology, these lesions showed the typical histomorphology of seborrheic keratosis in the form of exophytic proliferation of basaloid cells with these horn cysts, and there were these areas of ulceration in which larvae could be seen burrowing. This is a hyper view of the larva, which is showing the cuticular spines. Hello, can you see? Hello.
Kindly share your screen.
I have been sharing. I don't know how it stopped.
You are on the screen. Your slide is not visible. It disappeared. It was there till you were discussing the pathological.
Please go to the previous slide, ma'am. You might have come to the.
Yeah. I'm so, okay. Anyways, I have shown the pictures already. I don't know why I'm not able to share. No, it's not seen. Oh. So it was basically to conclude that cutaneous myiasis is quite well known. It can be in the form of wound myiasis or creeping myiasis. And however, seborrheic keratosis is a very common skin neoplasm that is seen in the middle-aged and elderly. But neglected hygiene and poor mental condition of the patient can cause continuous friction, ulceration, and subsequent infestation by maggots. But it is very much preventable if proper care is taken regarding the hygiene and nourishment of the patient and well-being of the patient. Thank you.
Go to the judges.
No questions.
Done.
Madam, how frequent is this condition?
No, myiasis, as cutaneous myiasis is pretty common, but then as far as the neoplastic, like otherwise seborrheic keratosis is a very common neoplasm for the skin. But as far as my literature search, I found only one other case of seborrheic keratosis, again in a mentally deranged patient which got infested by maggots.
Okay, thank you, madam.
Yeah, thank you.
Go to the next speaker, Dr. Kaustubh Patil. Is he here? Dr. Kaustubh. If he's not here, then we'll move over to the next speaker, Dr. Ronak Dhaule.
Yes. Should I share my screen, sir?
Yeah, start sharing your screen.
Should I start, sir?
You are visible. Can you adjust your slide? Yes. Now you can start.
Just a second, sir. I'll just need a second. Okay. Good afternoon, everyone, fellow panelists and my dear friends. I am Dr. Ronak Dhavle, Senior Resident, Department of Orthopedics, NKP Salve, Medical College, Nagpur. I'll be presenting a case report today, and my topic is Prostalac for infected proximal humerus fractures. As we all know, the shoulder joint infection is very common complication after proximal humerus fractures and joint arthroplasty procedures of the shoulder. Eradicating any sort of infection is very difficult in presence of implant, and it leads to implant loosening, pain, and restricted range of motion. Now, Prostalac has emerged as a definitive intermediate step for infection control and giving good range of motion in such patients. Jumping on to the case presentation, I would like to present my patient who was a 46-year-old male, right hand dominant, 1-year-old outside operated case of right proximal humerus fracture with Philos plate in situ and a discharging sinus since the last 8 months. Pain and swelling was present over the right shoulder, and the patient had absolutely no active range of motion of right shoulder. The passive range of motion, the numbers are given as below. There was no distal neurovascular deficit. Now, looking at the current scenario, the surgical plan was primarily to go in, remove the implant, put in a spacer of antibiotic, and give patient a good range of motion. Now, as you can see the preoperative radiographs, I would like to zoom in for that. You can see there was absorption of the humeral head, there was screw back out and implant loosening. Now, looking at this, we planned the surgery, and under proper anesthesia, we took all aseptic precautions. We went in through the previous scar. We excised the sinus tract. The remnant, the implant was removed with periosteum elevator properly, and the remnant part of the humeral head was nibbled out and sent for osteopath. The medullary canal was reamed, and the crux of the surgery was we made a 3D mold by taking CT scan images of the opposite shoulder. And on the back table, we used cement, a tense nail, and a combination of antibiotics to make the Prostalac. That is also called as a spacer. The head was reduced and the movements was checked, and the reduction was found to be satisfactory under CR. The repair of the cuff that was under the incision was sutured along the remnant part of the humeral bone. Thorough lavage was given and closure was done. Reasonable range of motion was started immediately post-op. As you can see the intraoperative images, this is the humeral reaming that was done, and this was the Prostalac implant that was made on the back table, the remnant part of the humeral head that was removed, the final implantation, and CM image after final implantation. So the results were fantastic, and after 2 years of follow-up, the patient had no signs of reinfection and significant range of motion improvement. And that too, the good part was it was active range of motion. So a satisfied patient at the end of 2 years and a satisfied doctor at the end of treatment. The patient did not want any further surgery as he was very satisfied. You can see the clinical images for forward flexion, external rotation, internal rotation, and extension of the shoulder. Thus, we conclude that in carefully selected patients of infected shoulder, Prostalac can be used as a definitive treatment. Below are my references, as there are very few papers presented on this. Thank you.
Thank you, Dr. Ronak. Over to the judges.
Yes. Sorry, ma'am, I can't hear you. Hello?
Madam, any questions?
Any questions, ma'am?
No questions.
All right. Thank you so much, ma'am.
Jan, any questions?
What are the possible surgical complications of this procedure?
The possible surgical complications of this procedure, sir, there can be the patient may end up in reinfection. There can be loosening of the implant that was there, because the implant which we have put in is not a proper metal implant. It is made up of cement. There are chances that there might not be any bone imbibement on the surface, because there is no ingrowth of bone on the surface of the cement implant. So that's why there are chances of implant losing. Thankfully, fingers crossed, in this patient, there was no such case. And also the patient might land up in pain. There can be rotator cuff problems also with the patient if it is not sutured properly to the humeral bone.
Okay, thank you.
Yes, thank you so much.
Speaker Dr. Shivani. Kindly stop sharing.
Yes, sir.
Am I audible, sir?
Yes, you are audible. Kindly share your screen.
Is my poster visible?
No, yes, you are visible. You can start your presentation.
Okay, good morning, sir. Today my topic of poster presentation is sonographic and mammographic evaluation of benign breast lesion. To start with, the primary modality for diagnosing for imaging breast lesion involves ultrasound and mammography, but the limitation for mammographic evaluation involves it cannot be done in dense breast and in less than 40 years of female. Thus, the USG remains the primary imaging modality. The imaging characteristic of benign breast lesions involved it is well defined. There is no architectural distortion. It is wider than and it is parallel to the breast parenchyma and shows benign lesions for post-acoustic enhancement. Now, there are a large majority of benign breast lesions, but I will be summarizing few of them. First involves ductal ectasia. In ductal ectasia, there are the USG features involved. There are multiple dilated ducts with diameter being more than 2 mm, and the mammographic features involve dilated linear branching densities, which is mostly seen in the retroareolar region. And the calcification, rod-like calcification can also be seen on mammography. The second lesion involved ductal papilloma. In this, the USG finding shows a solid homogeneous lesion present which may partially or completely occupy the dilated duct, mostly in the retroareolar region, and it shows raised vascularity. On mammography, often mammography is normal in intraductal papilloma, but when findings are present, it appears as solitary or multiple dilated ducts with high density mass within it. The third lesion that I'm going to describe is fibroadenoma. It is seen as well-defined hypoechoic lesion that may show coarse calcification, popcorn calcification as we can see, and it is wider than taller and parallel to the breast parenchyma. The mammographic features involved, it is seen as a high-density lesion without any architectural distortion. Next is lastly, we have cystosarcoma phyloides. It highly mimics fibroadenoma, but it is larger in size and it is locally invasive. Mammography can also show a increased density lesion in breast involving one or more than one quadrant of the breast. Thank you, sir.
Thank you. Over to the judges.
Thank you, Shivani. Just tell me what is the sensitivity and sensitivity of these radiological investigations for benign?
Sensitivity, man, it is 80 to 90% sensitive.
Hello, Shivani, you are not audible. Unmute yourself.
Yes, sir.
Now you're audible.
Pardon, sir?
You are not audible. Can you repeat your answer?
Am I audible now?
Yes, yes, you are audible.
Yes, yes. Can you repeat your question, sir?
The question was, what is the sensitivity and specificity? I mean, would this be 100% have
No,
a
ma'am,
negative?
it will not be 100% confirmatory, but MRI is more confirmatory, but we can screen and early diagnose the lesions in early stages.
Okay,
Okay, thank you.
Dr. Dhyan?
Any features of breast tuberculosis on imaging?
Sorry, it will be seen as hypoechoic lesion, and surrounding fat stranding will be seen, and associated axillary lymphadenopathy can also be seen.
Okay, thank you.
Okay, thank you, sir.
Thank you. Can you stop the screen? Share screen.
Okay.
Dr. Payal Gundane, are you there? Dr. Payal?
Yes, sir.
Kindly share your screen. You are visible. Yes, you can start your presentation.
Yes.
Good afternoon, everyone. My topic for poster presentation is anesthetic management of case of Guillain-Barré syndrome for cesarean delivery, a case report. Guillain-Barré syndrome is acute, autoimmune, rapidly evolving reflexes motor paralysis with or without sensory disturbance. Its incidence in pregnancy is 1.2 to 1.9 per lakh population per decade. Maternal and perinatal mortality is more than 10%. It is very rare in pregnancy, hence there is no proper guidelines for the safe anesthesia and the delivery. We reported a case, a 25-year-old female, primi gravida with 28 weeks of gestation, brought to a casualty with history of loose motions as 2 weeks, followed by progressive weakness in lower limb, followed by upper limb weakness and difficulty in breathing. Hence, patient intubated and put on mechanical ventilation. Patient tracheostomized in view of long-term ventilation and admitted in ICU. During her hospital stay, she has been diagnosed as a case of preeclampsia and autonomic dysfunction and abnormal sweating and started on tablet Lobet 100 mg BD. Patient taken for elective LSCS considering the respiratory failure, deranged LFT, INR on higher side, and the chances of impending eclampsia. Come to the Guillain-Barré syndrome, it is having the motor weakness, sensory dysfunction, autonomic dysfunction, and cranial nerve involvement. Considering all these things, selection of anesthesia was a tough task. Both have their pros and cons. If we select the regional anesthesia, as a patient is PIH, raised INR is a contraindication for regional. Then there are chances of convulsion during the intraoperative period. Second, autonomic dysfunction, so suspected fluctuation in blood pressure and dysarrhythmias. Motor and sensory dysfunction has difficulty in assessing the level of blockade and chances of high spinal and total spinous. Some studies, Wertlius et al. Considered the worsening of neurological symptoms and partial recovery following the rectal block. Brooks and Alice et al. Mentioned the successful use of regional anesthesia in pregnant. Come to the general anesthesia, Feldham et al. Reported the hyperkalemia and cardiac arrest after administration of scoline in pregnant female. Guillain-Barré syndrome, there is an axonal degeneration and disruption of neuromuscular junction. So there is altered response to the neuromuscular blocking agent. So GA was also challenging because of multiple drug uses affecting the mother and the fetus. Come to the patient's management. Patient's BP was on higher side, 160/90. We have pre-medicated patient. Considering her increasing secretions, anti-sialogo given, and the patient induced with the thiopentone and atracurium. Once the top score is 0 to 4, patient has been handed over to surgeon. Baby delivered at 7 minutes and injection oxytocin started and injection midas and injection fentanyl 30 microgram given to reduce the stress response. Patient has been maintained on O2 plus sevoflurane 1.5% dial concentration. Surgery time was 48 minutes and intraoperatively vitals were stable. Patient reversed with glyco and neostigmine injection after return of spontaneous respiration and top score of 4/4. Post-operatively, patient shifted to ICU and for the further ventilatory care and supportive management. Conclusion, we have successfully managed the case of Guillain-Barré syndrome with general anesthesia for cesarean delivery without any complication and adverse event. And this was the first case in the Maharashtra which was managed successfully with the general anesthesia with a multidisciplinary approach with thorough evaluation of patient, meticulous drug selection, intense invasive hemodynamic monitoring, and ventilator strategy leads to the successful maternal and fetal outcome.
Over to the judges.
Yeah. One question only, Payal. Of the two anesthesia, modalities of giving anesthesia, which one is preferable? Otherwise, what would you recommend?
Mostly, ma'am, general anesthesia is preferred because there is a disadvantage of local anesthesia because there is autonomic dysfunction. So there may be chances of fluctuation in blood pressure. Then there is motor and sensory disturbance. So there will be a motor weakness. So chances of not recovery from the motor blockade is, and then assessing the level of blockade of anesthesia spinal blockade is difficult.
So what was the dilemma here? I mean, she was already tracheostomized and on ventilatory support. So what was the dilemma?
Delivery of the patient, cesarean section, induction of anesthesia, ma'am.
Okay.
Dr. Gyan, any questions?
No, thanks.
Kindly stop sharing the screen, Payal. The next participant, Dr. Ashwini Lahoti. Ashwini Lahoti, are you there? Dr. Ashwini.
Dr. Ashwini, are you there?
Ashwini. If you're not there, then we'll go to the next speaker, Dr. Shweta. Dr. Shweta.
Yes, I'm there.
Okay. Kindly start sharing your screen.
Good afternoon, everyone. I'm Dr. Shweta Borkar, a senior resident in Department of Medicine, AIMS Nagpur, presenting a poster of 2 rare cases of bilateral superficial thrombophlebitis and COVID-19 infection under the guidance of Dr. Sunita Kumbalkar ma'am and Dr. Rajeshri Kaur. To start with, as we all know, COVID causes blood hypercoagulability and severe inflammation, resulting in increased risk of thrombosis. Endothelial damage and autoimmune mechanisms have been reported to contribute to the development of microvascular thrombosis and occlusion, as depicted in the picture on the right-hand side, which shows a flowchart, various factors contributing to hypercoagulability, sepsis-induced coagulopathy, disseminated coagulopathy, and microangiopathy. Limited data is available on the incidence of superficial thrombophlebitis in patients with COVID-19 infection. Here we report one case of bilateral superficial thrombophlebitis and other of bilateral superficial thrombophlebitis with DVT and multisystemic infarcts in young without prior history of vascular thromboembolism and predisposing factors with partial recovery on follow-up. So our first case was 34-year-old male who presented with oral ulcers, fever, dry cough, pain, swelling, and redness of both lower limbs. On examination, he had bilateral lower limb redness and edema up to thigh, as shown in this figure. His investigations were as follows. COVID RT-PCR was positive. NLR was more than 3.5. Platelet count was normal. Thrombophilia profile was negative. Sickle test was negative. His acute phase reactants were raised. LFT, RFT was normal. His CT thorax showed nodular opacities in apicoposterior segment of left up below. CT abdomen was normal. His bilateral lower limb Doppler showed bilateral superficial thrombophlebitis, as shown in this picture. There is non-compressibility of the superficial vein of the lower limb. That is the great saphenous vein. And his ECG was normal. Echo was almost normal. He was treated as per the protocol of COVID-19 and with low molecular weight heparin and supportive care. On discharge, we gave him dabigatran for 6 weeks, and his functional status on discharge was 0. The second case was 32-year-old female who presented with right hemiparesis and right and facial palsy. Her OBGYN history was uneventful. On 4th day of admission, she had pain, swelling, and redness of both lower limbs, despite being on low molecular weight heparin and antiplatelets. On examination, she had right side power of 3/5. Right ulnar pulsation was absent. Bilateral lower limb edema up to thigh, as shown in this figure. Her investigation showed COVID RT-PCR positive, NLR more than 3.5, platelet count normal. Thrombophilia profile was negative. Her sickling test was positive, showing AS pattern, that is sickle cell trait. Her acute phase reactants were raised. LFT was deranged, only enzymes were raised, except, but her INR was normal. Renal function test was normal. Her CT thorax showed thrombus in pulmonary artery and infarcts in spleen and kidneys also. And her MRI brain showed lacunar infarcts. Her bilateral lower limb venous Doppler showed superficial vein thrombophlebitis with DVT, as shown in this figure. There is a thrombus in the great saphenous vein. Her ECG showed sinus tachycardia, STT changes in inferior lids.
Please conclude.
Was normal. To conclude, our patient, both our patients were young, had no previous comorbidities, no predisposing factors for superficial thrombophlebitis. Timing of onset could be variable. Early onset is more common. Doppler ultrasound screening program needs emphasis in the hospitalized patients. And in literature, we found just 2 cases of superficial thrombophlebitis, that 2 unilateral, one in 62-year-old and one in 40-year-old. And both our patients had good clinical recovery with partial resolution of superficial venous thrombophlebitis, and they are still under. To conclude, my bilateral cases of superficial thrombophlebitis in COVID-19 are rare. Sickle cell trait has twofold increased risk of pulmonary embolism compared to the normal hemoglobin. We need to screen for common coexisting factors like prevalent in our areas like sickle cell, which we did in our cases. No guidelines for treatment of superficial venous thrombophlebitis is present in COVID-19 till date, and follow-up needs to be individualized. Longer follow-up is needed, and emphasis on variable atypical presentation of COVID-19. Thank you.
Dr. Shweta, over to the judges.
Yes, sir.
Yeah. Dr. Shweta, we all know that thrombosis is a common complication in COVID-19. What is the aim of presentation of these two cases? And why did you, one more question, why did you go for thrombophilia profile?
Ma'am, actually, both our cases were young. First case, he just presented with superficial venous thrombosis. No other, no other complication, no other comorbidities or predisposing factors for superficial thrombophlebitis, and that too bilateral. And second was a female patient. Actually, she was transferred from some other hospital. She presented there with just hemiparesis. So they evaluated her for thrombophilia. They applied, and everything was ruled out. And when she came to us, we did her COVID test, which came out to be positive.
Yeah, unusual thrombosis, rare thrombotic complications, they are known in COVID.
You can present at the end of Darshana.
Yes, sir, but yes, ma'am, but in literature, very few cases of superficial thrombophlebitis are reported. So, and that too unilateral are reported. Here we have, we both our patients had bilateral superficial thrombophlebitis. So that was something which was never seen before.
Yeah, and contribution of sickle cell to the superficial thrombophlebitis.
Darshana.
Yes, ma'am, that is also very rare. Sickle cell trait has twofold increase in risk of pulmonary embolism. So that could be an additive factor for thrombosis with COVID.
Yeah, thank you.
Thank you, ma'am.
Thank you, Shweta.
Thank you, sir.
Any questions? Go ahead, Dr. Gyan.
No, thanks.
I'm sorry to interrupt. Hello, Dr. Gauri Arora here. I'm sorry to interrupt. We are running very, very late. I will request the judges to please ask just one question. Otherwise, we will be taking the session after the oration, madam.
Okay.
I'm so sorry about it, but we are really running very late. So please ask just one question, ma'am.
Dr. Darshana. Dr. Darshana.
Good afternoon, one and all.
Please share your screen, Dr. Darshana.
Am I audible?
Yes, you are audible.
Yes. Is my screen visible?
Yes, yes, you can start the presentation.
Yes. I am Dr. Darshana Bhosle, GR1, Pediatrics. I am presenting a poster on late onset of familial HLH, where immune system is running amok under the guidance of Dr. Girish Nanoti sir and Dr. Snehal ma'am. My case is a 7-year-old female child, second issue of third degree consensuous marriage, who came to us with progressive complaints of high-grade fever, difficulty in breathing, and cough since 6 days. On examination and detailed laboratory workup, it was found that she had extensive pallor, splenomegaly, hepatomegaly. There was pancytopenia on peripheral smear and CBC. Her serum ferritin levels were raised, serum triglycerides were raised, X-ray and CT changes showed left-sided pneumonia. Bone marrow aspiration showed hemophagocytic lymphohistiocytosis. The probable diagnosis now was left-sided pneumonia with probable HLH. The treatment was done. Injection methylprednisolone, 500 mg IVBD for 5 days was given. A complete course of antibiotics was given. Hepatosplenomegaly was regressed. There was no fever. CBC was improved. We decided to give discharge to the patient, and she was put on the maintenance therapy of tablet cyclosporin, 5 mg per kg per day for 6 months. But the patient discontinued cyclosporin on her own will. Later, she experienced discomfort. She came to us with high-grade unresolving fever. There was a relapse of HLH. Patient was again admitted. Detailed workup was done. It was found the same laboratory workup was done. Now, the idea of gene therapy came in our minds. The exonic sequencing was done. It was found the mutant gene was UNC13D gene. Now, the conclusion was the patient had familial HLH type 3. This was the late onset of familial HLH, which was possible because of exomic sequencing. The treatment was done according to the HLH 2004 protocol, which is dexamethasone, which was done in tapering doses from 10 mg per kg meter square, 5, 2.5, 1.25, and tapered to 0 dose over the 8th week. She was put on a maintenance therapy again on tablet cyclosporin. Our plan was to start etoposide, but the patient went to higher center for hematopoietic stem cell transplant. So the take-home message is that hemophagocytic lymphohistiocytosis workup is possible and treatment is definitely possible. Thank you.
Thank you, Dr. Darshan. Over to the judges.
Yeah, that's a nice case. Thank you. I have no questions to ask.
Any questions?
What are the usual clinical features of HLH?
The usual clinical features are fever, hepatosplenomegaly, which can present with as abdominal distension. Patient will be weak, extensive pallor will be seen.
Okay, thank you.
Thank you, sir. Thank you, ma'am.
Okay, thank you, Dr.
हो मॅम झालं जस्ट झालं जेवत होते हा मॅम ठीक झालं हो जेवत होती मॅम अमोल सर आहेत अमोल सर म्हणाले की
Am I audible?
Yes.
Good afternoon, everyone. My topic of presentation today is a fractured tracheostomy tube migrating into the tracheobronchial tree with intact airway, which is quite unusual presentation, a case report. A tracheostomy, it is a common airway procedure for life support. Approx 20% of the patients with tracheostomy, they are discharged from hospital with the tracheostomy tube in situ, as was our patient. And the fracture of the tracheostomy tube with aspiration into the tracheobronchial tree is one of the rarest complications reported, and which can be potentially life-threatening, demanding a timely recognition and prompt intervention. Our patient, who was a 13-year-old female, she had been tracheostomized for about 9 years. She presented to the emergency department with just a vague complaint of a swelling and discharge from the tracheostomy sites since 4 to 5 days, which was quite insidious in onset and progressive. There was no history of difficulty in breathing. The indication of tracheostomy, it was subglottic stenosis, and since then she had been in follow-up for the initial 4 years, and later she used to do the self-cleaning as advised by ENT clinician. The current tracheostomy tube, it had been in use for 9 years, and on arrival the patient was completely normal with regard to vitals. Her systemic examination revealed no signs of respiratory distress. As a routine investigation, she was advised a chest x-ray, and which revealed, surprisingly, there was a cylindrical foreign body noted in the right tracheobronchial tree. So as our patient had no respiratory distress, so she was immediately taken for emergency HRCT thorax. As you can see, the axial, sagittal and core image, they are showing the displaced tracheostomy tube. There is a main tube which is in the trachea, and there is again another tube which is seen caudally to it in the right tracheobronchial tree. But you can see there is an adequate air column across the end of the fractured tube. There are no signs of consolidation and collapse. So the management, she was immediately transferred to OT room for bronchoscopic removal under GA. The foreign body, which was the distal tube of the tracheostomy tube, it was retrieved from the right main bronchus and removed through the stoma. The fracture, as you can see at the junction of the neck plate and inner tube, it was seen. So the patients of tracheostomy, they require a high degree of vigilance, although the incidence is low, but a high risk of mortality is associated due to severe airway compromise. Many times the tube get suspended in the trachea, or it might even displace cranially due to the active force generated by cuffing. So the major factors here, you have to consider the extent of the dislodgement, the need for resecuring the airway. The role of imaging here commences when the patient is rendered free from respiratory distress and airway is secured. It is essential to maintain a strict vigilance about the care of the tracheostomy site. The imaging, no doubt, is of paramount importance. Thank you.
Thank you, Ashwini. Over to the judges. Any questions from the judges?
No question.
Yeah.
Under which conditions can this tracheal foreign body lead to collapse?
if it get lodged in the bronchus, so there are high chances of collapse. But surprisingly, it was hitherto to our knowledge that our patient did not presented with any lung collapse.
Okay, so the main reason was there was no mucus secretion here or mucus
Yes,
impaction.
impacted mucus plug.
Yeah. Okay.
Yeah. Thank you, sir.
Thank you, Dr. Ashwini.
Hello. 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 May I interrupt, please?
Yes.
Myself, Dr. Avinash Vase. I am chairman of the scientific committee. So, respected judges, there is a small request from my side. The problem is that we are already running more than 1 hour late, and we have many respected faculties. They are waiting in line, and we have oration also at the end of this. So, can we finish the rest of the papers after 6 o'clock? Because all other speakers, they have spared that much time and they are waiting since almost 1 hour. So I would like to end the session here only, and we can resume after 6 o'clock. It is very difficult to finish another 18 to 20 papers now. So it is my sincere request, and please consider that.
Fine, sir.
Sure,
Okay.
sure, sure,
Okay, no
sure.
problem.
Okay, it's okay, sir. Yeah.
Yes, yes. So that we can proceed for the next. Thank you very much. Thank you very much, all the participants, all the judges, and we will get back to you at 6 o'clock once we are over with the oration. So please consider. Thank you very much. Hello, coordinators, please.
Sir, we have a request from Dr. Bhavini Pathak. She says that she has COVID duty, so if she can present now.
Okay, take just her paper. So, sir, Vase sir, please allow just her paper. Because she had earlier also requested that she has COVID duty. Just allow her paper.
Okay.
Sir. We can stop after that. Okay.
Hello, ma'am. Am I audible?
Yes, you are audible.
Thank you for allowing me to present.
Share your screen.
Yes. Okay, so we had a case of a female. She presented with abdominopelvic mass, and on radiological examination, it was suggestive of neoplastic etiology of ovary. However, on histopathological examination, we found out it to be a broad ligament leiomyoma. So I present to you this
ते करतो ना मी सगळं मला सांगितलं दीपाली ओके सर्टिफिकेट तर
leiomyomas are leiomyomas are benign tumors of female genital tract with uterine. Hello. Leiomyomas are benign tumors of female genital tract with uterine leiomyoma being the most common. Leiomyoma of broad ligament is extremely rare, having incidence of less than 1%. Case report: 49-year-old female came with chief complaints of pain in abdomen and severe dysmenorrhea since 4 months. She had 2 full-term normal vaginal deliveries. Her menstrual cycle was regular. Abdominal examination revealed a firm mass arising from the pelvis corresponding to 18-week size. On per speculum examination, the cervix and vagina were healthy. On per vaginal examination, huge mass was palpable, occupying whole abdomen. Uterus was not paired separately. Investigations: CCT abdomen and pelvis revealed lesion arising from right adnexa and occupying pelvic region, most likely suggestive of neoplastic etiology of ovary. USG was suggestive of an abdominopelvic neoplastic lesion arising from right adnexa. USG guided FNSE was suggestive of mucinous epithelial neoplasm of ovary, while cytology pap smear revealed inflammatory smear. Total abdominal hysterectomy with bilateral salpingo-oophorectomy was done. The specimen was sent for histopathological examination. This is the gross specimen. We received a solid cystic mass arising from broad ligament, total measuring 15 by 12 by 4 centimeter. On microscopy, sections from broad ligament mass revealed intersecting and interlacing fascicles of closely packed spindle cells arranged in whorled pattern. These are the microscopic pictures. As we can see, microscopically spindle cells can be seen and interlacing and intersecting fascicles of these cells are visible. Result, cellular leiomyoma with extensive cystic change. In discussion, the differential diagnosis for broad ligament leiomyoma are masses from ovarian origin, benign or malignant, broad ligament cyst, lymphadenopathy, and tubo-ovarian masses. In our case, on clinical and radiological investigation, it was suspicious of neoplasm of ovary. Conclusion, broad ligament leiomyomas mimic ovarian tumors on clinical and radiological examination, and they should be kept important differential diagnosis for such solid agenexial or ovarian mass. The diagnosis of broad ligament leiomyoma is difficult on clinical and radiological features due to its rarity and unusual presentation. It is thus very important for the histopathologist to diagnose it. Thank you.
Thank you, Dr. Bhavani. Over to the judges.
No questions. Thank
you. Dr. Gyanshankar.
Yeah. How frequent is this condition normally?
So this condition, broad ligament leiomyoma, this incidence is less than 1%. However, there are various types of leiomyomas, and in that category of cellular leiomyoma ranks the least incidence of cellular leiomyoma is there.
Thank you.
Yes, sir. Thank you, sir.
Thank you, Bhavani. You can stop the share screen.
Yes, sir.
For the rest of the contestants, I've said by Dr. Avinash, so we will be joining after 6 o'clock. A message will be posted by either me or Dr. Devani on the group. Accordingly, kindly join for the remaining paper or for the remaining posters.
Am I audible?
Yes.
Can I start my screen share?
This Dr. Should we allow one more poster?
The previous candidate has to.
We'll have just. Is the screen share available with you?
Can I begin?
This is Dr.
Can I begin, sir?
Devani, should we allow this paper?
Hello.
Is it after?
Hello.
Devani?
We must ask Gauri ma'am, sir.
Is this Anupama or this is Rasika?
Hello. Am I audible?
Yes, you are audible. Please go on.
Is it allowable? Because
Good afternoon, everyone. And thank you.
A minute, just a minute, please. Dr. Sumer, would this be the last presentation? This is Dr. Shilpa.
Yes, that's what I was confirming. Anupama, can you just let me confirm with the organizers whether they will be allowing one more paper after this, or this is the last paper before for a break?
So it will be a kind request if you let me present it.
Sumer, let us go ahead with this just one presentation and then we can stop if everybody agrees.
because Dr. Rakesh is giving messages again and again that she also wants to present.
Or else postpone the session. Postpone the session, as Dr. Vasi said. Please take a call.
Okay, we'll allow this
behind the schedule. Therefore, we have postponed the session to the evening one. As per now, Dr. Vase sir had just said, we are going to shift this session because we have the speakers waiting and we have an oration also. So it's a kind request for you to all to please bear this with delay because we have our eminent speakers waiting, and we would be shifting this session in the evening around 6 o'clock. So we would be preferably starting the new session. Okay, sir?
Dr. Anupama, kindly bear with us and we'll join after 6 o'clock.
Yeah, it's a kind request to all the participants also. Please bear with this delay because we are running very much late by. And we would be preferring to start the new session. So, good afternoon, respected teachers, seniors, and dear friends. Myself, Dr. Prajakta Berde, along with Dr. Kasturi Prasad, welcome you for this annual academic extravaganza of IMA Nagpur NIMACON 2021. I hope we are on the virtual platform, and I am sure that this NIMACON conference will be a unique event in itself, which will serve the platter of academic feast for everyone that will fulfill the satiety of knowledge. So we welcome you to NIMACON 2021, the Festival of Learning.
It's immense. Due to unavoidable circumstances, the speakers of the first two lectures are unable to join us now and may join later. So we have rescheduled the lectures. We'll be having the talk by Dr. Bharat Vaswani. I now will take immense pleasure to invite our chairperson, respected Dr. Y.S. Deshpande, Deshpande sir, past president, IMA Maharashtra State, guide, philosopher, mentor to us. He is the backbone of IMA. Sir, words fall short to say something about you. We are honored to have you with us. Our chairperson is Dr. Sushil Mandania, Director, Mandania Cancer Hospital, and senior most practicing DM oncologist of Central India. Fellowship in Adult and Pediatric Oncology from Tata Cancer Hospital. Member of American, European, and Indian Society of Oncologists.
Over to the chairperson, please.
Hello.
Still, you need to unmute yourself.
Yeah, can you hear me now?
Now you're audible.
Yeah, great.
Hello.
Should I start?
Yes, sir.
Yeah. Welcome, Bharat.
Hi,
and thanks to the NIMACON team for such an excellent webinar, and that too in the time of such a big COVID scene. And second thing is I enjoyed this paper presentation, which were very good papers. Unfortunately, because of the time, we could not continue that. So straight away moving to the today's first lecture by Dr. Bharat Vaswani, that is Advances in the Diagnosis, Personalized Approach. Bharat is my colleague. He is from GMC Nagpur. He is MBBS and MD from GMC Nagpur, and he did his DM from GCRI Ahmedabad. And now he is a senior practicing consultant, medical oncologist at Hyderabad. Bharat, please go ahead.
Two most important questions. Am I audible and are my slides visible?
Both, yes.
Yeah. So thanks, Chairperson, for the kind invite. I will thank IMA Nagpur for this invitation. The topic that I am discussing today in the next 13 to 14 minutes is what are the advances in diagnosis and treatment, and how we have approached our treatment, or how we have personalized our treatment. So my first question to everyone is, why should every doctor know about cancer at this moment? So when you look into the epidemiology of cancer, it is the leading cause of death all over the world, along with cardiac disease. When you look into the latest data in Globocon, around 2 crore new cancer cases were diagnosed in 2020. Unfortunately, 1 crore people died of this disease. And when you look into the latest statistics, this looks frightening. 1 in 5 will develop cancer in their lifetime. More importantly, 1 in 8 male and 1 in 11 female will die of this deadly disease. And when you look into the mortality pattern in India, 9% of all deaths are due to cancer. So it is high time that we should know about these rapid advances in diagnosis as well as management, so that we can treat this deadly disease more effectively, leading to better cure and or survival. My second question to everyone: what exactly have changed in the management of cancer? So the entire concept has changed now. The older concept of world treatment fits all has been replaced by what we call as personalized therapy, that is tailoring cancer treatment to patient. You don't treat cancer accordingly singly in every patient, but you treat every patient in different ways depending upon the mutation status. Two of the common examples I'll show you. One of my patients, carcinoma lung with brain mets in November 2010. She is Miss India celebrity. Unfortunately, was diagnosed with brain mets, as you can see on the right side. Luckily, in those times where in 2010 we had a PCR test and we could diagnose a new mutation, that is an exon 19 deletion. This patient was started on the tablet erlotinib. This patient is still surviving for 11 years without any problem. A last stage of lung cancer on 11 years without a disease is nothing but a miracle. Unfortunately, this patient stopped treatment after 8 years because she thought unnecessarily she is taking tablets. Again had a relapse, again got that mutation positive, again started on tablet, and she is cancer free as of 11 years from now. One more example of how the treatment has worked. A gastroesophageal junction cancer who relapsed very early after surgery. There was no much treatment available. If this would have come to me 2 years back, I would have not given him anything. But luckily, due to this NGS technology, found out to be mismatch repair deficient, we did a IHC. This is a new tumor marker we have done, and that was positive, and this was started on a new treatment option now, immune checkpoint inhibitor. If you can see on the left side, there are black dots. Within 4 cycles of chemo, everything disappeared. This patient is hail hearty for the last 8 months because of why? Because we found out that targetable disease and we gave a new option of treatment that is called as immunotherapy. So this is the way we are approaching our patient based on how it is. So this advances or this personalized treatment is mainly possible because of advances in diagnosis. Now, which is the most important diagnosis? That is called as next generation sequencing. The thing speaks for itself. It is sequencing of DNA or RNA in a cell, because what we know is cancer in one person is different from cancer in other person is because of the unique mutations in that person. If we can find out what are these mutations, now we have tablets and injection which can kill those cells with the mutation. As for example, if you see in the case 1, we had exon 19 deletion, and now we have an oral tablet to control it. In fact, many of my patients are surviving for more than 5 years in a disease where 1 year survival was a luxury. The second advances is if you see the lung cancer, before it was one disease, now we have divided lung cancer in 10 different diseases. So every patient is treated differently based on what mutation has come out in lung cancer. And if you mind, there are so much advances and there is so much prolongation in survival, and we are getting what we call as a chronic disease. Now, what is the advantage? We can assess genome better. We can find out new drugs based on the mutation, which will help in treating this cancer better leads to better survival or cure also. The second advances is a question: can we avoid solid organ biopsy? So the answer is yes. Nowadays we are going what we call as a liquid biopsy. So a liquid biopsy is defined as test done on blood irrespective of solid tissue based on the concept that these cancer cells are circulating in the blood or their DNAs are present in the blood. By this way, we are early. More importantly, when we know the mutations, we can target those mutations accurately. For example, if you ask a patient to do repeated biopsy, they may not do. But based on this concept, we can monitor disease better. More importantly, if there are new mutations, we can treat the disease accordingly. So liquid biopsy has helped in our management immensely. The third thing is, can we diagnose cancer early and more accurately? So here comes the concept of what we call as a PET-CT scan. PET-CT scan is based on the principle of fibrodeoxyglucose, which is taken up by the cancer cell due to its higher metabolism early. So if you can see these black dots, these are cancer cells which has taken up early. The advantage of having this is earlier diagnosis, early treatment leading to better and or prolonged survival. So based on this, the advances in treatment are, in the older days, we had what we call as conventional or cytotoxic chemo. That has evolved now to the concept what we call as targeted therapy and immunotherapy. The world has changed upside down with this immunotherapy. Now, can anybody correlate these three pictures which was famous? A World Trade Center, a famous partnership of Dravid and Lagan. These three events occurred in 2001. And in 2001, we had the first targeted therapy on that deadly disease called as chronic myeloid leukemia, a drug called as imatinib. In fact, it was Time's discovery of the year, the magic bullet. This was the first targeted therapy, and over the last 21 years, we have around 100 or more targeted therapy. Just look into the left-sided lower diagram, a cell. Now, we know that in cancer, there are abnormalities in genes, proteins, or blood vessels. So if we have a drug which can target these genes or proteins or blood vessels, this can help in killing tumor cells better. More importantly, only the abnormal cells will be killed, and that is what the concept of targeted therapy has involved. So three targets we are looking at: abnormality in cell receptor, example in lymphomas. The second most and the most important, you remember that gefitinib drug or erlotinib in lung cancer. There are multiple cancer which has a problem in this tyrosine kinase, and now we have newer tablets based on that. And the third target is mTOR inhibitor, which we are also using in kidney cancer, mammalian target of rapamycin. So you see, based on novel target and their abnormalities, we are having repeated drugs. The second concept in targeted therapy is a cancer needs new blood vessel formation, and that is done by secreting vascular endothelial growth factor. So if we have a drug which targets this vascular endothelial growth factor, that will help in killing the tumor cell better. In fact, this anti-VEGF is also used in ophthalmology, retinopathies of. So this drug has multiple uses apart from oncology, but combining with cancer drugs, these targeted therapy helps in prolonged survival. So the third concept is intraoperative chemotherapy, chemo given by surgeons. Now there are some cancers like pseudomyxoma peritoni and appendicular mucinous cancer. Chemo does not work. So these are where the surgeon itself gives the chemotherapy in the operation theater.
I think we have lost the connection of
I think we are not hearing it.
Maswani. I'll just try to contact. Yeah, he's back.
Madam, where did we use me? Madam, what was the last slide?
Yeah, please change.
Was this slide over?
Yes, sir.
Yeah, this was over.
Yeah,
Intraoperative chemotherapy.
To continue this.
Yeah. So the concept or the third concept is intraoperative chemo. Am I audible, madam? Hello, am I audible, ma'am?
Yes, sir. Yes, sir. You're audible.
Yeah. So the new concept of chemotherapy that we have evolved is intraoperative chemotherapy. So chemotherapy in the operation theater following surgery. Now for resistant tumors like mucinous carcinomas of ovary and in appendicular cancer, this is the way we are giving in operation theater only we are giving chemotherapy because it helps in better control of cancer cells. Can anybody tell me who are these two famous persons? James Ellison and Tasuku Honjo. These were the pioneers of what we call as the newest technology, what we call as immune checkpoints inhibitor. In fact, this was the treatment of the year 2014, and based on this work, they were awarded the Nobel Prize. Now, the basic principle is a T cell in the body should kill tumor cells. But because of immune checkpoints, they are not able to kill tumor cells. So now we have a mechanism where we have a drug which can remove these checkpoints in the cell, and the T cells are able to kill tumor cells better. So a therapy which utilizes the body's own T cells is a new mechanism of treatment, and I have shown you one diagram. This is a drug which is based on this principle. So there are two groups of drugs, anti-PD-L1 and anti-CTLA. In fact, this is the treatment of choice on most of our cancers now. For kidney cancer, liver cancer, head and neck cancer, lung cancer. This immunotherapy has taken over the cytotoxic chemo along with chemo, or as a single agent, this has become a treatment of choice, the concept of personalized therapy in a very big way. And this is the most exciting thing in oncology, a gene therapy. In fact, in 20 years, you will see every cancer or most of these cancers will be treated with these therapy only. There's two cancers where this has evolved is ALL and myeloma. What we do is blood is taken out from the body. They are modified in the laboratory by adding chimeric antigen. They are grown in the laboratory in millions of cells and are reinfused in the body. In fact, in two of the cancers now in US, this has led to 90% cure rates in those cancers which have not responded to any treatment in the world. So probably the future of oncology is a CAR T-cell therapy, and in a decade you will see most of the cancers is being tried with this new form of therapy. The last advances was vaccines. Can we prevent our cancer well? The answer is partly yes. Now in second deadly cancer in female, that is cervix cancer, which is caused by human papilloma virus, we have a vaccine which we should vaccinate all our females less than 25 years of age. In fact, that will reduce cervical cancer by 90%. And in June, we will be having Gardasil 9. This is probably the thing we will be getting next month. So 95% HPV protection, probably going on a very long way in controlling this I can call it incurable but a highly morbid second common cancer in female. So if I have to summarize the advances in diagnosis and treatment, the recent advances in cancer treatment has made the cancer treatment more personalized. We have newer drugs, we have monoclonal antibodies, we have tablets which include tyrosine kinase, and the most important is immunotherapy. But more importantly, we are choosing our patient rightly based on molecular alteration, based on our NGS test. I am always optimistic in cancer. You should never get pessimistic. And in a decade, you may see newer advances, probably making this incurable disease, metastatic cancer, as a cancer disease where we can make it as a chronic disease. I thank you all for a patient hearing. Thanks for a nice hearing.
Prajakta, can I speak?
Sir, please.
Yeah. It was a nice, lucid talk by Dr. Bharat Vaswani, and it is always informative and interesting. Last year also we heard him on some different topic of cancer. Our session got delayed, and the positive part of that, if we look at it, the academic interest has gone so much that there were a lot of paper presentation, and I'm honored to be chairperson along with Sushil Mandania, the eminent oncologist from the city. Cancer is a mysterious disease, as was always, but there are a lot of changes which we can observe during our post-graduation. Radical mastectomy was there. Now we have come to PCS, and then we talk about gene therapy, as Bharat was mentioning, and so many advances are there. The diagnostic modalities are also there, but at the same time, early diagnosis and the proper treatment, complete treatment, is the hallmark for the success of the treatment of cancer. And as we say that the research is going on so well, and every day we are coming out with something. As Bharat was mentioning about the vaccination for cancer, just 2 days before only I read it in the newspaper that they are coming out with some vaccination, and that was the news from United States. And it will not remain limited only to the cervical cancer, but vaccination would also be available for the other cancers. We hope in the due course of time that will come. And cancer, for many of the cancers now, the cancer can be cured with the tremendous comprehensive treatment which we are offering. And the chemotherapy and the radiotherapy and surgical therapy, immunotherapy, psychotherapy, and all that, they are working in cohesion together, so that we are giving such positive results in the treatment of cancer. And we hope that more and more positive results will come in due course of time. Thank you so much, Bharat, for your wonderful presentation. And I am sure audience is benefited to a great deal. And I, along with Sushil, I think we would close the session here, because we are already running short of time. And if there are some questions, you can put it in a chat box, so that Bharat would be most happy to answer that. Am I okay, Prajakta?
Yes, sir. We would be entertaining the questions later on, because we are very much going back behind the schedule. Yeah. Thank you, sir. Thank you, Dr. Vaswani. Thank you, Deshpande sir and Dr. Sushil. Dr. Vaswani, please accept the memento from Team NIMACON for the wonderful rendition.
Thank you.
Yeah. So now we move on to the next session.
We
have one announcement. Thank you. We have one announcement.
I have an announcement to make. Because of time shortage, we had to interrupt the poster presentations. We will resume, because we had to resume the scientific sessions. I request the participants of poster presentation to kindly log in around 6 p.m. after the oration.
Thank you so much. So now we are moving on to the next session. And for the next session, we have the chairpersons. A respected Dr. Anand Katesa, the renowned physician, former president of IMA Nagpur, and the chairman of PPS IMAMS. Along with him, we have Dr. Sanjay Ambadkar, sir, director of Kalpavriksha Hospital, executive member of IMA since 20 years, and past president of Rotary Club of Nagpur Green City. Over to you, sir.
Thank you, MOCs. Let me congratulate the organizers of NIMACON 2021 and also the scientific committee, Dr. Gauri Arora, Dr. Dinesh Chakrawal, Dr. Archana Kothari, and Dr. Savar Bande. A wonderful conference is being arranged, though in spite of a lot of limitations of being online and virtual. Let's move on to the lecture by Dr. Nirmal Jaiswal, who would be speaking on immunomodulators in sepsis. Dr. Jaiswal doesn't need any investigations. He's a renowned critical care specialist of the city, a very senior practitioner, and being a very renowned or a name to reckon with in the management of COVID pandemic in the city. He will be talking to us about the immunomodulators in management of sepsis, which is also quite an important in management of COVID also. So with these few words of introduction, I will hand over the mic to Dr. Nirmal. Please unmute yourself, Dr. Nirmal Jaiswal.
Yeah, thank you, sir, for your introduction. I would like to thank organizer of NIMACON for organizing such a very beautiful academic session. Otherwise, till today, what we were discussing only corona and corona only. But because of the Gauri Arora and Agrawal's team, I think we have got a different aspect of the medicine also as well. That's the reason I think a lot of people must be attending this conference. Thank you very much again. Coming to the most important topic. One second. My screen is visible, sir?
Yes.
Yeah.
Yes.
Coming to the very, very important topic, like sepsis. Sepsis is going on since decades together. How to deal with sepsis? Because we also have it is almost like a fifth cause of the death in our globe, as far as the death rate is concerned. So till today, we have not conquered the sepsis. Nobody, very less patients are going home when the patients land up in the multi-organ dysfunction syndrome. Sepsis is definitely a complex disease and life-threatening syndrome induced by the dysregulated host response to infections. The inflammatory process plays a very, very major role in pathogenesis of the sepsis and leading to the septic shock later on. Why this is happening? This is happening just nothing but because of the overwhelming response of the inflammation in response to the infection, which lead to the SIRS, that is a systemic inflammatory response, and which may further culminate into the multi-organ dysfunction syndrome. This crucial aspect of this pathogenesis of the systemic inflammatory response and the multi-organ dysfunction syndrome is very, very important, because here you are supposed to act very fast. If you will just overlook this particular phase of the sepsis, then definitely the patient will land up in the multi-organ dysfunction syndrome, and most of the time it is an irreversible process. So that's the reason the patient should be monitored very well as far as the investigation parameters are concerned and the clinical findings of the patients are concerned, where you are supposed to interrupt, or you are supposed to play a major role in preventing the further deterioration of the patient. Why this is happening? This SIRS is nothing but the release of the cytokine in the body because of the sepsis, because of the bacteria which is present in the bloodstream. So this sepsis is also been called as a cytokine release syndrome, or maybe cytokine storm syndrome. So this terminology came in 1991, that is cytokine release syndrome, which was introduced by Algri et al. In experimental models of the hyperinflammation. But in 1993, this cytokine storm, this has been first introduced by Ferrara et al. On the effect of the interleukin-1 on the graft versus host defense after the transplantation of the organs. So in the following years, the same continued, particularly in the GVHD remained, that is growth versus host disease, remain a main area of the concern and the term. And in 1996, Aikawa was the first author to describe this particular terminology, that is the cytokine storm, as the key pathway to multi-organ dysfunction syndrome because of the sepsis, particularly in the post-op patient. So later on, the multiple articles have followed later on, and other clinical syndromes were brought to the notice in the context of the cytokine storm and the CRS leading to the multi-organ dysfunction syndrome, particularly not only in the area of the bacterial infection, but it has also come in the process of the pathogenesis of the viral infection, or maybe hemophagocytic lymphocyte histocytosis, or multiple sclerosis, pancreatitis, or other inflammatory disorders. The specific effect of some bacterial toxins on the host response regulation, including the cytokine storm, which lead to ultimately the septic shock. And the septic shock is nothing but the first step of going for the multi-organ dysfunction syndrome. If you see what happens to our immunity when the patient gets the sepsis. This is a sepsis where you get it. If you have the immune hyperactivity because of the sepsis or because of the bacteria which is coming in the body because of some different reasons, it damages from the inflammation. And if your immune response is not proper, or if it is suppressed, or it's suppressed because of the sepsis itself, then the patient can lead to the more vulnerable opportunistic infection. So when the sepsis continues, and when patient don't get the proper treatment, the patient go for the organ failure, and almost it causes the early death. But sometimes, most of the times, when the patient comes to the hospital and get the treatment, proper treatment, under complete vigilance of the physicians and the critical care people, in that scenario, patient can recover very well with the proper diagnosis and treatment related to the diagnosis, and patient goes home. But sometimes what happens, because of the cytokine storm, the late death occurs, maybe because of the recurrent infections, continued organ injury, or maybe the septic shock leading to the poor tissue perfusion that lead to the death at the end of the journey of the patient, for which the patient got admitted. And when you have got a oncology patient, what the Bharat was talking about is they usually have the immunosuppressed. They are usually immunosuppressed. And this immunosuppressed state can give rise to the dysregulation of the immune system and ultimately lead to the opportunistic infection. And that also cause the death. What are the changes observed in the cytokines levels during this sepsis? Is something like cytokines may vary according to the heterogeneity of the disease background. The cytokine assay by multiplex array in burn mice, which has been seen in the previous trials, and we showed the susceptibility to sepsis, that there are some interleukin family, that is interleukin 1 beta, interleukin 6, interleukin 17, and so on. Also the gene GCSF, GM-CSF, and so on, which regulated on the activation of the normal T cells expressed and the secreted from the cells, respective cells. And the TNF alpha were increased during this, particularly people who had done the study on the bone mice. Same thing has happened. The IL-2, IL-3, and IL-3 were decreased in those patients. IL-10 and interferon gamma and IL-2, IL-12, P70 were expressed in the biphasic manner. But here the interleukin family has plays a major role as far as the cytokine storm is concerned. The multiplex analysis evaluating the plasma levels of the 17 cytokines were observed in this patient with a severe sepsis, where the concentration of the interleukin family were topping the list along with the TNF alpha. So distinct cytokine profiles were associated with the severity of the sepsis, evolution of the organ failure, as well as the which is leading to ultimately the death. This is the changes what we have observed. These are the changes we observed in the cytokine levels. Again, the first 7 days, what we have observed is when the patient is getting the sepsis, there is on the first 2 or 3 days, the IL-6 levels were very high, and gradually after the treatment, who has responded to the treatment, the interleukin levels were gone, IL-6 levels were going down. Same thing, the TNF alpha also behaved. But in non-survivor females, the TNF alpha were very low. The IL-10 paralleled the sepsis score. These are the different scenarios where we face in day-to-day life in the critical care units. It's influenza, what we already face, H1N1, we already face SARS and the MERS, where the interleukin as well as the TNF alpha plays a major role, which has been proven by the lot of literature. This causes the multi-organ dysfunction syndrome or the septic shock and ultimately the death. If you just observe the different levels of the IL-6 or TNF alpha or IL-8 in the different scenarios, in COVID-19 with ARDS, the TNF alpha remains on a higher side. The sepsis is topping the list in TNF alpha. The sepsis with the no ARDS, the TNF alpha goes down, is lower as compared to the sepsis with ARDS. The outside the hospital cardiac arrest, again the TNF alpha rises. In trauma also it rises. The same thing happens with the IL-6 and IL-8 also as well. So what is this cytokine? How it generates in the body? Whenever there is a bacteria introduced in the body, where there is it causes the induction of the TLR signaling, that is the toll-like receptors, which with these bacterial endotoxins such as it binds with the TLR, and there is the activation of the small guanosine triphosphate that is GTPase, RAS-related C3 botulinum toxin substrate, and then there's the activation of the C-Jun terminal kinase, NF-kB, and the AP1. And these all lead to this massive cytokine production in the sepsis. So the genetic polyformism plays a major role in the sepsis. The role of this individual's genetic background and the predisposition for the extent of the inflammatory response is determined by variability of the genes encoding endogenous mediators that constitute the pathway for this inflammation. So the pro and anti-inflammatory responses contribute to the susceptibility and the outcome of the patient with systemic inflammation and the sepsis. So polymorphism of TNA alpha, TNF beta, IL-10, IL-6, IL-1 beta, IL-1 RN, all this has contribution to the susceptibility and the outcome of the sepsis in some research which has been documented by the research. So impact of the single cytokine target oriented therapy has been tried on so many patients. So where in those patients where the severe immune dysregulation is the prominent hallmark of the sepsis, as everybody knows, rendering the disease biologically complex and consequently a challenge to the treatment because of this system. The multiple single target oriented approaches have been employed for the treatment of cytokine storm in the sepsis in the last few decades, but none of the immunomodulators have been proven to be consolidated option to deal with the inflammatory response. And that is the reason why we cannot conquer this sepsis related multi-organ dysfunction syndrome in some few patients. So that's the reason every 1 decade or every five years, some new molecule comes, and we are sometimes dependent on other new molecule because we already tried the previous molecules where we could not get the good responses as far as the control on the sepsis related multi-organ dysfunction syndrome, and we go on trying these molecules. So these are some list of the cytokine targeted oriented therapy. The LPS enterotoxin, these are the molecules where people have tried in different trials. But even the methylprednisolone, vasopressin, activated protein C, which was once upon a time was topping the list in controlling the sepsis related inflammation or the cytokine storm, but it has been just first trial has been shown that there is no benefit on this. On the contrary, the people were having a lot of mortality in that particular trials. Again, cytokine targets is anti-alpha, anti-TNF alpha, IL-1 receptor antagonist, soluble TNF alpha receptors. They've all been tried. Even the nitric oxide has been tried, but nothing has. Even apoptosis, that is the caspase inhibitors, which is one of the hallmark for the producing the cytokines. They have also been tried, but at the same time, it has not been shown any promises. Some people get the response, some people doesn't get the response. At the end of the trials, it has been nullified. There is no reduction in the mortality at the end of the journey of the patient. What is needed is basically when you see the cascade. I have not put the slide of the cascade of the sepsis. There are n number of cytokines which causes the damage to the different organs by different pathways. So what is needed is definitely a multi-target approach, not a single target. When we target the single target to reduce the inflammation, but other cytokines are still open to cause the multi-organ dysfunction. So what we need is a multi-targeted approach. So experimental drug therapies for sepsis like activated protein C, which has shown no effect on the controlling the mortality. The others are the talactoferrin alpha or the cytofab, an antibody directed against the TNF alpha, have also been tried but not shown any good response as far as the mortality benefit is concerned. So this failure could be attributed to the strategy of targeting only one component of the inflammatory changes in the sepsis. Every time we were amazed to see those molecules, but after some few very big multi-centric trial, it has shown the negative results. So we were again going for the depression. Okay, what is next for the sepsis as far as the management is concerned? So in the context of the sepsis, the inflammation is necessary even as the inflammatory cytokines are the activators of both the innate as well as the adaptive immune systems. So blocking of these pathways proven to be counterproductive in treating the sepsis as evident by increased risk of infection. So requirement of the multi-targeted approach is approach is number one is the immune paralysis phase of the sepsis accounts for the more than 80% of the sepsis related mortality. So therefore, there is a need of an agent which is targeting the cytokines which are prevailing in excess at the same time doesn't suppresses the immunity. That is very, very important. There are molecules which target that particular IL-6, but at the same time, it reduces the immunity, and that's the reason we get the second phase of the sepsis. So we need to have those particular drug molecules where we will not get the disturbances in the immunity system or suppression of the immunity system. So an agent bringing in the balance in the dysregulated immunity would be an ideal fit for the current gap existing in the management of the sepsis. So what are the available immunomodulators till today around us for the treatment of this sepsis-related multi-organ dysfunction syndrome? One is the Sepsivac, Mycobacterium welchi, the unilastatin, tocilizumab, or itolizumab. Amongst this, when we see, we have tried so many times in the past, and still we are trying in the patients who are in the sepsis with the gram-negative sepsis particularly, or the tropical infections, or maybe pancreatitis. These unilastatins is definitely plays a very good role, in most of the time. But in gram-negative sepsis, we have not found any major changes as far as the death rate or mortality is concerned. But definitely, this has been very good drug for the where is the SIRS predominantly because of the tropical disease or the pancreatitis. Sepsivac is another challenging molecule which has came lately in this year, and we are using in this molecule and show the little bit very good response, little dependability on this molecule as far as me is concerned, and showing the good results sometimes. So what is this Sepsivac? The Sepsivac is a Mycobacterium welchi, also known as a Mycobacterium indicus pranae. It's a saprophytic, non-pathogenic strains of the Mycobacterium. It's a non-pathogenic. So it's also an immunomodulator, and it's known to contain the multiple antigen. How it acts? It antagonizes the TLR4 and the antigen-specific blocking of the TLR4 receptor. That is the toll-like receptors, number 4 receptors. So blockade, and by this way also it causes the blockade of the lot of inflammatory cascade which is there, which are causing the sepsis-related multi-organ dysfunction syndrome. So it also inhibits the inflammatory cytokines, and also it causes the antagonism of the cytokines in its circulation itself. So considering this mechanism action, it looks like quite a promising drug in near future if we go on using this molecule quite frequently. So these are the pathways where the Sepsivac acts. So it prevents the cytokine production from the cell macrophages. So what is the macrophage role of the macrophage in cytokine storm? It releases the interleukin family. It also causes the IFN gamma and the TLR, right? So when you hit the host where the cytokines are coming in the circulation, it looks like quite a promising hypothesis, and thereby we can control the cytokine-related multi-organ dysfunction syndrome. So same thing, tocilizumab. It has a targeted approach. It neutralizes only the IL-6, but the IL-6 is not the only cytokine which causes the multi-organ dysfunction syndrome. There are n number, what we are seeing here, the n number of interleukins, n number of cytokines which causes the cytokine storm and ultimately the dysfunction. So Sepsivac acts at a macrophage level and causes the suppression of the or reduction in the cytokine release. Same thing here, which causes the if we block this particular area of macrophages, then you don't get the cytokine storm, and thereby we don't get the rising levels of the IL-6, interleukin 1 beta, IL-10 or TNF alpha, and so on. So in conclusion, the sepsis triggers the production of a diverse array of the cytokines that are pro-inflammatory and anti-inflammatory. So while both types of cytokines are essential, their dysregulation can also trigger the pathogenesis. While some cytokines play a critical role, a combined signature profile of the cytokine involved in the sepsis is necessary to understand the mechanism at play and offer the better treatment approaches. So here, what we see at this point of time, we have got only 2 molecules. One is the Sepsivac, that is Mycobacterium welchi, and the unilastatin. These people can play a very major role in preventing the cytokine storm related the multi-organ dysfunction syndrome. so that we should use it. Why this molecule has come up also in COVID-19 infection, because when we use the steroid as well as the monoclonal antibodies in prevention of the inflammation secondary to the COVID-19, in that scenario, this suppression of the immunity, both this can cause the suppression of the immunity and ultimately can lead to the fungal infection, can lead to the gram-negative sepsis. The whole world is fighting against the gram-negative sepsis after the complete treatment of this COVID-19 infection. And because of that also, there is a high mortality after 10 to 12 days of the treatment of the COVID-19. So I think there is a role of this Sepsivac as well as the unilastatin in this sort of scenario of the COVID-19 also as well, not only the gram-negative sepsis originating from these diseases other than the COVID-19. Thank you very much for me giving this opportunity, and thank you for the patience listening from your end. Thank you.
Thank you, Dr. Nirmal Jaiswal, for an excellent presentation regarding how the cytokines are responsible for producing the effects of sepsis on multiple organs and leading to multiple organ failures, and how to intervene in preventing these multiple organ failures because of sepsis. I think this will go a long way in management of serious sepsis patients, and of course it's being used for the treatment of sepsis in COVID-19 also. If there are any questions, do we allow it on platform or on the chat box?
I think, sir, chat box would be preferable.
Please write your questions in the chat box, and Dr. Nirmal Jaiswal will also reply it using the chat box. Thank you, Nirmal.
Thank you, sir. Thank you. Thank you.
My co-chairperson, Dr. Sanjay Ambadkar, also is here.
Yeah.
Good afternoon, everybody. I welcome all the delegates to this afternoon session of NIMACON. Our next lecture is by Dr. Prakash Khetan. He will be talking on chronic kidney disease, delaying the progression. Dr. Khetan is a senior consultant nephrologist practicing since last 23 years in Nagpur. He is a managing director of Shravan Hospital and Kidney Institute and also director at Kingsway Hospital. He was the past chairman of Central India Nephrology Society and Nephrology Society of Nagpur also. He has a very special interest in kidney transplant and hemodialysis. He has published many articles in national journals. Dr. Khetan, over to you. You please start.
Good afternoon, everybody. At the outset, let me thank the organizers of NIMACON for chasing it hard and making it again an event to be successful. Among the pandemic, we are discussing another pandemic, and can I share my screen?
Yes.
Yes, sir, you can.
The topic for today is chronic kidney disease delaying the progression. Is the screen visible to all?
Yes, sir.
Yes, yes.
So CKD, chronic kidney disease, is a silent killer, and we can say if patient has got CKD, especially stage 5 CKD, he's got 14 times increased risk of death as compared to normal population. So amongst these COVID pandemic, we are having another pandemic, that is CKD. CKD stage 1 and 2 are asymptomatic. It is the third commonest cause of death after cardiovascular disease and cancer. Almost the prevalence is pretty high. Almost we can say 1 in 10 Indians can have CKD, and there are almost 10 million people of having CKD. We do not use the term CRF nowadays, chronic renal failure. We have changed the terminologies to chronic kidney disease. And patients who are on dialysis have a death rate of almost 100 times as compared to normal population. And small increases in creatinine can increase the cardiovascular mortality proportionately. So what does the kidneys do? Almost in a day, 210 liters of blood is filtered, and of these, only 2 liters of urine is formed by the effective working of the kidney. So kidneys filtrate, reabsorb, and secrete. These are the functions of the kidney. And the normal GFR is 120 ml per 1.73 meters square. And of the total nephrons, only 20% nephrons work at a time. So to define CKD, CKD can be defined either as a GFR less than 60 ml per minute per 1.73 meters square for more than 3 months, or kidney damage in the form of persistent microalbuminuria or macroproteinuria, biochemical abnormalities in renal function test, persistent non-urological hematuria, structural renal abnormality as defined by the ultrasonography, or biopsy-proven glomerulonephritis. If any of these things are there, then the patient are labeled as chronic kidney disease. As per GFR, it is classified into 5 stages. Stage 1 is when the eGFR is more than 90. Stage 2 when the eGFR is between 60 to 89. Stage 3, the kidney damage with eGFR of 30 to 59 ml per minute. Stage 4 is between 15 to 29. And stage 5, when the eGFR falls less than 15, then we call it as end-stage kidney disease or stage 5 chronic kidney disease. So during stage 1 and stage 2, there are only markers of kidney disease in the form of proteinuria, hematuria, or anatomic abnormalities. In stage 3, complications are possible, and stage 4 complications are evident, and patients who have stage 5 need a renal replacement therapy. So what are the factors which causes progression of chronic kidney disease? One is systemic and intraglomerular hypertension. Second is glomerular hypertrophy, intrarenal precipitation of calcium and phosphorus, hyperlipidemia, altered metabolism of prostanoids, metabolic acidosis, anemia, tubulointerstitial disease, and proteinuria. These are all the factors which can cause progression of chronic kidney disease. Am I audible? Hello?
Yes, yes, you are audible.
So as the eGFR decreases, the prevalence of hypertension increases, and the hypertension in stage 5, stage 4 chronic kidney disease, almost more than 70% have hypertension, almost more than 50% have anemia, almost 25% patient have decreased easy fatigability. So these are the things which can progress with the progression of chronic kidney disease. So this is in nutshell. Stage 1, one can have microalbuminuria. Urine output is normal. There is no edema, no anemia. Calcium phosphorus is normal. There is no secondary hyperparathyroidism. But as the stage progresses from stage 1 to stage 5, you have evidence of decreased urine output, presence of edema, anemia, deranged calcium phosphorus product, and secondary hyperparathyroidism. If we want to know the death rate from all causes, it is almost 14 times more in patients who have stage 5 CKD. And in stage 5 CKD, the cardiovascular risk is almost 36.6 times as compared to the normal population. These people are likely to die much before they reach end-stage kidney disease because of the cardiovascular disease, underlying cardiovascular disease. So why general practitioners must be engaged? We have almost 80 lakh patients with eGFR between 30 to 60 ml per minute. Patients with albuminuria are double this number. There are only about 2,000 odd nephrologists in the country. Nearly 4,000 new patients per nephrologist. Mean 11 new patients per day per nephrologist. this is obviously not possible for all nephrologists to do. So I suggest that all general practitioners must have a knowledge to treat CKD. So if we talk about the primary care provider, he should take care of the CKD patients almost up to stage 4, wherein the eGFR falls in till 30 ml per minute per 1.73 meter square, along with the help of cardiologist and endocrinologist if the patient has got underlying cardiovascular disease and diabetes. But the nephrologist should take over from management of the patients once the patient reaches stage 4 CKD. So what is the general approach to treatment? Physicians treating the patient with renal failure should have 2 goals: preventing or delaying progression of kidney disease, elevating the electrolyte and hormonal abnormalities that can lead to symptoms or complications of the disease. So the factors which are present in most of the patients is hypertension, and it has been very clearly shown that if we control blood pressure well, then the kidney disease progression is certainly taken care of. And we should target the blood pressure to less than 130/80 in patients with chronic kidney disease. Treatment with ACE inhibitors and angiotensin receptor blockers is useful as the first-line antihypertensive agents, or the combination of these with other agents should be the first-line antihypertensive therapy. Patients who do not tolerate these drugs might benefit from non-hydropyridine calcium channel blockers. In patients with proteinuria, even if the blood pressure is controlled or they are normotensive, the doses of ACE inhibitors or angiotensin receptor blockers should be raised to levels even greater than recommended to reduce urine protein excretion to levels less than 500 milligrams. So first is targeting the blood pressure, and second is targeting the proteinuria. These two are very important things which can retard the progression of chronic kidney disease. In patients who have diabetes, the goal should be to keep the fasting blood glucose between 60 to 110 milligram per deciliter, postprandial glucose 220 to 160 milligram per deciliter. The HbA1c should be between 6.5 to 7%. The LDL should be less than 100. Albuminuria should be targeted to be below 30 milligram per gram of creatinine. They should preferably avoid smoking, and the BMI should be between 17 to 25 kg per meter square if the patient is obese. Regarding protein restriction, we need to restrict the protein once the CKD crosses stage 3. We need to cut down on protein intake to 0.8 to 1 gram per kg body weight. And 50% of these patients should be protein should be of high biologic value. In patients with substantial proteinuria, we need to add these protein losses in the urine to the recommended allowances of the protein intake, so that the patient does not develop hypoalbuminemia. Once the patient reaches stage 4, protein restriction may be useful to prevent expression of uremic symptoms, and it also protein restriction does not only reduces the blood urea and creatinine, but also adds in benefit in decreasing acid production, potassium restriction, and increase in the serum potassium, and also phosphate production. So all these things are present in CKD. Regarding control of lipids, control of hypertension, cholesterol with statins prevent progression. As I have told you that these patients die of cardiovascular disease much before they reach end-stage kidney disease. These patients should be treated with statins, and we should adhere to the newly proposed aggressive recommendations of keeping the LDL below 100 milligram per deciliter. These patients do have anemia, and this anemia is directly because of deficiency of erythropoietin. There is a reduction in endogenous production of erythropoietin because of the diseased nephrons, and therefore anemia should be corrected with supplementation of erythropoietin. And these erythropoietin can be either the conventional erythropoietin or the long-acting erythropoietins like darbepoetin or pegylated erythropoietin, which can be given either once in 15 days or once a month. Because iron stores need to be repleted for anemia to be successfully treated, the iron store should be periodically monitored in patients who are on erythropoietin, and if iron levels are deficient, then supplemental iron should be given, preferably in the form of intravenous iron. The target hemoglobin which has been recommended by the KDOQI guidelines is we should not exceed a hemoglobin of between 11 to 12 grams per deciliter. Sorry for the mistake. It is 11 grams per deciliter. So the hemoglobin should be between 11 to 12 grams per deciliter, and the hematocrit should be between 33 to 36. If the hemoglobin exceeds 12 grams per deciliter, then we should temporarily discontinue erythropoietin, or we should reduce the frequency of erythropoietin administration. Measures to treat metabolic acidosis. Metabolic acidosis is a formal component of chronic kidney disease, and there is a controversy where what should be the target value of bicarbonate for patients with chronic kidney disease. Some experts have recommended it to be above 20 milliequivalent per liter, but others recommend complete normalization of plasma bicarbonate, that is between 22 to 26 milliequivalent per liter. So to properly raise plasma bicarbonate level, the deficit should be calculated from the formula, and this formula is very well known to all of us, and these deficits should be corrected slowly over several days. The studies have suggested that at all stages of CKD, base supplementation could be beneficial in slowing the progression of chronic kidney disease. Therefore, all patients of CKD should have oral soda bicarb supplementation, and the levels of bicarbonate should be periodically monitored. Regarding the divalent ion metabolism, that is the calcium and phosphorus metabolism, the serum phosphorus has to be controlled by administration of phosphate binders, which can be with calcium citrate or calcium containing phosphate binders like calcium citrate, calcium acetate, or calcium carbonate. If these are not successful, or if patients have elevated serum calcium levels, then there are non-calcium containing phosphate binders in the form of sevelamer or lanthanum, which can be used alone or in combination with calcium containing phosphate binders. We should aim to maintain the serum phosphorus level below 5 milligram per deciliter and keep the serum calcium phosphorus product below 60. The PTH level should be maintained below 150 picogram per ml or less, depending upon the stage of chronic kidney disease. Usually PTH gets elevated beyond the stage 4 of CKD, and we need to treat this hyperparathyroidism following stage 4 CKD with the help of either vitamin D analogs. Suppression of PTH secretion can be with vitamin D analog, and the recent recognition of calcium sensing receptor and development of calcium mimetic drugs that are extremely effective in lowering PTH secretion may make using vitamin D compounds obsolete in the future. The problem with vitamin D analogs is they can cause hypercalcemia, and if there is hypercalcemia, then it is preferable to use calcium mimetic drugs to treat the hyperparathyroidism. Measurement of 25 hydroxy vitamin D level should be obtained in all patients with CKD and eGFR of less than 60 ml per minute. And if the levels are less than 30 nanograms, then they should be supplemented with ergocalciferol. Hyperkalemia is the most serious electrolyte disorder, and hyperkalemia is directly related to cardiac arrhythmias, and patients with hyperkalemia can have sudden cardiac arrest. So potassium level monitoring is very important in patients with chronic kidney disease, and we should target a serum potassium of less than 5 milliequivalent per liter. the use of ACE inhibitors and ARB is recommended to treat CKD patients. So, and these drugs have the side effect of causing hyperkalemia, and so these have the mineralocorticoid receptor blockers, which have also been recommended as the drug to reduce the rate of progression of chronic kidney disease. So these two groups of drugs, along with the chronic kidney disease, can predispose the patients to hyperkalemia. So whenever these patients are on this group of drugs, potassium level should be periodically monitored and they should be taken off, or patient should follow a potassium restricted diet so that hyperkalemia does not occur. Administration of loop diuretics and thiazide diuretics can control hyperkalemia. And when the eGFR falls less than 20% of normal and patient has hyperkalemia, we can use potassium binding resins. The elevated blood urea nitrogen is the marker of other retained solutes and is roughly correlated with the development of uremic symptoms. When the blood urea nitrogen is more than 100 and the creatinine is more than 8, usually patients may develop uremic symptoms, and these may be initially treated with protein restriction, and if the protein restriction does not help, then the patient has to go for renal replacement therapy. Volume overload is very common in patients with chronic kidney disease because of retention of sodium and water because of the failing kidneys, and the hypertension is many times related to volume overload. So we need to advise the patients of chronic kidney disease salt restriction, along with that water restriction, and we should use diuretics, especially thiazide diuretics in the early stages of CKD, and loop diuretics in the later stages of CKD to treat volume overload and also control the hypertension. Because the effectiveness of both these agents require access to tubular lumen, the effective doses of these diuretics may be higher than the normal doses which are required in patients with normal kidney function. So how to handle CKD? What is the ABCD of handling chronic kidney disease? A is the A1C should be less than 6.5. Patient should be preferably be treated with either ACE inhibitors or angiotensin receptor blockers. These SGLT2 inhibitors are another new group of drugs which have been found to be useful in patients of chronic kidney disease. The blood pressure should be less than 130/80. The cholesterol, LDL cholesterol should be less than 100. And drugs which can cause nephrotoxicity should be avoided. The diet should be moderate in protein, sodium, phosphorus, potassium, phosphorus, fluids, and calcium. These SGLT2 inhibitors are the wonderful drugs which act on the proximal convoluted tubule, and inhibition of these SGLT2 inhibitors have been found to be very useful in reducing the rate of progression of chronic kidney disease because of all these mechanisms which are mentioned over here on the slide, like decrease the sodium and glucose reabsorption, decrease metabolic demand, increase sodium delivery to the distal tubule, increase afferent arterial vasoconstriction. So these are all potential mechanisms by which SGLT2 inhibition is helpful in reducing the rate of progression of chronic kidney disease. So in treating CKD, the management goal should be to keep the blood pressure less than 130/80, glycemic control to less than 6.5 of HbA1c, hemoglobin around 11 to 11.5, calcium phosphorus to less than 50, and so if we start, if a patient comes to us and we don't provide any treatment, then the patient is likely to progress to chronic kidney disease at the end of 7 years. If we pick them at a later stage when the eGFR is around 50 and start treating this patient, we can retard the progression of chronic kidney disease to end-stage kidney disease. to another 2 years. And if we start the treatment pretty early, then we can delay the end-stage kidney disease by almost to 11 years. So stage 0, we should test for chronic kidney disease. We should manage risk factors. In stage 1, we should manage comorbidity, treatment for cardiovascular disease and risk factors. Stage 2 of chronic kidney disease, we have to slow the rate of loss of kidney function with the use of ACE inhibitors, ARB, SGLT2 inhibitors, and mineralocorticoid receptor blockers. Stage 3, we have to prevent anemia, bone effects, treat the calcium phosphorus. Stage 4, we have to prepare for renal replacement therapy, refer to nephrology. And stage 5, we have to subject the patient to renal replacement therapy. So these are the KDOKI guidelines for frequency of monitoring. If the patient has got stage 1 or stage 2 chronic kidney disease, then the frequency of monitoring should be once or twice a year. If the patient has got stage 3, then it should be quarterly, every 4 months, the patient should be seen. And if it is stage 4, stage 5, then it should be, patient should be called for follow-up almost every 3 months or maybe earlier than that. So decision to refer the patient with proteinuria, overt proteinuria should be referred to the nephrologist, or patient with severely decreased eGFR like stage 4 CKD should be referred to to the nephrologist. Regarding preparation for
As we are
renal
running out of
replacement
time, can you
therapy,
please sum up?
the choice of renal replacement should be explained, whether it is dialysis or transplant. If it is dialysis, then there should be timely access surgery, timely initiation of dialysis. We should advise the patient about preparation for renal replacement therapy once the eGFR is less than 25 ml per minute. Obviously, renal transplant is the first choice. Workup of living donors should start early. If there are no donors available, then we have to list the patient for cadaver transplant, and we need to place an AV fistula if a patient prefer to undergo hemodialysis. So to conclude my talk, we know that the CKD ESRD patient population is increasing in our country. Early detection and proper management has many advantages. Later stages RRT is required, and various modalities of renal replacement therapy as well as renal transplantation are available in our country, but pretty expensive. So I request everyone that keep the kidneys normal and don't let them reach end-stage kidney disease. Thank you. Thank you very much.
Thank you, Dr. Chetan, for your lucid presentation. You have very well explained various measures for delaying the progression of chronic kidney disease. If there are any questions, please put it in the chat box. Dr. Chetan will answer them afterwards. Thank you. Thank you very much.
Thank you.
Thank you, sir. We like to felicitate the speakers for this session, Dr. Nilman Jaiswal, sir. Sir, words fall short to felicitate you regarding the views you have shared on such complex topics. Please accept this memento and a floral bouquet on behalf, though digitally, on behalf of Team NIMACON. We would also like to felicitate Dr. Prakash Khetan, sir, for giving such a beautiful rendition of the talk. Thank you so much, sir, from Team NIMACON. And last, not to forget the chairpersons who gave their valuable inputs. Thank you, Kate, sir, and thank you, Ambedkar, sir, for chairing this session.
Thank you. Thank you.
Our Honorable Prime Minister Modi ji promoted Digital India. In the recent COVID times, digital medium was only savior for all of us. It is said, since we cannot change the reality, let us change the eyes which see the reality. The use of digital methods in medical science has revolutionized the medical science and scenario. Its use in ocular surgery is going to be highlighted by Dr. Prashant Bawankule, sir, I invite chairpersons for this session, Dr. Rafat Khan sir and Dr. Gopal Arora sir. Dr. Rafat Khan sir is a senior consultant ophthalmologist at Green City Hospital, Nagpur, and was vice president IMA. Dr. Gopal Arora is a phaco and LASIK surgeon and director of Akshar Eye Institute. He is fellow of Royal Science of Health, London. He has been bestowed V.K. Chitnis Oration Award. He is president of Association of Medical Faculties and past president JCI Nagpur Medicos and Academy of Ophthalmology. Over to you, sir.
Well, thank you. First of all, a very good afternoon to all IMA members. I'm sure in physical conferences, post-lunch session is a difficult task, but I think that has an advantage in this virtual conferences. We have, as you mentioned, the digital world has come to existence now because of the pandemic. And here we have a talk on 3D digitally assisted ocular surgery. If you remember in the 90s, there was the 3D movies, wearing goggles and watching the movies. This is one aspect. And a lot of the surgeons started with the endoscopic surgeries. So the ophthalmic techno world decided to incorporate both of these. First was the 3D surgery and second was the doing surgery by viewing at the LCD rather than actually looking at the patient operating procedure. So we have this 3D digitally assisted ocular surgery to be spoken by my dear friend, Dr. Prashant Bawankule. But there are many questions which needs to be answered. Does it offer any benefit from the normal microscopic ophthalmic surgery? Does it give you a better depth of focus? And especially in this pandemic, does it offer any advantage? The 3D surgery actually started, I'm sure Dr. Prashant will agree with me, that with the retinal surgeries. But now he will tell us more about what are the other areas in the ophthalmic surgery that this 3D surgery has entered into. But before he takes on this talk on digital surgery, I would request a very dear friend and a very active IMA members, few of the ophthalmologists who are very active in IMA, Dr. Rafat Khan, to introduce a dear friend, Dr. Prashant Bawankule. Dr. Rafat Khan, sir.
Good afternoon, everyone. Can you hear me?
Yes, yes.
Yeah. It's indeed a great pleasure to introduce young, dynamic, and handsome ophthalmologist of Central India, Dr. Prashant Bawankule. Prashant को कौन नहीं जानता? After completing his MS in Nagpur, he went to Chennai and did his retina fellowship at prestigious Shankara Netralaya. And nowadays he is managing director of well-known eye hospital, Sharakshi Netralaya. Prashant has 23 publications in national and international journals, received many awards. Recently, he is awarded with NSS Eye Institute Retina Substratum Oration by All Gujarat Ophthalmological Society, V.K. Chitnis Oration Award by Maharashtra Ophthalmological Society in 2020. Received Best Video Award at Asia Pacific Ocular Trauma Society, Best Paper at Chhattisgarh Ophthalmic Society, that is Anand Saxena Gold Medal, and the Best Video Award at World Congress of Ocular Trauma. He is a past president of Vidarbha Ophthalmic Society and Maharashtra Ophthalmological Society. And currently he is holding the position of Joint Secretary, Joint Treasurer at Vitreoretinal Society of India and Treasurer of Ocular Trauma Society of India. With this, presenting you, debonair leader in our ophthalmic fraternity, Dr. Prashant Bawankule.
Thank you, Gopal sir and Rafat sir, for a wonderful and kind introduction, I should say. You have really bloated my ego and my heart, I should say. Thank you once more. So shall I start sharing my screen? Yeah.
Sure.
Yeah, please.
So for the sake of the time, I have made a pre-recorded video so that I maintain the time, and my video is exactly time for 17 minutes. So here starts my presentation, and I can have the questions later on. Good afternoon. At the outset, let me thank the organizing committee of NIMACON and the scientific committee of IMA for this honor. It's a beautiful world of 3D or heads-up surgery, which has added a new dimension and precision in our surgery since last 3 years. And now we have an experience of more than 4,000 cases. Let me share this experience with you. This is how we used to operate a few years back, and this is how now we operate. This is exactly the 3D surgery. Is it that the heads-up surgery or a 3D surgery protects an aging back of a surgeon like me, or it gives me an advantage of upmanship over my peers? Or does it translate into a technical advantage over microscope, which naturally translates into better surgical outcome? Let's understand during this talk. This is how the system looks. In this microscope, there are no eyepieces. Instead of eyepieces, there is a camera which picks up an image, and this image is processed by this computer, and this is the heart of the equipment. And this image, which is processed for betterment, is then shown or displayed on a 4K OLED screen, which you have to visualize with the help of a Polaroid glasses. This is a visual from our theater, where the surgeon is not looking into the microscope, but with Polaroid glasses, he is looking at the screen and operating. There is a vast improvement in the visualization technique in TVs. In 1983, this is the TV set on which we saw our country winning at historically the World Cup for the first ever time. Then came the evolution in 1990s, the screen size increased, clarity increased. This was 2000. And this is actually what we see in today's era. On a LED screen, in fact, now you can even see an ant crawling over the lawns of the stadium. And that is the beauty of visualization technique. And if this technology is helpful to us in medical sciences, naturally your surgical or medical results are going to improvise vastly. Magnification. The least basic magnification which this system offers is 30 to 40% more than the highest magnification of a microscope, which brings out the finest details during surgery, which is unseen in an analog microscope, as magnification compromises on depth and field of microscope. So, a very simple example from our undergraduate days. This is what we could see a microbe when we were using a light microscopy. Then came the transmission electron microscopy when we could see further details. And now it is a scanning transmission electron microscopy where 3D image of a microbe can help you in seeing the most finest details of a microscope. So imagine what you would like to have in today's era. Simple light microscopy or a scanning? Yes, a magnified way of scanning laser microscopy. This is a case of epiretinal membrane, which is an idiopathic cellular proliferation on a macular surface leading to crimpling and distorted vision. Look at the beauty at magnification at which we are operating, which was unseen with a microscope. Here I am removing the thin filmy membrane. There is another thin filmy membrane which would have gone unnoticed, and then peeling the internal limiting membrane. Another age-related problem, that is full thickness macular hole, which is seen more commonly in females. Here, after staining the internal limiting membrane, the internal limiting membrane is peeled off and stuffed into the residue or into the gap of the retina or the break in the retina, that is macular hole. This is base excision, which is being done, which is an essential step during any vitreous surgery for retinal detachment. At this magnification, actually you can see the individual fibrils of a vitreous, which was never seen on a case of a microscope. Field of view is inversely proportional to the magnification. Ocular-free design allows unrestricted field of view even at such high magnification, unlike that of microscope. Peripheral field or field of view at high magnification, central image is more better seen, but it leads to the blurring of the peripheral image. Digitalization not only compensates for this, but enhances the peripheral view. Case of a proliferative diabetic retinopathy with tractional retinal detachment, which is the last stage of diabetic retinopathy. Such a large field allows the surgeon to have a complete view of pathoanatomy and thereby unravel a complex interrelation of retina, membranes, and vitreous in such situations. Here you can see how coning of peripheral vitreous from the membranes is done, then the inside out membrane approach, that is membrane peeling, and then all this is possible because of the expanded field of view in spite of the magnification at which we are operating. And because of such a great field of view, here you can end up with such a complicated case even without any iatrogenic complication. Giant retinal tear is a retinal detachment with tear which is more than 3 clock hours or 90 degrees. Here, the tear is more than 270 degrees, an extreme tear. Here, in a single field of view, you can actually see so beautifully the unrolling of the giant retinal flap, and this makes this look so simple. Depth is 5 times more than that of microscope. Again, define the concept of microscope that magnification is inversely related to depth. Let me explain you with a simple example of a SLR camera. In a single shot, you can either view the arch which is closer to your camera, or you can focus a valley which is miles away. But you cannot see both the things sharply. But digitalization can make you both the valley as well as the arch look as sharp as you would love to see. Another extreme case of proliferative diabetic retinopathy with flat neovascularization over the whole posterior pole. You can appreciate the audacity and confidence of a surgeon in dissecting and cutting the membranes over retina, which is hardly separated by less than a millimeter. It is simply possible because of the depth and the high magnification which this system offers, giving the surgeon ability to micro-titrate the movements with his instruments and thereby avoiding iatrogenic tears. Similarly, the depth in the capsular bag seems so deep, so discreet that I can dare to introduce my irrigation aspiration tip beneath the posterior capsule and in between the sticky epinuclear plate. Also, this is a lens which is put upside down, and because of the sheer depth, I can flip in the IOL inside the antechamber without the fear of iatrogenicity. Digitalization enhances the quality of image captured by the camera. Let me give an example. This is a mountain which is sunlit. The valley is in shadows which cannot be seen so well. If you increase the exposure, the camera overexposure leads to dazzling. But digitalization of the same image lets you see the beauty of the valley which is in shadows as well as in sunlit mountain. Well, you will feel this photo is taken on an overcast day, while the other photo is taken on a bright sunny day. No, it's the same photograph courtesy digitalization. Precisely, this is the advantage of digitalization, which enhances what you see and thereby making your surgery more precise and more risk-free. And all this is possible at 1/10 of the illumination, thereby reducing the drying of the cornea because of the heat generated by a halogen bulb, and also less chances of phototoxic macular burn. Filters are value addition useful in better weaving of certain tissues during the surgical step. ILM peeling being done without filter and with the filter. And you can see the ILM, though stain in both the cases, is better seen with the filter on. In anterior segment surgeries also, the red-free filter attenuates the red color, which is exaggerated in a digital image, and thereby making your surgery more pleasant. Bending into the eyepieces of a microscope is a bad ergonomic posture, making the surgeon more prone for back and neck problems. Here, while you sit straight and in a relaxed position, and thereby gives an advantage to a surgeon. As a teaching tool, unlike microscope, where assistant only gets 20 to 30% of quality image, what a surgeon is perceiving, here the assistant and the fellows, as well as the postgraduates who are in the theater, can have the same surgical experience as the surgeon is having, and thereby making them more conversant with the techniques. It is especially important to the places, to the hospitals, which offer postgraduate courses like ours. Here, I am sharing some vitreoretinal surgical videos of extreme diseases depicting the advantage and superiority of 3D surgery. This is a case of a vitrectomy for a complicated proliferative diabetic retinopathy. I'm doing a membrane peeling. In such complex tabletop TRDs, we usually end up creating a break, thereby compromising on the end results. While you can see the ease with which we are doing in the 3D and the precision with which we are operating, and well, you can see the end result where I have completed such a complex case without an iatrogenic break. This is a case of giant retinal tear where I'm doing a detachment case for giant retinal tear, and such a beautiful panoramic all view which we are enjoying. Doing a vitrectomy, then an internal limiting membrane is being done, then the PFCL is being put and the laser being done, and all these things with a panoramic big field of view makes your surgery look so simple. Foveus cases is a challenging case for any vitreoretinal surgeon because of the lack of reflexes. Here you can see the ease with which the use of filters allows you to visualize the internal limiting membrane even in such cases where there is lack of reflex. Multiple studies have proven the superiority and usefulness of 3D surgery in vitreoretinal procedures. Does this system also offer similar benefits in anterior segment surgeries? Was the question. Because of the supposed lag, 3D surgery has not gained much popularity amongst the anterior segment surgeon. This is one of the first studies published in a journal recently by our group on the utility of 3D surgery in anterior segment surgery. The aim of our study was to evaluate the efficacy and safety of 3D system in varied anterior segment surgeries like phacoemulsification, glaucoma surgeries like trabeculectomy, scleral fixated IOL, scleral buckles, and trabeculectomies. Patients were randomly assigned to 2 groups and various parameters were studied. And this is the study. I would just come to the conclusion, what we concluded. So the conclusion of our study was that anatomical and physiological results were similar in both the groups. It means the use of 3D was non-inferior to microscope. Regards safety, 3D surgery has proven to be as safe as that of microscope. Surgical time after the initial learning phase is similar between microscope as well as 3D system. Time lag and learning struggle was only perceived by the surgeon during the learning phase, while the surgeon appreciated the field of view, depth perception, and color contrast much superior to that of microscope. Postural comfort in surgeons having long OT hours, Ingenuity was definitely scoring over microscope. While as an educational tool, Ingenuity is much more superior. Let me share with you some videos of use of this system in anterior segment surgeries in extreme cases. Well, we have been using this in routine phaco, left and right. This is a case where we are doing a phacoemulsification, where after installation of a dye, the cornea becomes suddenly hazy. Through the hazy cornea, it is difficult to complete the phacoemulsification. By playing with the parameters of this system, we could complete the surgery uneventfully and put a lens in spite of a bad view through the hazy cornea. In a case of a microscope, we would have to peel off the epithelium to facilitate a good viewing. And this is the advantage in cases of corneal haze. This is a phaco in a hypermetropic eye. Hypermetropic eyes are smaller, and this patient needed 32 diopter of IOL power, and the anterior chamber depth was less than 2 millimeter. But in a 3D, anterior chamber looked as big as 2 to 3 inches, giving us the confidence of operating in a routine eye and thereby preventing any heterogeneity and an uneventful case, even in such a shallow anterior chamber, and putting an 3 multifocal IOL. Another complicated, challenging cases, that is of a grade 5 nuclear sclerosis, where it is really tough. Most of the surgeons go for small incision cataract surgery. Here we are doing phacoemulsification in a grade 5 with a 3D system, and you can see the ease with which we are able to manage in spite of lack of glow, and we could complete the case. This is another challenging case. Here we are having a cataract with a iris tissue loss, with a corneal opacity, with a partially subluxated lens. Here we are doing a phacoemulsification, a capsulorhexis being done, an uneventful phaco surgery being done, and Lens was put in the bag through the corneal opacity, and now we are trying to create a pseudo pupil. Iris repair is done to create a, when the iris tissue is lost, we create a iridoplasty to give a pupil a circular look. Here the pterygium surgery with a conjunctival autograft is being done by one of our cornea surgeons, and this is a case of a squint surgery being done by our pediatric ophthalmologists. They are as comfortable, rather they enjoy the whole system and they are as conversant as with a microscope. So 3D digital surgery is here to stay, not only for vitreoretinal procedures, but also for anti-segment procedures like phaco, because of the sheer magnification which it offers, along with enhanced depth imaging, increased peripheral acuity or field of view, all at low illumination, with advantages of digitalization like color and light mapping. So better you see, better you perform. So friends, it is up to us to decide whether we would like to star watch or moon watch with the help of a bare naked eyes, or with the help of a simple micro telescope looking at the crypts from such a far distance, or you would like to use a reflecting and refracting telescopes to see the minutest details even on the surface of it. So technology has to be accepted for the betterment, and that would lead ultimately to the better outcomes in the patient. So thank you once more for the patient here.
Thank you, friends. And thank you, IMA, for a wonderful opportunity. Hope this was informative. Over to you, Chairman.
Well, thank you so much. That was indeed a wonderful presentation. And I'm sure even for the general practitioners, it would have answered all the queries in the question that there must be there in their minds. If there are any other doubts, I think you can put it in the chat box, and Dr. Prashant would be more than enlightened to highlight and solve all your queries after the talk is over. I hand over to Dr. Rafat Khan.
Thank you, Gopal. Thank you, Prashant. It was a beautiful talk, and everybody has delighted to see you working and doing those vitreoretinal surgery in such a simpler way. So everybody now wants to purchase those machines.
Thank you.
So thank you very much. Over to IMA headquarters.
Thank you, everyone.
Thank you.
We felicitate Dr. Prashant Bawankule, sir, with a token of appreciation and florals.
Thank you, ma'am. Thank you.
Moving on to the next session. It is a saying that the way I see it, if you want the rainbow, you gotta put up with the rain. The whole universe is bearing the effects of pollution in some or the other way. Then how come the humans can be unaffected? Enlighten us on the topic pollution and health, we have Dr. Sandeep Sarvi with us, who's going to speak on that. The chairpersons for these sessions are Dr. Rajesh Ballar, sir, Dr. Sudhir Safle, and Dr. Aditya Parihar. Dr. Rajesh Ballar, sir, is a versatile, multi-talented physician par excellence and past president of IMA. Dr. Sudhir Safle, sir, he is a critical care consultant at Getwell Hospital, past secretary, Diabetic Association of India, and Dr. Aditya Parihar, chest physician who is practicing since 40 years. Over to the chairpersons, please.
Hello, am I audible?
Yes.
Yes. A very good afternoon to all of you. So we are already late. So shall we start? Because Sandeep Sarvi sir is waiting from last 1.5 hours. So let me introduce Dr. Salvi sir. Salvi sir is our teacher. He is a director at the Pulmocare Research and Education Institute Foundation, Pune. He is a founder director of Chest Research Foundation from 2002 to 2009. He is a member board of directors, Gold, that is Global Initiative for COPD. He is a current active vice president of Indian Chest Society. He is the International Advisory Board, Lancet Respiratory Medicine. He is a chairman, Chronic Obstructive Diseases Section, Global Burden. He is a members steering committee on air pollution and health. He is with Ministry of Health and Family Welfare. He has more than 200 publications, and I hope you all will be delighted to hear from him. on his favorite topic, that is on pollution and health. Over to you directly, Dr. Sandeep Salvi, sir. Please start.
Thank you. Thank you so much, Dr. Parihar, for those very kind words.
Yes, sir.
Wish you all a very good afternoon. At the outset, I would like to express my very sincere thanks to NIMACON 2021 for inviting me to this wonderful academic feast and giving me the opportunity to share with you some very important and exciting information that is currently being made available about the impact of air pollution on our health. The first thing that we do when we are born is we take the first breath. The last thing that we do before we leave this world is we take the last breath. The period, the time between the first breath and the last breath is what we call as life. Life is equated to breathing. If you're breathing, you're alive. If you're not breathing, you're not alive. That is how important this very simple aspect of breathing is for our survival, and not only for that, but also to keep ourselves fit and well. Out of the three basic necessities of life, which include food, water, and air is perhaps the most important. And within the air that we breathe, the molecule that is perhaps most important is what we call as oxygen. You may perhaps not know this, but the oxygen that we derive from the air that we breathe generates 90% of the body's energy, with only 10% coming from the food that we eat and the water that we drink. Air is absolutely vital for our survival. And it is this oxygen that is the main component that is responsible for this. The lungs are an organ that soak in the oxygen that is present in the air and then transfer it to the circulatory system. They transfer the oxygen to this tiny cell called as a red blood cell, which contains 300 million hemoglobin molecules. Every tiny red blood cell has 300 million hemoglobin molecules. Each hemoglobin molecule attaches 4 oxygen molecules to it, and that is how it is transported in the blood to the various organs and the tissues of the body. One more very fascinating fact is that if you count all these cells in the body, right from the tip of your head till the tip of your toe, that would account for around 37 trillion cells. Trillion is with a T. Out of these 37 trillion cells, 25 trillion are the red blood cells that are circulating in the blood. Isn't that fascinating? The red blood cells constitute around 60 to 65% of all the cells in the human body. The circulatory system, I believe, has been dedicated primarily to transport oxygen to all the tissues in the body. So whatever oxygen the lungs soak in, it is the responsibility of the circulatory system to transport it to all the tissues and the organs of the body. In fact, 50% of the nutrient that is transported in the blood is oxygen. Because if you take 100 ml of blood and just keep it in a test tube, after a while, you'll see that the red blood cells, they occupy 45 to 50% of that volume of the blood. And that is the portion that is transporting oxygen to the various parts of the body. Look at the amount of investment that the human body has made in order to soak in the oxygen that is present in the air and transport it to all the organs of the body. The quality of air that we breathe, therefore, is a very critical determinant of our health. The lungs, as I said, are an organ that nourish the body with oxygen. We breathe about 10,000 liters of air every day, 10,000 liters, out of which the lungs soak in about 1,000 liters of oxygen and push it into the circulatory system, into the red blood cell. At the same time, the lungs also excrete a very important waste product that the cells produce called carbon dioxide. On a daily basis, the lungs excrete 350 liters of this waste product called carbon dioxide. That is the beauty of this organ. Unfortunately, not many of us breathe pure air. What is pure air? Pure air is 78% nitrogen, 20.5% oxygen, 0.05% carbon dioxide, and 1% argon. How many of us even know what is pure air? 98% of the population in India live in areas where there is no pure air at all. We all breathe polluted air. And this polluted air comprises essentially of gaseous air pollutants, and these include carbon monoxide, nitrogen oxide, sulfur dioxide, and ozone. But more important than this is perhaps the particulate matter. These are the very tiny black particles that we see that are perhaps more harmful than the gaseous air pollutants. When the technology was not very advanced, we were able to measure only large size particles, and these large size particles were around 10 microns in diameter. So the ability to measure particles which were less than 10 microns in diameter, that was called as PM10. Later on, as the technology got better, we could measure PM2.5, that is particles which are less than 2.5 microns in diameter. Then we have PM1 and more recently nanoparticles. So as the technology has advanced, we have been able to measure the particulate matter pollution that is present in the air. And the tinier the particles, the more deeper they enter into the lungs, and from where they can enter into all the into the circulatory system and then reach all the organs. Other than that, there are other pollutants such as heavy metals and endocrine disrupting chemicals, which I will come to a little later on, and then pesticides. So these are important pollutants that most of us keep on breathing all the time. Air pollution is largely classified into two types. Ambient air pollution, also called AAP, which is not the Aam Aadmi Party, but pollution that is present outside your house. The sources of which come from motor vehicles or road dust or industrial smoke or burning of crop residues or burning of garbage or burning of dried leaves. These are all the sources of ambient air pollution. That is, sources that are outside your house. And a lot of these are harmful for the human health. The second classification of air pollution is called as HAP, or household air pollution. But more recently, the word household air pollution has been replaced with indoor air pollution. And the reason for that is indoor means not only the house, but indoor means your school classroom, indoor means your office where you study or where you work, or indoor could be one of the malls or the cinema theaters where you go. So indoor air pollution is also a very important component of air pollution. Perhaps one of the major sources of indoor air pollution in our country is the burning of biomass fuel for cooking. So we use crop residues or animal dung or wood. And you can see this poor woman who is cooking food for the family. You can see the smoke that is coming out. Fortunately, there is a little window over here, but in most kitchens, there is very poor ventilation. So in poor ventilated homes, when you burn the wood or the animal dung or the crop residues, you're producing a lot of air pollution. And the amount of air pollution that this female, or this mother who cooks food for the family inhales on a daily basis is equivalent to smoking 25 cigarettes a day. That is how much pollution is produced when she cooks food for the family. Did you know that burning one mosquito coil in the night for a period of around 6 to 7 hours produces as much amount of pollution that is equivalent to smoking 100 cigarettes? One mosquito coil, 100 cigarettes. You keep the door and the window closed, and the number of people who are sleeping in the bedroom, inhaling the smoke coming from the mosquito coil, everybody has smoked 100 cigarettes every day. That is the amount of air pollution that we produce every day. Then we have the agarbattis. Perhaps the most highly polluting thing that I've seen is this dhoop agarbatti. The dhoop agarbatti is only 4 centimeters tall. It burns only for 15 minutes. But during these 15 minutes, it produces as much amount of pollution that is equivalent to smoking 500 cigarettes. When we did this research a few years ago, we got a shock of our life. We repeated the experiments again and again and again just to confirm, really, is there so much of pollution that is produced when you burn one dhup agarbatti? And the answer was very consistent. So this is perhaps one of the most polluting substances that I've seen inside our house. Diwali is a very popular festival and we burn a lot of firecrackers. The individual exposures to air pollution during those 3 days is extremely high. Look at this. The snake tablet is perhaps the most polluting firecracker. As a child, I used to burn so many of these snake tablets. Burning one snake tablet produces as much amount of smoke that is equal to 2,900 cigarettes. Then the lead, 1,000 firecrackers, 1,750 cigarettes equivalent to that. Pulpul and the sparkler is around 500 cigarettes. So this is the level of pollution that we breathe during the Diwali festival. This is personal individual exposure. This is a work that we published in Lung India a couple of years ago. The harmful effects of air pollution start even before you're born. This was a very interesting study from New York. 10 randomly selected newborn babies were taken. And after they were born, when you cut the umbilical cord, they removed the blood from the umbilical cord and sent it to the laboratory to look for presence of circulating air pollutants. Randomly selected babies from New York. Do you know what they found? They found presence of 287 different pollutants circulating in the umbilical cord blood. Most of them originated from indoor air pollution. Now, what does this mean? This means that when a mother is pregnant, the pollution that she inhales through her respiratory tract enters into the systemic circulation. From there, it enters into the fetal circulation, and the placenta does not offer any barrier for the passage of these harmful substances into the growing fetus. So the growing fetus is exposed to air pollution even before that baby is born. And this is a recent study a couple of years ago that actually quantified the amount of black carbon particles from the ambient air in the placental tissue. So they took the placental tissue from women who were living in different polluted environments. You can see the red colors over here. So this is the placenta from women who are living in more polluted areas. And the amount of black carbon particle that was identified in the placental tissue was very high. In contrast to that, women who were living in a cleaner environment, far away from the main road, the amount of black carbon particles within their placenta was much smaller. So clearly, if you're a person whose house is next to the main road or next to a very highly polluting area, then obviously you're going to be exposed to a lot of air pollution. And the mother will be transmitting this air pollutants to the growing fetus. Now this gets translated into clinical practice. Look at this. So this is gestation duration, early delivery. So delivery at 12 weeks, preterm delivery. Now, babies who are born by preterm delivery, look at the amount of black carbon particles that they found in the placenta compared to the babies who are born towards term. So preterm deliveries, what does this mean? Preterm deliveries are associated with high levels of black carbon particles present in the placenta. And that could perhaps be a reason why they're having preterm deliveries. The obstetricians have suddenly now got a lot of interest in environment and the baby growth, fetal growth. So this is a very, very beautiful review article published in Fertility and Sterility a couple of years ago. And it talks about something very important. Preconception exposure to environmental pollution. Now this could be heavy metals, endocrine disrupting chemicals, as I said, pesticides, other air pollutants. Now they have an ability to have an impact on each of these: fertility, the ability to get pregnant, pregnancy, fetal growth, and delivery. All of these are seriously impacted if the mother gets exposed to air pollution. Now, not only that, but subsequently, when the baby is born, during the neonatal period, when the baby becomes an adult, and perhaps even the subsequent generations can get affected because of what this mother was exposed to during her pregnancy. So air pollution and the impact on the growing fetus and subsequent impact on adulthood has become a very, very important topic that we have just started recently understanding. Even the cardiologists have understood the importance of air pollution. In fact, many cardiology societies are now coming up with these guidelines: air pollution and cardiovascular disease. What is the impact of air pollution on heart diseases, whether it be ischemic heart disease or hypertension, cerebrovascular disease, or even stroke? But here is a very old study published in the New England Journal of Medicine way back in 2004. Odds of having a heart attack in an elderly individual who is more susceptible. Okay, just look at this. If you're a smoker, the risk of you developing a heart attack is more than 2.5 times compared to if you have never smoked before. Lack of physical activity increases your odds of having a heart attack by 1.5 times. Presence of diabetes increases the risk of having a heart attack by more than 1.5 times. If you have an angry personality, the odds of you having a heart attack is 3 times. If you have high blood cholesterol, 3.5 times. And if you spend 1 hour in the traffic, inhaling all the pollution that comes from the motor vehicles, look at the odds of having a heart attack. Much more than if you have had high blood cholesterol levels. Now, that is the impact of air pollution on cardiovascular diseases. Tuberculosis is a very common problem that affects our country. And it's important for us to understand what are the risk factors associated with tuberculosis. Now, this is a very nice and very important study that was derived from 22 countries, and they looked at the risk factors associated with TB. I have shown you a pie chart over here. This is one risk factor, purple shade, another risk factor, dark brown shade, another risk factor, green, and so on. Can you tell me what are these risk factors associated with tuberculosis? Malnutrition contributes to 34% of the risk for developing TB. Indoor air pollution contributes to 26%. Smoking contributes to 22%. Alcohol, 13%. HIV infection, 7.3%. Diabetes, 6.3%. Perhaps we may have known these risk factors, that these are risk factors for TB. Little have we really appreciated the impact of other risk factors, including indoor air pollution. Indoor air pollution has also been shown to be associated with the risk of developing lung cancer in women. A very large study in 71,000 women from China. And you can see that the risk varies from 1.5 times to almost a 2-fold greater risk of having lung cancer. You are fat not only because of what you eat, but you become fat because of the quality of air that you breathe. Is a new research revelation. It is only recently that we have started understanding that air pollution gives rise to obesity. These pollutants are called as endocrine disrupting chemicals or obesogens. When you inhale them through your lungs into the systemic circulation, they have the ability to directly impact your endocrine organs. And through that, they can cause metabolic syndrome and give rise to the generation of obesity. So the quality of air that you breathe is one of the critical determinants of having high body mass index. It's not only about the food that you eat or the lack of exercise, it's the quality of air that you breathe is also a major determinant of air pollution. This is a study that was published a few years ago from China. Pregnant rats divided into 2 groups. One group received polluted air from Beijing. One group received filtered air from Beijing. So polluted air, non-polluted air. Pregnant rats. The pups that were born to them, those who were exposed to polluted air were heavier than those who are exposed to clean air. So the babies become fat when the mother is exposed to air pollution. Not only that, but look at the levels of malonyl dialdehyde. So this is metabolic syndrome type findings. So this is oxidative stress. So white is clean air exposed rats, and this is polluted air exposed rats. Look at the amount of oxidative stress that is present in the lungs, in the liver, in the spleen. All organs get affected. The antioxidant levels, as you can see here, glutathione, is significantly reduced in the pups that are born to mothers who are exposed to polluted air. And then if you look at the LDL, the LDL or the total triglycerides and the total cholesterol is very high, something like a metabolic syndrome. So you can develop a metabolic syndrome type of a picture if you're exposed to air pollution. Is one of the new research findings that we have started appreciating. So this is my last slide that talks about the summary of harmful effects of air pollution. The growing fetus gets affected. Lungs are affected in the form of infections, asthma, COPD, lung cancer. The cardiovascular system of the heart gets affected in terms of hypertension, ischemic heart disease, and heart failure. All of them have been shown to be very strongly associated with air pollution. The vascular system is stroke. You can develop paralytic attacks because of exposure to air pollution. Endocrine disrupting chemicals, as I said, gives rise to obesity, diabetes, and metabolic syndrome. And even the brain also gets affected. Your cognition is affected. It leads to depression. And a lot of people develop Alzheimer's because of exposure to air pollution. So I think it's important for us to appreciate and start realizing that air pollution is a big problem that we should be aware about. The last slide, and this is just showing you the correlation between air pollution and the risk of developing a COVID infection. This is a map from Italy. This is the map of Italy that shows you the COVID density in terms of a heat map, and the same map of Italy showing you the mean particulate matter pollution levels. And you can see they almost mirror each other. In places where the pollution levels are high, there are more COVID-19 cases. And there seems to be a very strong recognition now that areas where the pollution levels are high, you will get more COVID-19 positive cases over there. So with this, I will stop over here. And if there are any questions, please send them to the chat box. I would be more than happy to answer them. Thank you very much.
Thank you very much, sir. Sir, can we have a second topic by Dr. Rajadhar? Because
Yeah, we can.
Yeah.
For that, I just want to make a single announcement. This session and along with the next two topics, these are on behalf of Indian Chess Society, Maharashtra and Vidarbha Chess Association in association with IMA Nagpur. And we have Dr. Aditya Parihar, Dr. Rajesh Ballar, and Dr. Sudhir Chafle as chairpersons for this session. Over to you, Dr. Aditya.
Yeah. Sir, Dr. Rajadhar is there because next talk is on.
Yeah, we would be having a recorded presentation of Dr. Raja.
Okay.
We would be just playing it right now.
Yeah.
And then we would like to felicitate our speaker, Dr. Sandeep Sarvi. Sir, please accept this memento on behalf of Team NIMACON. It was our honor to have you here. And it was a wonderful lecture with an eye-opener. Thank you so much.
Thank you. Thank you so much. Thank you very much. I appreciate it.
Yes.
Yeah, we would be starting the next recorded lecture of Dr. Rajadhar. As we know, we hear, we see, we think the COVID. And he's going to talk about COVID pitfalls and
COVID infections.
Management.
A big thank you to the organizing committee of NIMACON. There's been various obstacles on the way, in spite of which we are seeing NIMACON today. The world is in the middle of a pandemic, and I'm going to talk about this pandemic very briefly in a period of 12 to 14 minutes. Hence, I have taken the speaker's prerogative for selecting something in the basket of COVID, which I think is useful, rather than speaking about pearls and pitfalls generally, which is not something that I would manage in the time given to me. So I'll talk to you about a case that you would see in your clinical practice, and I will talk about various facets of management with special emphasis on secondary infections, which is an important problem in COVID today. So I bring to you this man that I admitted in the middle of the second wave about 2 weeks ago. This is a 37-year-old man who is a cashier at a bank, unmarried, living with a mom who has multiple comorbidities and is elderly. They live in a small apartment, and she presented to me, or he presented to me, on an online consultation with bog standard symptoms of a sore throat and myalgia and fatigue. The symptoms started 4 days ago, and the first symptom was a mild throat irritation. He did not have any worrying symptoms, no shortness of breath, no anosmia, no GI symptoms, had no comorbidities. He was a fit young man and had observations which were essentially normal. 2 days later, because of these symptoms of throat irritation and myalgia, he went out and had a test done, and the RT-PCR for SARS-CoV-2 came back as being positive. Note the value of the NG, which was 27, which would indicate a low viral load. Just to try and reiterate that a low viral load based on the cycle threshold value on an RT-PCR test does not seem to correlate well with the severity of the disease. And this is something that I'm also going to illustrate in this particular case for you. So we discussed with the patient on an online consult, and we agreed for home isolation. Because he had visited a hospital to get his test done, he also got some baseline bloods done at the time. And just to sort of repeat, this is not essential. This is something we did in this gentleman because he was in a hospital setup. He had a total count of 9,600. Note the lymphopenia. The lymphopenia is important. Lymphopenia, we've heard over a period of time, is an important prognostic marker. Progressive lymphopenia is an important prognostic marker, and an LRR ratio, a neutrophil lymphocyte ratio, which is low. So a neutrophil count which is low and a lymphocyte count which is high indicate poor prognosis. And along with the D-dimer, which was normal here, together they provide the best prognostic markers in patients with COVID-19 infection. So we started the antiviral early, which is the dictum that I follow myself. So it's a viral illness. And hence, if you have a relatively innocuous, less side effect antiviral, start it early. So we started the favipiravir at the standard dose. We gave him enoxaparin at home for 5 days, which was the protocol in Bengal at the time. And the patient was started on the normal box standard vitamins. We have no evidence these vitamins work. However, there's some observational studies which show a little bit of benefit. They do no harm. And that's the rationale of giving these medications. So let's try and answer some of these questions which come to mind. I think they're important questions that will probably come to your mind too. Does this patient need an antiviral? And I think I have answered that question for you already. It's a viral illness. We know that favipiravir seems to work early in the course of the disease rather than in moderate disease. And hence, starting an antiviral early with mild or very mild disease seems to be a rational thing to do. How do you select a patient regarding when to give an antiviral and when not? And I have said that I would give an antiviral in most cases, maybe not in patients who are asymptomatic, patients who are accidental detections or contacts of patients who have symptoms. However, in the remaining population, I would tend to give the antiviral, which in this case is favipiravir. When do you think this patient needs empiric antibiotics to be prescribed? So I'm not for antibiotics for everyone, unless the patient has cough with purulence, unless the patient has disproportionate fever, unless the patient has consolidation on chest X-ray, which might indicate more than a COVID infection, I would not give empiric antibiotics to everyone. Would the prognostic inflammatory markers influence your decision to prescribe antibiotics? It probably would do. If I have a CRP which is significantly high, it would push me towards prescribing an antibiotic. If I have lymphopenia, like I said before, it would not change my prescription. However, what it would do would be to push me to monitor this patient more closely, because these are the patients who develop severe COVID and might become hypoxic, needing hospital admission. Would radiological assessment influence your decision? That's a good one, because this dictum has changed with the passage of time. Initially, we said that a radiology in an asymptomatic patient or a mildly symptomatic patient doesn't matter. Now we know that if the CT score, the CT scan score of more than 14 can be an indication of severe disease by itself, it would be an independent predictor of poor prognosis. And hence, these patients, you might want to admit these patients and give the patient the IV antiviral in the form of remdesivir. Or you would probably start the favipiravir at home more proactively. So yes, radiology, CT scan does to an extent influence your decision. What antibiotic would you want to use in this scenario? So the choice lies between 3 antibiotics if you're giving it at all. And I've told you what these antibiotics, what the indications are in my book. So in my book, the 3 antibiotics that I would consider is a coamoxiclav, and azithromycin and doxycycline. You know, there's a little bit of evidence to show that both azithromycin and doxycycline have some antiviral effect along with their antibacterial effect, and they hence they get chosen often. However, if you're worried about a secondary infection, a beta-lactam antibiotic in the form of coamoxiclav is likely to be a better choice. So that's my thinking about case 1. Let's now come to case 2. So this is a 50-year-old man who's a doctor. He's a consultant physician who works in a tertiary care, that should be tertiary care, so tertiary care hospital, and involved in the care of COVID-19 patients. He presents with dry cough and a high-grade fever of more than 104 for 2 days. So that should send your alarms ringing. So while this could be just COVID infection, equally, a high fever increases the possibility of a co-infection or a superinfection. So that's why your antenna will go up when you see a fever that's as high as that and it's lasted beyond 48 hours. He, however, does not have any other symptoms, no breathlessness, no GI symptoms or other complaints. He's diabetic, so that's an important comorbidity anywhere, but especially in our country. The symptoms, like the previous gentleman, started with generalized weakness, tiredness, lethargy for the past 10 days. He gets admitted to the hospital because of the high fever. His saturations are fine. His temperature is high, and his other observations are normal. And the chest is clear to auscultation. 1 day after admission, so the subsequent day morning, he has his RT-PCR sent off. The RT-PCR comes back as being positive. You can see the viral load is greater there. Here, if you go by the CT value compared to the previous one, the chest X-ray shows a right lower lobe opacity, and the CT shows a subpleural ground glass opacity along with ground glass opacities in the lingula and the left lower lobe. And you can see, but I'll point out to help you, the areas of ground glass opacity, the right middle lobe, the right lower lobe, and the left lower lobe is what you see. So those are definite areas of evolving consolidation. Because this patient only has a fever as a symptom, the patient gets started on favipiravir on day 3. Standard dose. He also gets given according to, this is not one of our patients, this is actually a patient from your state, the patient from Maharashtra, gets given doxycycline, ivermectin, vitamin C, zinc, and vitamin D3 as per protocol for all patients. And then this patient has enoxaparin initially prophylactic, and then when the D-dimer climbs up on repeat testing, the enoxaparin is changed from prophylactic to therapeutic. The fever subsides on day 5 after admission, the patient is better, and discharge is being planned. Day 7 proves to be a bad day for this patient. Spikes a high fever again, 102 degrees Fahrenheit. He desaturates to 84% on room air, 96% on 3 liters of oxygen. He develops new crackles at both bases. He's tachypnic with a respiratory rate of 28 per minute, and he gets transferred to intensive care. The chest X-ray shows bilateral lower lobe opacities like before, but they're far more dense. So this is a more organized consolidation that you see now. The total count is 18.5. The CRP is risen sharply, it's 162. You can see the D-dimer is sort of shot up from about 500 to 2,500, and the procal is high. So we order an HRCT, and this is important. This is one carry-home message I want you to take with you. Day 7 or 8, patient getting worse, think of these possibilities. Think of a cytokine storm. If it's a cytokine storm, your procal and your CRP is going to be low, and your IL-6 is going to be high. So low procal, high IL-6 beyond day 7 usually would indicate a cytokine storm in the presence of increasing oxygen requirement. The second possibility, so reverse. So if you have someone who might have a secondary infection, you will have a raised procal, a raised CRP, but the IL-6 also is going to be raised and raised disproportionately. So raised IL-6, raised procal, raised CRP or rising titers of CRP and procal might indicate a secondary infection, again, in the background of worsening hypoxia. Then the important possibility we miss out often, not much of change on X-ray, the CRP hasn't changed a lot, worsening D-dimer, thick thromboembolic disease. So this patient falls in that category too. The procal has risen, however, the D-dimer is also worsened. So along with secondary infection, thick thromboembolic disease, and both of these can coexist as we have seen in some of our COVID patients. And then you can have heart failure, you could have COVID myocarditis, etc. So that's the CT scan. You can see the dense consolidation, the pneumonia in both lower lobes. The antibiotics were escalated, sputum was sent, the methylpred was given at 60 milligrams twice a day, the Clexane was increased to a therapeutic dose, and supportive medications were given. Sputum was tested, which showed Diplococcus, looked like strep pneumoniae. The sputum culture showed pan-sensitive strep pneumoniae. The patient was continued on the medications that we described. The question arises, sicker patient, higher viral load, how would you decide between remdesivir and favipiravir? So to be honest, if this patient had come in with the observations that I described on day 3, so hypoxic requiring oxygen, I would have gone for remdesivir first up. However, given the fact that this patient was on favipiravir, we diagnosed a secondary infection here. We thought we might let the antiviral continue the way it is, which is why we went on with favipiravir. Do you think HCQS and ivermectin helps? I personally don't. I never prescribe HCQS and ivermectin, but I guess there are state protocols to be followed because of which this drug got prescribed and got prescribed. Do you think the initial management should have been different? No, I don't think so. I would probably manage the patient the way it was managed. I think the management, aside from the ivermectin and doxycycline, the HCQS was appropriate. Do you think we should have started empiric antibiotics? I think not. I think at the beginning, what was prescribed was right, and it's always easier on hindsight. So this is my carry home message that about 3.5% of patients come in with 2 bugs, so COVID-19 and a second bug, which might be a virus or a bacteria, but about 15% of patients, so 1 in 6 patients will have a secondary infection after presentation. And about 72% of patients get an antibiotic on presentation. So this is about disease progression. Patients get a secondary antibacterial infection. Because it's in a hospital scenario, the bacteria is often antibiotic resistant. So you get MDR bugs. And depending on the promptness of initiation of treatment, the patient would recover, or this would be a cohort of patients who have mortality. And this is a paper which looks at percentage of patients with COVID-19 with bacterial co-infection and secondary infections. You've looked at the numbers that I showed you, and I will finish off there with messages about bacterial pathogens. The fact that most of the co-pathogens were either mycoplasma or Haemophilus. In some patients, there was Pseudomonas. So those are the bugs that you need to cover when you think about co-infections. And in antibiotic prescribing, your best broad spectrum cover would be with the co-amoxiclav or with the fluoroquinolone, along with a 3rd generation cephalosporin. So that's my carry home message. I know I've not covered a lot in the spectrum of COVID, but I think you might find what we have covered useful. Best of luck for NIMACON 2021. And I hope the world recovers from the second wave of COVID-19 soon, and we can go back to the new normal and live our lives the way we want to. Stay safe and stay healthy.
That's a wonderful talk by Dr. Rajadhar. Am I audible?
Yes, yes, you are.
Yes. I think Dr. Rajesh Ballar has also joined. Sir Ballar, sir, over to you. Sir, unmute yourself. Bala, sir.
Are we taking any questions?
No, sir. Question answer session is in inbox, chat box.
Okay, so we are not taking any questions live.
Yeah.
Yeah.
So,
Yeah. Yeah.
sir, the next. Ma'am, the next topic is on.
I would be going in that.
Yeah.
Yeah. We heard Dr. Rajadhar, who is Director and Head of Department of Pulmonology, CK Group of Hospitals, Kolkata, and Director Research and Education, National Allergy.
Yeah.
He is the ICS National Representative for ERS, and he is the Joint Secretary of Indian Academy of Allergy, and a vast CV to depict. Sir, we want to felicitate you with this memento and a bouquet as a token of appreciation from Team NIMACON. Thank you, sir. Now inviting the next speaker, Dr. Pratibha Dogra. Madam is a consultant respiratory critical care and sleep medicine at Pratiksha Hospital, currently working on developing new models of care integrating complementary therapies in insomnia and other fields of sleep medicine. She has an extensive experience in management of all aspects of respiratory pathologies, and she is involved in various research projects. She is a founding member of SEASM, that is Southeast Asian Academy of Sleep Medicine, and she is going to talk on obstructive sleep apnea. I welcome you, madam.
Yeah. Thank you. I'm going to share my screen. So am I audible?
Ma'am, you are audible.
And the screen is visible. So shall I start?
Slides are definitely visible.
Okay. First of all, thank you so much to the NIMACON organizers, Dr. Rajesh Swarankar, for giving me this opportunity to speak on this esteemed platform. So topic of my discussion is obstructive sleep apnea, and I'm very glad that this topic has found its right place to be on the right platform, which I would really like to discuss with all the physicians. So to begin with, what is SDP? So sleep disordered breathing is an umbrella term which tells us about the effect of sleep on breathing, and it includes central sleep apnea, chain stroke respiration, nocturnal hypoventilation, and obstructive sleep apnea. Now, obstructive sleep apnea is the most common of the sleep disordered breathing, and it is caused by partial or complete collapse of the upper airway, which is characterized by repetitive pauses in breathing during the sleep despite the effort to breathe. So to be, if I have to simplify it, this is the pictographic representation of the pathophysiology, very simplified version. So this is the point of obstruction to the passage of air that is happening. So in case when the tongue falls back, or due to various other reasons, if there is any obstruction here, which leads to the narrowing of the passage or complete obstruction, that leads to apnea. Either there is cessation of the breathing while the patient is sleeping, or there is decrease in the flow of air. Just give me 1 second. I just need to remove this. So why we want to talk about sleep apnea? Because it has become, it's like a global burden is huge, and it has become almost a public health hazard. And if we talk about prevalence, in America, 26% of adults aged 30 to 70 have sleep apnea. And this study, which was published in Journal of Clinical Sleep Medicine in 2013, it has very beautifully kind of conveyed the message that South Asian population has more kind of predisposition or at a higher risk of developing OSA. Not only OSA, but the OSA with a higher AHI, and the South Asian ethnicity, independent of demographics, BMI and comorbidities, is associated with increase in AHI compared to white Europeans. So that means that our side of the population is more at risk of developing OSA. And if we look at India, the various community and survey-based studies that have been done, that estimates the prevalence of OSA anywhere between 3.5 to 19.5%, of the population, with males having, are more predisposed to have this problem than the females. And when we kind of translate it to the economic cost or the economic burden of the disease, it has been beautifully kind of, tagged as the price of fatigue, the surprising economic cost of the unmanaged sleep apnea. And it, if you just look at the numbers, they say identifying the costliest and the sickest upper third of OSA patients will reduce expenses to the healthcare. The economic burden which is related to untreated OSA is substantial, accounting for billions of dollars per year. So what is this sleep apnea doing? As Dr. Sandeep Salvi's, talk, he also talks about the pollution leading to metabolic syndrome and leading to everything else that, it can affect every system of our body. Similarly, OSA also comes out to be a systemic metabolic, it just leads to metabolic syndrome, and it also has an impact on almost every system in our body. So when apnea is happening, so this is the physiological changes that come when the patient is having obstructive sleep apnea. So when there is a blockage that is happening to the breathing, the saturation is falling. So that is the direct impact. Now, because so much of an effort is going on in overcoming the obstruction, there is negative swings in the intrathoracic pressures, which will lead to further changes, leads to surge in sympathetic nerve activity during the night. Now, during the night, as we all know, that everything, the parasympathetic activity is the one that increases, and everything just slows down, from your blood pressure to the heart rate to the sugars, everything goes down. But with this kind of situation happening through the night, there is a surge in the sympathetic activity, which further leads to various effects in the body, like increasing the blood pressure. And even during the night, patients can have increased blood pressure and they're predisposed to have the hypertension. So when we talk to the patients and we try to explain why, how OSA is impacting their life, the direct impact is the fragmentation of the sleep. So because every time your saturation is falling, the receptors, they lead to microarousals in the brain. Whenever the microarousal is happening, the patient, the mind goes back to the, from the deeper to the deeper stages of sleep. So this is the normal sleep pattern, and it happens in cycles. And the sleep is happening in stages from 1, 2, 3 to 4. And this is, of course, this is going from the lighter to the deeper sleeps. But when the patient is having desaturation, suppose every, maybe every minute or every 2 minutes, and there is so many of microarousals that lead to the fragmentation of sleep, the sleep is not consolidated. As a result, the patient gets up with unrefreshing sleep and is drowsy through the day. So that is the direct impact of OSA, and indirect impacts are many, which may take years to come and which the patient may not be really aware of. And this includes various metabolic, problems that comes in, like the insulin resistance, weight gain, nocturia. So now there are various studies which have now proven that OSA, there is a causal relationship between OSA and various disorders. Now this study proves that the cumulative incidence of both non-fatal and fatal cerebrovascular syndrome is much higher in patients with OSA, in patients who have severe OSA, but the same patients, if they use a CPAP, the kind of the prevalence or the incidence is almost similar to the patients who don't have OSA. So diagnosing OSA and treating it with its CPAP is almost prophylactic. Mortality in heart failure, now this has been established that AHI is directly proportional to mortality in heart failure. So as the AHI increases, the risk of mortality in heart failure also increases. In diabetes patients, also it has been found that sleep apnea is pretty common, and this is a sleep heart health study, and they say that greater the rate of sleep disorder breathing is found in diabetic patients. So this is almost my urge to the physicians to be like, really be, increase the awareness or increase your, to be more sensitized to kind of, find out the patients with diabetes who are at risk of OSA. Because if we are treating diabetes and along with that we treat OSA, we'll be benefiting the patient a long way. So again, the pathway is established now. Almost we know this, that there is sleep apnea. This is the pathway through which it leads to, there's more risk that patient will develop diabetes, or if the patient has diabetes, it may be very difficult to control that diabetes. Even in hypertension, OSA is more common in hypertensive than control. Again, this various, now we have great database and evidence is there to support these facts. Again, it is related to atrial fibrillation. So almost every system in our body is affected by obstructive sleep apnea, which is untreated. The larger sequel, if you look at the larger picture, now this is the reason because of the OSA and the fragmented sleep, the patients are at more risk of motor vehicular accidents, industrial accidents, neurocognitive impairments, mood disorders. And again, it's a pictographic representation of how every system, OSA is found in all these diseases, like in stroke patients, 63% of the patients will have OSA. Similarly, in depression, type 2 diabetes, obesity. So OSA is linked with all these things. And again, to reiterate my point, diagnosing OSA and treating OSA is almost prophylactic if we do it at the right time. So how do we go about diagnosing OSA? Well, like any other disease, we need to go to the similar, protocol of taking a detailed history, physical examination, evaluating comorbidities, and the golden standard is polysomnography. If we look at the symptoms, what are the symptoms we look at? Any patient who complain of excessive daytime sleepiness, feeling tired, lack of energy or fatigue, early morning headaches, or the patient's having concentration and memory problems. Any patient is having, depression, anxiety, which is new onset and which is difficult to explain, learning difficulties in children. Also the patients, again, who have diabetes or hypertension in early ages. Again, these are the patients who are at risk of OSA, or we should consider them evaluating for OSA. When you talk about the nighttime symptoms, the patient complain, or usually the partner, it is the partner who comes with a, complaint that there is snoring, the partner is snoring. Frequent urination is there, irregular breathing during sleep, and this is known as witnessed apneas. The partner is usually able to tell that, the patient is like, sometimes gasping for breath. The breathing stops, and we call it as witnessed apneas. There is night sweats, increased cough. There's patients come with this problem of excessive dryness of mouth when they wake up in the morning. So all these symptoms are associated with the patient or determine if the patient is having OSA or not. Now we also have various screening questionnaires which can be used in the OPD basis, which help us to kind of screen and help us to understand who are the patients which can be at risk and who can be evaluated further. So one of this is stop-back questionnaire, and this has been very well validated to understand the risk the patient has. And this is the simplest questionnaire, and it's very easy to use. So if we can just spend some time with the patient and help them, ask them to fill this questionnaire, this definitely will help us to kind of narrow down the patients who are at risk of OSA. Another thing we talk about is the ASM, that is American Academy of Sleep Medicine, OSA task force, which are the physical findings that may suggest OSA. So the patient walks in your OPD, and just a look at the patient, can help you understand, okay, this patient can have OSA. So there's going by this, the standard ASM has given us is the increased neck circumference of more than 17 inches, BMI of more than 30 kg per meter square, Friedman class 3 or greater, nasal abnormalities, retrognathia, lateral peritonsillar narrowing, macroglossia. So these all things, if you just you just have to, while examination, if we just look at the face of the patient, we call it as the craniofacial anatomy, that is very obvious. And if we just ask the patient to open the mouth, we are able to define which Friedman class the patient belongs to, and all these things can be very obvious, the tonsil is, the tongue is big, or the uvula is elongated, or if you just see there is a lateral narrowing is there because the tonsils are enlarged, or this, I was talking about the retrognathia, when the chin is receded, and again this decreases the space at the back of the tongue. So anything, I will say, in the mouth cavity, if anything is there which decreases the cross-sectional area at the back of the tongue, which is our airway, that will put the patient at the risk of OSA. Deviated nasal septum. Okay, so next comes who needs to be tested. Any patient who says excessive daytime sleepiness. This is usually, a complaint that comes from the males, but females will be more like they have chronic fatigue or tiredness. Snoring, of course, is the first thing that we ask. Witnessed apnea almost become diagnostic for OSA, and if the patient is having comorbidities, And then there is a screening questionnaire which kind of put the patient at the risk of OSA should be screened. So when we talk about OSA, this is something that comes to our mind. This is almost like sleep apnea personified. This is the kind of image that comes. The patient is obese and has more, the parapharyngeal fat is more. And we think, okay, these are the patients who have OSA, but then what about these patients? Patients with who are lean and thin with the right amount kind of weight. But again, because of the craniofacial anatomy, these patients, or because of various other, things we talked in the previous slides, can also be at the risk of OSA. And if they have all those symptoms, and this is the sleep study of the same patient, and which showed that this patient has OSA, these are the apneas that were seen during polysomnography. So how do we prepare the patient for the sleep study? So the patient's question is like, we need to discuss with the patient the importance of sleep apnea and its relevance to many diseases. Explain to them what a sleep study entails, that it will involve the leads or spending the night with a technician. So it's something like, we always tell this is something like we, get the ECG done or the Holter done, that you will be hooked for the night and you sleep with it. A little bit spending a time with the patient increases their confidence to go ahead with the study. The frequently questions which are asked by the patients are like, what to do about the medications at the night of sleep study. So the answer is that whatever they are taking should be, that they should continue with. Even if they're taking some pills for sleep or some sedatives, they should continue with the same. Yes, they are able to use the loo even when they're hooked on. We should be able to explain the discharge process in case the study is being done in hospitals, which in the COVID times, it's hardly being done. And again, some instructions which we'd like to give is that they should not oversleep before the nights, before the day of the sleep study. What are the types of sleep studies which are available? So we can label as type 1, type 2, and type 3 devices. It depends upon the number of channels that we are using. The type 1 devices, which is a full polysomnography and which is the gold standard for OSA, which includes almost like 24 channels. And in this, we are also using the EEGs, which is helping us to do the staging of the sleep. That is, can be done. EOG is your eye movements, EMG. So this is a full polysomnography, which gives us a complete information of what is happening. And definitely it is done in patients who have a lot of comorbidities. Now the ambulatory PSD, which is almost similar to type 1, but which can be done at home and where the technician has to supervise. So this also falls into the level 1 kind of a study. But now with the the pandemic that all of us are going through, this has almost become a little difficult to carry on because of the risk of infection. So what is now being used is more or less the polygraphy, in which the number of channels are less, and we don't need a technician to be by the side of the patients. And we say that the patients who have the high pre-test probability, we can go ahead with the type 3 or the level 3 devices, which are equally, beneficial in at least diagnosing the patient. So yes, level 3 devices or the level 3 studies are here to stay through the pandemic, and they are helping us to diagnose and treat the patients. What is AHI, is the apnea hypopnea index. Now this is the matrix on which we kind of diagnose, and we are able to kind of tell the patient is having mild, moderate, or severe OSA. AHI of 0 to 5 is normal, 6 to 15 is mild, 16 to 30 is moderate, and 31. So this is the primary metric that we look into while we are diagnosing, or we are kind of telling the patients they have mild, moderate, or severe apnea. This is just how the window look like, all the channels, like this is the picture that we get. Now this is the level 1, type 1. This is the sleep stages and the eye movements, and there is a thoracic abdominal movements, snoring channels. So all these channels, saturation. So there's a kind of extensive and exhaustive data that we get when we are doing the studies. This is a polygraphy which uses a minimum of 5 channels, where we look at the flow and the movement and the saturations. This is a minimum we look at when we have to diagnose a patient as an obstructive sleep apnea. And this is level 4, which is again a screening kind of a thing. We just look at the saturation, and if the patient's saturations are dipping, we can actually also understand that this patient has a risk of OSA and should be evaluated further with the proper sleep study. And again, we are lagging a lot. India is lagging a lot. I would say we are still way behind the curve as far as the awareness is concerned and the number of studies we are doing. And if we have to match up with our Western counterparts, India need more than 20 crore polysomnographers per year still to match with Australia. So yes, a lot of, I think this can come only if the respiratory and sleep physicians get all the support from our physician counterparts. So we need to get the patients, referred specifically, like, from the, the cardiologist and the diabetologist. Sleep study can be done as a usually done in twin night studies. I will not get into the detail because of the, just keeping the time in concern. So another thing is like, how do we choose when we choose which study has to be done? So again, what is the clinical question? What is the scale of the problem? Issues of reimbursement, cost, logistics, and if we do have a backup plan. Because there are various studies can be done, but to choose the study for a particular patient, that should be the physician's right, or that should be the physician's, should be involved in when we, try to understand this patient needs with study. So we have many tools in sleep apnea. There are various level of studies, and to treat also we have various kind of machines. There's the CPAP or auto CPAP or the bi-level. So it all depends, after titration, what is that the patient is requiring. But yes, once we are able to diagnose and titrate, we will really be able to help the patient. Thank you so much for your kind attention.
Thank you, madam.
You're most welcome.
This was really an awakening talk, and we would like to felicitate you with a token of appreciation. Please accept this memento on behalf of Team NIMACON.
Thank you so much. Thank you. I hope this will be useful for all of you.
Yeah, definitely, ma'am. And I take this opportunity to thank the chairpersons for this session, Dr. Ballar sir, Dr. Parihar sir, and Dr. Sudhir Chapli. Thank you so much. Your inputs were very valuable. Thank you so much.
Moving to a session from CGP. India is emerging as a diabetic capital. There is change in the management of diabetes over the years. Let not diabetes stand in the way of enjoying life with sheer determination for positive approach towards diabetes and living with diabetes. Our next speaker is going to speak on management of diabetes. We have Dr. Pradeep Rajdekar sir and Dr. Vandana Kate ma'am as chairpersons. Dr. Pradeep Rajdekar sir is past president IMA, practicing family physician since 30 years, active member of IMA since 20 years, chairman of various subcommittees of IMA. Dr. Vandana Kate ma'am is Vice President IMA Maharashtra State, Assistant Director CGP IMA Nagpur, President Rotary Club of Nagpur North Hills, Joint Secretary IMA Nagpur. Over to you, chairpersons.
Good evening. Am I audible?
Yes, ma'am.
Good evening to you all. Changing paradigm of diabetes management in last 3 decades. Very important topic for general practitioners in this CGP session. General practitioners are the backbone in healthcare of society, are the one who first see the patient, and so they should be get abreast themselves with changing paradigm. Our today's speaker is Dr. Pramod Gandhi, GMC alumni, well-known consultant, endocrinologist of Nagpur, Director, Kingsway Hospital. He was past president of AMS, DAI, and secretary of Maha Endocrine Society. He has conducted over 100 of diabetes detection camps and many educational programs for the public. Also organized national workshop on on diabetic food. Many publications at his credit. Dr. Gandhi to proceed. Thank you.
Yeah, thank you, madam. I hope I am audible and my PPT is visible to all of you. Yeah. So what I'm going to discuss in next 15 to 20 minutes is changing paradigm in the diabetes management in last 3 decades. Now, I would like to tell you here that what we have learned during our post-graduation or during our DM, while doing DM at KEM Hospital, Mumbai, what we have learned in diabetes, we are not practicing. There are tremendous changes in the various aspects of diabetes management, which includes pathophysiology. The understanding of the pathophysiology has changed. The diagnostic criteria for the diabetes has been changed. There is new entity called as type 2 diabetes mellitus. There are newer therapies in the diabetes, which includes insulins as well as OHA. And the approach towards selecting these oral anti-diabetic agents and insulin has been totally changed. What I am going to start with pathophysiology. Initially, we always used to say that diabetes is due to these 3 pathophysiological defects, that is impaired insulin secretion, decreased glucose uptake by the muscles, and increased hepatic glucose output. Now here, our understanding from triumvirate has changed to ominous actate, where we have realized that it's not only these 3 factors, but then there are many more other factors which has been responsible for the development of diabetes and hyperglycemia in these patients. This is the ominous octet. From ominous octet, we have moved to dirty decade, and from there we have moved to dirty dozens as well. So these are the multiple pathophysiological risk factors which are responsible for hyperglycemia in patients with diabetes mellitus. The diagnostic criteria for both diabetes as well as pre-diabetes has been changed. 1985 WHO criteria was fasting of less than 140 was normal, which was changed to less than 110 in 98, and which was later on changed in 2005 to less than 100. So your fasting, if it is less than 100, it is normal. And previously there were only 2 terminologies: impaired glucose tolerance and fasting and diabetes mellitus. Now, impaired fasting plasma glucose is a new entity which has emerged in 1998. Initially, the levels for IFG were 110 to 126, and currently the IFG levels are between 100 to 126. The diagnosis of diabetes has been changed from more than 140 milligram of fasting to more than 126 milligram of fasting plasma glucose, whereas post-glucose plasma glucose has remained constant. HbA1c was never used as a diagnostic criteria in the past, but with the availability of the better equipments, the HbA1c has also been included as one of the diagnostic criteria for the diagnosis of diabetes. However, HbA1c as a diagnostic criteria should be used only if HbA1c is done by HPLC. Otherwise, no other method is acceptable. And hence, the current diagnostic criteria for the diabetes, diagnosis of diabetes, which are described in January 2021, these are the diagnostic criteria for both diabetes as well as pre-diabetes. Similarly, the diagnostic criteria for the gestational diabetes mellitus or pregnancy and diabetes has also been changed. The fasting plasma glucose of 92, 1 hour fasting plasma glucose, post-glucose plasma glucose of 180, or 2 hour plasma glucose of 153, or any one of these value, if it is more than these normal range, then we can say that patient has gestational diabetes mellitus. These are the IAD PSG guidelines which has been laid down in 2013. From that day onwards, we are following these are the diagnostic criteria. A new entity which has been introduced in the year 2002-2003. Whenever we used to, when we were doing PG, we realized whenever any patient of childhood diabetes comes to you, it was always type 1 diabetes or maybe secondary diabetes. But a new entity has come up in 2002, wherein we are saying that patients with type 2 diabetes can be seen in childhood. And especially, this is because of rising incidence of obesity. There is increased insulin resistance, and metabolic syndrome, which is responsible for hyperglycemia, high blood pressure, and early onset coronary artery disease in these children. A word about newer therapies. This year we are celebrating 100 years of insulin discovery. Now, though insulin was discovered in 1921-22, there are tremendous changes in the insulin therapy in last 3 decades. We used to say that we had only bovine insulin and porcine insulin which were initially available. Later on, subsequently, 1980 onwards, recombinant DNA technology has come up and human insulins were also developed. This was the slide. This is a slide which shows the 100 years of insulin therapy. Banting and Best, who discovered the insulin, who got the Nobel Prize for the insulin discovery. In last 3 decades, you can see there are a lot of changes, which includes not only human insulin, but a lot of insulin analogs has come up, and the bovine and porcine insulin has gone out from the market. These are the insulin analogs: aspart, glulysin, and lispro. These are the short-acting or rapid-acting insulin analog. Fiasp is a ultra-short-acting insulin. Glargine, detamir, and deglutide, these are the longer-acting insulins. Even nowadays, 300 IU glargine is also available, which is again a very long-acting insulin analog, which is available to us for the management of diabetes. You can see the action profile of all these insulins here. The insulin delivery devices has also been changed from syringes to pen to jet injectors to currently the insulin pumps. The insulin pumps has also been developed in 1964. You can see a huge size of insulin pump. From there, we have reached to a stage where we can see these are the very small sizes of insulin pump, which can be applied on the belt and can be used along with the glucose sensor. Currently available insulin pumps are the low glucose suspend insulin pumps, which are available to us, wherein if patient starts developing hypoglycemia, if we set a threshold at say 70 mg%, probably the insulin will stop delivery from the insulin pump. And the future is that we should develop an insulin pump which is fully automatic insulin delivery devices with minimal patient interaction. The device should record the blood sugar and try to maintain blood sugar in the normal range with proper insulin delivery in these patients. The oral antidiabetic agents, which has been developed in last 3 decades, though we were using sulfonylureas and metformin since long, in last 2 decades, 3 decades, we have seen that there are a lot of newer agents which are being used, and we have a huge armamentarium of anti-diabetic agents which are available to us for the management of diabetes mellitus in our day-to-day practice. Then when we have such a huge number of anti-diabetic agents, how do we select anti-diabetic agents? In past, we always remember we used to manage type 1 diabetes by bovine, porcine, or human insulins, which has been withdrawn in the market. But currently, we have various insulin analogs, which we have discussed for the management of type 1 diabetes. Similarly, for type 2 diabetes also, we always used to manage all our patients on metformin and sulfonylureas. But nowadays, we have alpha-glucosidase inhibitors, glitazones, incretin mimetics, which includes DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors. These are the drugs which are available to us today for the management of diabetes mellitus. Now, how do we select the anti-diabetic agents in this situation where we have multiple anti-diabetic agents which are available to us? ADA-EASD has came together for the first time in 2012. That is, ADA is American Diabetes Association and European Association for Study of Diabetes. Now, there was always a contradiction between ADA and EASD. This is for the first time in 2012. Both these organizations came together and they brought a position statement for the management of hyperglycemia in type 2 diabetes mellitus, wherein they suggested that all patients with type 2 diabetes mellitus has insulin resistance, and hence they should be given metformin as a first line of therapy, irrespective whether they are obese or lean, along with lifestyle management. If patient is not controlled on metformin, probably you can choose sulfonylurea, glitazones, DPP-4 inhibitors, GLP-1 receptor agonist, or insulin, any of these agents can be used as second line of therapy. If not control, maybe a third line of agent can be added. If not, probably insulin, initially with basal insulin and later more complex insulin regimes can be added for the glycemic control. But then how do we select these agents? Amongst them, if your target is to avoid weight gain, probably you are justified in using DPP-4 inhibitors or GLP-1 analog. GLP-1 analog has an additional benefit of weight loss. So if your target is to lose weight, probably GLP-1 receptor agonists were the drug of choice. Then if your target is to avoid hypoglycemia, glitazones can also be given. But if your target is to reduce the cost of the patient, probably sulfonylurea and insulins were the drug of choice after metformin. Now this has to be decided based on patients' we have to individualize the glycemic targets in these patients, and this is based on patients' risk associated with diabetes or hypoglycemia, duration of the disease, life expectancy, comorbid conditions, established vascular complications, patient preferences, and the most important thing which was never included was resources and support system which is available to the patient. But the whole management has really brought the change. In 2008, US FDA has brought a rule that all the anti-diabetic drugs which are being introduced in the market must have cardiovascular safety study done. Then only they will be approved for the use of management of diabetes. And then there onwards, there are n number of cardiovascular safety trials has been undergone with various drugs. I am just going to show you the number of clinical trials which has been done. These are the clinical trials which are done after 2008 till 2019 for the all anti-diabetic agents. And this has really changed our approach towards the management of diabetes mellitus. And hence, in 2021, the ADA has given the newer guidelines wherein they recommend that our decision for the anti-diabetic agent should be patient-centered, wherein we should try to prevent the complications and optimize the quality of life of the patient. And this is the algorithm, though this slide looks very busy and very complex, but I will try and make it simplified. This is very important. This is the most important slide for today's talk, which I feel, which everyone should be attentive to towards this slide. The first line of therapy is metformin. Metformin is the drug of choice as a first line of therapy along with therapeutic lifestyle changes. If patient is not controlled on metformin, then we should assess the risk factors or establish atherosclerotic cardiovascular disease, CKD, or heart failure evaluation. Should be done in all these patients. If there is definite established ASCVD, CKD, or a heart failure, or there are indicators of high risk of diabetes, then these are the therapies. Those patients with ASCVD or associated with high risk factors, we should give either GLP-1 receptor agonist or SGLT2 inhibitors as a second line of therapy, as a third line of therapy after metformin. And if not controlled with any of these two agents, you can add third agent and fourth agent and fifth agent depending on patient's glycemic control. But second agent should be GLP-1 receptor agonist or SGLT2 inhibitor only. If patient has past history of heart failure, that is heart failure with reduced ejection fraction especially, in these patients, SGLT2 inhibitor should be used as a second line of agent in these patients. These patients will be benefited in terms of long-term cardiovascular morbidity as well as mortality reduction. Currently available SGLT2 inhibitors are known to be associated to reduce the cardiovascular morbidity as well as mortality benefits. Those patients who has CKD, in these patients, if SGLT2 inhibitors can be given, preferably they should be given, especially those patients whose eGFR is more than 45. If eGFR is less than 45 or SGLT2 inhibitors are contraindicated, in these patients, probably GLP-1 receptor agonist can be given as a second line of agent. And if not controlled, probably these patients should be given insulin as a third line of agent. Now, this part we have discussed that those patients who has established ASCVD, CKD or heart failure, or there are high risk, how do we manage? Now, suppose if patient does not have any of these risk factors, or patient does not have established ASCVD, CKD or heart failure, then what do? We have different approaches. If we want to reduce the risk of hypoglycemia, then in addition to metformin, we should give DPP-4 inhibitors, GLP-1 receptor agonist, SGLT2 inhibitors, or TZD. Here you can see GLP-1 receptor agonist and SGLT2 inhibitors are the agents which are associated with weight loss. DPP-4 inhibitors are the drugs which can be weight neutral, whereas TZDs are the drugs which are associated with some amount of weight gain in these patients. If our aim is to minimize the weight gain or promote weight loss, GLP-1 receptor and agonist and SGLT2 inhibitors, and if our aim is to reduce the cost, then sulfonylurea, TZDs, or even other therapies which are available at lower cost, the drugs which can be availed at lower cost should be used. Currently, we know there are SGLT2 inhibitors which are available in lower cost. DPP-4 inhibitors which are available in lower cost should be used as a second line of agent in these patients. So to summarize, we can say that we have to, with the better understanding of diabetes and availability of newer therapies, our approach in patient management has definitely changed. Glycemic targets and blood glucose lowering therapies must be individualized based on the patient preferences, based on the comorbidities which patient has, and all the treatment decisions should be made in conjunction with the patient, with the focus on preferences, needs, and values of the patient. We are shifting our focus from glucocentric approach to comprehensive cardiovascular morbidity and mortality reduction for the management of diabetes. So in addition to glycemic control, we must focus on reduction on cardiovascular morbidity as well as mortality. Thank you. Thank you very much for your patient hearing.
Thank you, sir.
Thank you, Dr. Pramod Gandhi, for your lucid talk on diabetes update and what has changes it has happened in the last 3 decades. I'm sure this will be beneficial to all the general practitioners in their day-to-day practice. Thank you. Thank you.
Thank you, sir.
Thank you, Chairperson. Thank you, Gandhi, sir. Please accept a token of memento as appreciation from Team NIMACON.
Thank you, madam. Thank you.
Thank you, Chairpersons.
Next session, which is a talk on constipation and its management. And to deliver this talk, we have Dr. Prashant Bhandarkar with us, who's going to talk on it. The chairpersons for this session are Dr. Ravindra Zaharia, sir, and Dr. Nitin Gupta, sir. Dr. Ravindra Zaharia is a consultant general practitioner and past chairman IMA CGP. And Dr. Nitin Gupta, sir, is a senior consulting physician and also secretary of IMAMS and associated with IMA since long. Over to you, chairpersons.
Good evening, everyone.
Yeah, good evening.
On behalf of the IMA CGP, I welcome all of you, all the delegates who are present today on this talk of constipation, which Dr. Prashant Bhandarkar is going to give. Dr. Prashant Bhandarkar has been a consultant gastroenterologist and a hepatologist and a therapeutic endoscopist at Gastroenterology and Endoscopic Center at Nagpur. He was a former professor of gastroenterology at MGIMS Sevagram. His special interest is in therapeutic ERCP and hepatology. Dr. Bhandarkar had done his MD medicine in 1998 from our own GMC Nagpur, did his DNB in medicine in 1981, and DNB gastroenterology in 1994 from BL Nair Hospital from Mumbai. Let me tell you, Prashant was in the teaching line for almost 12 years. He was a lecturer in medicine at GMC Nagpur between 1989 and 1991, subsequently an associate professor in gastroenterology in 1994 to 2000 at GS Seth Medical College, NKM Hospital, Mumbai. He is a recipient of the Hargobind Foundation and J.N. Tata Endowment Scholarship for Studies Abroad. And he has been trained in therapeutic gastroenterology, GI endoscopy at centers in Europe and the USA. He's been a former postgraduate teacher for DM gastroenterology at Mumbai University, former editorial board and member of the Indian Gastroenterology. He has numerous publications and in national and international journals and textbooks and chapters. Something extra about Prashant, he's been a brilliant stage actor. His interest is in religion, philosophy, cricket, and he loves to sing. Let me tell you, Prashant's most memorable songs I have heard was from Silsila, Ye Kya Ho Gaya Hai Hame, and the sonorous voices of Amitabh Bachchan. Well, I invite Dr. Prashant Bhandarkar to start his talk.
Thank you, sir. Am I audible? Am I visible?
Yeah.
Okay. Thank you, Dr. Jha, for those really wonderful, kind, and warm introduction. And I'm really overwhelmed. Thank you very much. At the outset, I will thank the organizing committee, Dr. Gauri Arora, presidents of IMA, Dr. Archana Kothari, Dr. Sanjay Devtaye, and all the organizing committee for this honor. I would be speaking this evening on constipation and my slides are somehow not getting forward.
Sir?
Okay, so let us begin with defining constipation. Constipation is so common to all clinicians that we really wonder whether it needs a definition. Any difficulty in defecation, any less reduced frequency of defecation in straining, we all know is constitutes constipation, but there is a formal definition. And this has been laid down by the Room 4 diagnostic criteria for functional constipation, especially. I'll come to that in a moment, what is functional constipation. But if a patient has difficulty in defecation in the form of, say, straining during defecation more than 25% times, lumpy or hard stools, sensation of incomplete evacuation, sensation of anorectal obstruction or blockage in defecation, he uses manual efforts to remove the stools, or the stool frequency is more than 3 per week. Any two criteria out of these are sufficient to label the patient as having constipation. Most important is the patient should usually never has loose stools without the use of laxatives, and there should be no criteria for diagnosing irritable bowel syndrome. So constipation is the most common digestive symptom. Yes, I was telling you about what is functional constipation. Whenever there is an established cause of constipation, like patient may come with intestinal obstructions, patient may come with colon cancer, patient may come with any stricture in the colon, and that if it is causing constipation, you call it as there is a cause behind to that. That is called as secondary constipation. There are various causes of secondary constipation. Primary constipation, when there is no definite cause. So the topic for this evening would be primary or functional or idiopathic constipation, but I will also just enumerate what are the causes of constipation, secondary constipation. So how common is the problem? Global prevalence is about 10 to 30%. Indian prevalence, this is a study which shows that about 14% of Indians have chronic constipation, more common in women, and in the age group of 40 to 65, it is around 20% prevalence. So in your clinical practice, what is the type of patients who are likely to present with constipation? So advanced age and female gender, low socioeconomic status. If the diet is low in fluids or low in fiber, if there is a recent travel history or immobility or inactivity, say because of maybe any critical illness or a surgery, or patient is moribund, malnourished, or he uses a lot of medicines. So in your clinical practice, you can expect that these patients can have constipation. Then what are the causes of constipation? One is the idiopathic constipation, which we'll be discussing in detail, which consists of normal colon transit, slow colon transit, and dyssynergic defecation. But the secondary causes which can cause constipation, most important for us, I would say, is drugs. Then certain endocrine causes like hypothyroidism, diabetes mellitus, hypokalemia, pregnancy is an important cause, panhypopituitarism, neurogenic disorders like autonomic neuropathy. Diabetes, of course, causes constipation and a lot of GI symptoms because of autonomic neuropathy. Many CNS disorders like multiple sclerosis, spinal cord injury, paraplegia, Parkinson's, and the drugs used for all these conditions, they all cause constipation. But idiopathic constipation, when there is no cause, is classified into these three types. So, what are the drugs? Just a quick list: antihistaminics, antispasmodics, antidepressant, antipsychotics, iron supplements, antihypertensives. So I usually tell my patient that any allopathic drug can potentially cause constipation. But of course, we know there are drugs which cause diarrhea and not constipation. But we must always ask drug history and see if the patient constipation is because of diabetes. So as I said, what is functional constipation? When there is no cause. Functional constipation is classified into normal transit, slow transit, and defecatory disorders. Normal transit constipation is most common, which means stool traverses at normal rate throughout the colon. Stool frequency also may be normal. The symptoms are of difficulty in evacuation, bloating, pain, discomfort. Significant overlap with IBS, constipation predominant IBS. Slow transit constipation, in which colon transit time from cecum to rectum is very slow, so time is prolonged. The hyperperistaltic contraction frequency is reduced. Patients may, for days together, will not have urge to defecate. There can be bloating and discomfort. Here, in normal transit, there is usually urge to defecate. The frequency sometimes may be normal. You can have symptoms like hard stools, straining, manual evacuation, and so on. And defecation disorders is a particularly well-defined entity where there is difficulty in expelling the stools from rectum, and it is supposed to be because of poor coordination of pelvic floor and anal canal. Let me describe that in a bit detail. This is the pelvic floor which supports the pelvic organs. Then there are two sphincters in this. This is for the passage of rectum, and this is the urethra. So the proper defecation and proper micturition requires that the sphincters be relaxed and the pelvic floor should be relaxed. And pelvic floor, of course, consists of pelvic diaphragm, urogenital diaphragm, and these various sphincters, external anal sphincters, and so on. But in normal at resting state, the pelvic floor muscles are in a state of perpetual contraction, especially the puborectalis muscle, which is part of the levator ani muscle. It's a part of the pelvic floor. It is in a state of perpetual contraction. Because of this contraction, as you can see, a right angle is maintained between the anal canal and the rectum. And this is responsible for proper continence also. But during defecation, when the patient is squatting and straining, the puborectalis muscle, this relaxes, the pelvic floor goes down, there is a descent, the pelvic floor relaxes, and this passage, which was this angle which was acute, now becomes more straightened, allowing easy passage of motion. But in defecatory disorders, there is paradoxical contraction. The patient is trying to defecate, trying to strain and squat, but this angle remains same, acute angle. The puborectalis muscle paradoxically contracts, the pelvic floor does not relax, and that causes a sense of obstruction. The patient is unable to expel the stools from the rectum, and that is the defecatory disorder. And this can be alleviated to some extent. We want this angle, which is in squatting and straining. But in India, the commode seat, this angle remains acute. To make this angle more beneficial or more facilitatory for defecation, we need to put something called as the footrest below the feet, and this may lead to 2 times faster evacuation. So that is one thing which we can check and encourage in our patients. The importance of right defecation, because many patients with the onset of middle age or patients who have got arthritis, they start, you stop using Indian commode and they switch to Western commode, Indian seat, and switch to Western commode. So that is it. So when you take a footrest, the angle becomes more beneficial. Right. So how do we approach a patient who has constipation? You take a proper history, because you need to diagnose that the patient has constipation. Depending on the own criteria, you to evaluate the frequency of motion, whether it is hard stool, sense of evacuation or not, whether the patient uses any additional maneuvers like manual removal of stools, digital evacuation. What is the diet, whether it is low in fiber, what are his exercise habits, whether the patient already using laxatives or not, whether the fluid intake is adequate or not. You should look for any systemic causes of constipation, like patient may have symptoms of hypothyroidism, patient may have symptoms related to diabetes mellitus, there may be neurological symptoms, there could be a history of medicines the patient might be taking, or history of recent travels. These all point to a secondary cause of constipation. But most important feature in the history is what are known as alarm features. If these features are present, you must rule out secondary cause in particular, and especially colon cancer. So if there is sudden change in bowel habits or stool caliber, advanced age more than 50 years, if there is GI bleeding, overt or occult, if there is weight loss, there is anemia, patient has a strong nausea or vomiting, patient has clear-cut obstructive symptoms, or there is a family history of colon cancer, or there is stool occult blood positivities, all these are called alarm symptoms, and you should have a very low threshold, and you must advise early colonoscopy in such patients. Bedside digital upper rectal examination is important, because it will help you to identify, to some extent you can pick up defecatory disorders. When you put the finger in patient's PR rectum and put one hand on the abdomen, ask the patient to strain as if he is passing motion. Paradoxically, ideally the external anal sphincter should relax and the pelvis should descend down. But if there is defecatory disorder, the external sphincter will contract instead of relaxing. The pelvis will not move down, even though the patient is straining. So up to 75% you can pick up defecatory disorders by a digital rectal examination. So do we need to investigate patients with constipation? In a patient who is young, there's no alarm symptoms, recent onset constipation, maybe you really don't need to investigate, just give a trial of laxatives and see if the patient settles down. But many times, if it is middle age, the constipation has been long standing, you must always do a complete blood count to look for any anemia. You should do blood sugar, TSH, calcium to rule out diabetes, hypothyroidism, hypercalcemia, and so on. Colonoscopy is not performed in routine patients with constipation, only if there are alarm symptoms, as I told you, like blood in stools, anemia, weight loss, and age which is appropriate for colon cancer. Now, once having done this, you can easily you feel it's a idiopathic constipation, not a secondary constipation. You can put the patient on laxatives. If there is no response, then you can go ahead with the next level of investigation, wherein you the mentioned investigation of anorectal manometry and rectal balloon expulsion. We'll not go into the details of these investigation. Only thing, these are done in order to diagnose defecatory disorders. You suspect them when there is a failure of response to laxative. If the results of anorectal manometry and rectal balloon expulsion test are inconclusive, then you do what is known as a difficography. especially the MR difficography is more popular, and that has to be done. And if MR difficography or anorectal manometry does not show a defecatory disorder, then you must do colon transit studies to see if it is a normal transit constipation or slow transit constipation. One simple colon transit determination is by radio opaque capsule, which contains 20 radio opaque markers. The patient swallows that capsule, X-ray is taken after 5 days. If more than 5 markers are retained, that means it is slow transit. Like this patient, numerous markers are retained after 5 days in the colon. So this is a slow transit constipation. This is another thing for transit. You can use as a wireless motility capsule, which can actually give you segmental transit. It can give you gastric emptying, it can give you a small bowel transit, and it can give you colonic transit. So this can be this. So just to summarize the diagnostic approach, do an interview, physical examination, consider causes like diabetes, thyroid. Maybe you can do CBC and TSH and blood sugar. That is normal, means probably you're dealing with idiopathic constipation. Give a trial of fiber supplement and laxatives. Inadequate response, then you do anorectal manometry and balloon expulsion test to diagnose what is defecatory disorder. If it is abnormal, then it is a defecatory disorder and you treat accordingly. If it is normal, that means there is no defecatory disorder, then you do colon transit, whether it is slow transit or a normal transit constipation. But if it tests of anorectal manometry and balloon are inconclusive, then you do a MR difficography or a barium difficography. If it is abnormal, then again you diagnose defecatory disorder. So I think that is a very simple approach. Then we come to actual management algorithm. So for diagnosis of constipation, you need to take 3 things into account. You need to do dietary modification, you need to do lifestyle modifications, and you need to use laxatives. And 4th is the actual pharmacological treatment. So what is one is you need to counsel the patient, tell them that daily bowel movement is not really necessary. Somebody's mute, mic is not mute, I can hear background sound. So whether patient is taking adequate water intake per day, adequate fiber intake can be increased in diet itself. You can ask the patient to take some diet which is rich in fiber, like wheat bran can be added, green leafy vegetables can be added, fruits can be added. I told you the importance of right posture. Daily exercise should be advised. Avoid smoking, alcohol, avoid excess tea, coffee, avoid fatty and spicy food. And most important, avoid medications that cause constipation. But then finally, we need to come to laxatives. I can quickly summarize the types of laxatives which are available, which help in constipation, relieve constipation. These are the bulk forming laxatives, emollient laxatives, also called as surfactants or stool softeners. And then we have got osmotic laxatives, and finally we have got the stimulant laxatives. So which are the bulk forming laxatives? They act by binding water and holding water into the to the fiber, and increases the stool bulk and stimulates peristalsis. So both bulk forming and osmotic laxatives, they are water binding agents. They retain water in colon and increase stool bulk and facilitate peristalsis. In bulk forming, we have got natural fiber like xylem husk or wheat bran. Synthetic fiber is methyl cellulose. In osmotic laxative, we've got undigestible disaccharides like lactulose and lactitol, synthetic micromolecule called as polyethylene glycol, and saline laxatives like magnesium hydroxide, magnesium sulfate, and citrate, which we commonly see in milk of magnesia. Softeners are docusate sodium, docusate calcium, and mineral oils like liquid paraffin. Stimulant laxatives, we've got 2 categories: diphenyl methane derivatives like bisacodyl and picosulfate, and anthraquinone derivatives, Senna, aloe, cascara. And they act, they locally stimulate colonic motility, as well as they stimulate water and electrolyte secretion from the large intestine. These are the stimulant laxatives. So they are a bit stronger as compared to bulk laxatives. Then we have got other agents. These are called pharmacological agents. Here the laxatives are list is ending. These are chloride channel activators like lubiprostone, guanyl cyclase agonists like linaclotide and plicanatide, and a 5H24 agonist, which is a prokinetic agent, prucalopride. Drugs like tegaserod and cisapride are banned. So all these laxative agents and as well as pharmacological agents, they may have their side effects. Like both the bulking agents like fiber supplements and osmotic laxatives, all of them cause bloating, flatulence and abdominal pain. They can cause calcium ion malabsorption. Osmotic laxatives especially, they can cause electrolyte imbalance and should be used in caution in patients with renal or cardiac dysfunction. Emollient laxatives, lubricants and stimulants, these two categories, the second and fourth, they cause abdominal cramping, electrolyte imbalance. Of course, laxatives in general should not be used in patients with bowel obstruction naturally. So that is about tegaserod, as I told you, has been withdrawn. The other agents like lubiprostone, linaclotide and prucalopride, they're quite safe, but they can cause diarrhea. Then we use a combination of laxatives. Well, there has been an Indian study by Roy Patankar group where they use milk of magnesia, liquid paraffin, and sodium picosulfate. Milk of magnesia is the osmotic diuretic, liquid paraffin is emollient laxative, and sodium picosulfate is a stimulant laxative. So the combination, yes, many times we use in practice. Stool frequency improves, staining is improved, stool consistency is improved, and 50% significantly improved and 50% somewhat improved. So there is a role for combination in clinical practice. So just to summarize, treatment guidelines, gradual increase in fiber is the first step, either through diet or supplement like xylem, means isabgol, or you can add a wheat bran. Then you need other osmotic agents like milk of magnesia, polyethylene glycol, or lactulose or lactitol. Then if that doesn't work, then you investigate. But if it is again normal transit constipation, then you may have to use stimulant laxatives like sodium picosulfate, bisacodyl. And finally, pharmacological agents, lubiprostone and prucalopride, which are available in India. Maybe if I have the chairpersons give me 1 minute, I can summarize the specific situations which we face in clinical practice. Can I, sir?
Yes, please go ahead.
Yeah, so that was my main already over. But there are certain clinical situations. For example, if you are dealing with temporary constipation, which is not a long-standing constipation, you seek the reason, whether the patient has got recent history of travel, whether the patient is pregnant, drugs, or even chronic illnesses, even viral illnesses. A simple bout of influenza can cause, or fever, patient can have constipation. So we can use, if we want a quick effect, we can use stimulant laxatives like bisacodyl. Osmotic laxatives like magnesium hydroxide, lactulose, lactitol will take 2 to 3 days to act. And bulk laxatives like isabgol will take somewhat longer time to act. But these two, the osmotic laxatives and bulk laxatives, can be continued for a longer period if you think the patient needs slightly prolonged treatment. But for a quick short relief of constipation, temporary constipation, then the stimulant laxatives are best. Many times we see fecal impaction, patients who are moribund, who have not passed stools for days together. There can be an impaction of stools in the rectum along with spurious diarrhea. I must warn you that these patients, though they have constipation, the clinical presentation looks like diarrhea to you. With incontinence, the patient is continuously passing small amount of liquid stool in the mainly in the diaper because it's so frequent and continuous. So the most important thing is to empty the rectum. We have got laxatives, especially polyethylene glycol. We can use in 4 to 6 divided doses. Many times you need to give enemas to this patient, enemas and suppositories. And most important is manually breaking the stools in the rectum. That may sometimes need general anesthesia. So once the rectum is empty, the main job is to keep the rectum empty. Patient should be encouraged to have regular attempts at defecation. Whatever laxatives we discussed, we need to reassess and the need for continuous laxatives. And if there is no motion for 2 consecutive days, definitely you must avoid fecal impaction by using suppository or enema. So that is about it. Just the last slide. We know I told you in chronic constipation, first is fiber supplement, then is osmotic laxatives like isabgol. And at this stage, if there is no response, then you investigate with anorexia, manometry, and balloon. Then if you got a defecatory problem, then you must advise these patients behavioral treatment, training or biofeedback as it is called. So defecatory disorders does not respond so well to laxatives, but it responds better to biofeedback. But if it is slow transit or normal transit, not a defecatory disorders, then we have to go to stimulant laxatives, suppository or enema. You may also address any psychological issues in this patient. If everything fails, then surgery for constipation may be advised, which is in the form of colectomy and ileorectal anastomosis. It gives very satisfactory results, but then all other measures should have failed. It should be a slow transit constipation. It should not be a defecatory disorder. It should not be a normal transit constipation.
Bhandarkar sir, sorry to interrupt.
Yeah, I am done. Thank you very much.
Announcement to make. In the morning, we could not complete the poster session. So we have created a parallel meeting ID. I request all the students who are logged in with this meeting ID to please check the WhatsApp group of NIMACON paper and poster and log in. That there is a parallel room meeting ID. And we will be resuming the poster presentation there. Please take note of it, all the students, and please log into the new meeting ID that has been posted in the WhatsApp group of NIMACON paper and poster. Thank you. You can resume the sessions here.
Okay. Thank you, Dr. Gauri. And thank you, chairpersons, and thank you all the audience. And once again, thanking all the organizers for this honor and your kind attention. Thank you very much. I will be happy to take questions if they are allowed.
I think there are no questions in the chat box as such. Is there any other question?
No, sir, there are no questions in the chat box. We are done. Thank you so much. Thank you so much, Dr. Bhandarkar, sir. And thank you, Chairperson. We would like to felicitate Dr. Bhandarkar, sir. They said flowers are token of gratitude and admiration. Presenting you with a memento and flowers from the team NIMACON. And thank you, chairpersons, for chairing this session. We are sorry we are running short of time and we have our oration to come on. Thank you so much.
Thank you very much.
Thank you.
Coming to the most awaited event of the day, Dr. Sushila Nair oration on hepatology. Late Dr. Sushila Nair, lovingly called Behenji, was a great physician, prominent Gandhian. She was a health minister in Honorable Pandit Jawaharlal Nehru's cabinet. The oration was started by Dr. Sudhir Gupta sir in memory of late Dr. Sushila Nair. This oration covers topics in hepatology. This year, this prestigious oration is going to be delivered by senior gastroenterologist Dr. Shrikant Mukewar sir. Dr. Sudhir Gupta sir is going to chair this oration. Dr. Sudhir Gupta, working as professor, head of Department of Gastroenterology, Government Medical College, Super Speciality Hospital, started Dr. Sushila Nair Hepatology Oration under IMA Nagpur branch, organized national conference in 2006, INASL, state executive member of IMA Nagpur. Over to you, sir. Over to you, Dr. Gupta, sir.
Yeah. Good evening, sir. Good evening, all of you. Hello.
Good evening, sir.
Are you audible?
Yeah, sir, you're audible.
Okay. So This time, this is the 13th oration in the name of Dr. Sushila Nair Hepatology Oration. And this year, our beloved friend, Dr. Mukhewar, Shrikant Mukhewar, is going to deliver his lecture on hepatitis B, still an angina. Dr. Mukhewar is a leading practitioner in Nagpur for last 35 years, and he is a director of Midas Multi-Speciality Hospital and Private Limited. He is one of the brightest student of his batch, and he topped MBBS with a gold medal. He has done his MBBS and MD medicine from Government Medical College, Nagpur, and by chance, I am sitting here as a dean of this medical college. He did his DM gastroenterology from PGI Chandigarh. He is having multiple awards from Nagpur University in his career during his MBBS. He is a life member of Indian Society of Gastroenterology, Indian Association of Study of Liver, Society of Gastrointestinal Endoscopy, American Gastrointestinal Association, and American College of Gastroenterology. Apart from his bright career, he has published international and national paper. May I request Dr. Mukhewar sir to deliver his oration on chronic hepatitis B.
Thank you, Dr. Sudhir, for this kind introduction. I am extremely...
Sir, Shrikant sir, just interruption. I apologize and correct. Dr. Sudhir Gupta is Dean of Government Medical College and Super Speciality Hospital, Nagpur. We apologize, sir.
Yeah.
Over to you, Mukhewar, sir.
A warm thank you, Dr. Sudhir, for a kind introduction. I am extremely thankful to the team of IMA for giving this an honor, for giving the oration in the name of Dr. Sushila Nair. I am privileged to do that, and I can see my presidents whose names are so big, so I will try to fit in their shoes and try to deliver a message. I must at the outset, I would thank the entire team from President of IMA, Dr. Gauri Arora, Dr. Sanjay Devtare, and Dr. Ashok Adhau for giving me this opportunity together with Dr. Sudhir Gupta, who has selected this. And I must congratulate Sudhir for becoming a Dean of Government Medical College, a prestigious post. So I am proud that my colleague has become the Dean of the college. Without wasting time, I start with the oration. Hepatitis B, a very common problem, and still, after so many years, it's an enigma how to tackle. India has been placed as an intermediate endemic zone with the prevalence of 2 to 8%. More than 8%, one would say that it's a high prevalence. Less than 2% is supposed to be low prevalence. So we are placed intermediate zone. It has been estimated that there are 50 million carriers of Hep B, which are there, which are acting as a pool. It forms 15% of the entire pool of HBV carriers globally. Prevalence in the non-tribal population is about 2.5%, and the prevalence can go as high as 15.9% in a tribal population. So with us, hepatitis B is a burning problem. What you can see here, A and D, are the various genotypes which are prevalent A and D are better than B and C. The chronic liver disease is more seen in C. So that's the important identifying genotypes. We had an occasion of finding out the patients' relatives who were coming and attending the MEDAS OPD. And when we tested 4,280, 110 were positive. The prevalence was 2.57%. In rural areas where we are taking camps, we had an opportunity to test 235. None was positive. To nutshell, around 3 to 4% of Indian population have this virus, which is HBsAg. Now, world over, there are about 360 million carriers, out of which 15%, 50 million are in India. Around 15 to 40% develop cirrhosis and liver cancer, responsible for about 1.2 million deaths. It is 10th leading cause of death worldwide, and especially in younger age group. But the good news is that the 70% of infection is inactive, so does not require any treatment. Now, before understanding about hepatitis B, let me take you to some of the basics. The hepatitis B antigens are 3 types of antigens you must know. The outer surface yellow you can see is a HBsAg. The core antigen is a red one, and the E antigen, the envelope antigen, is in between them. So the surface antigen suggests Australia antigen, which is suggestive of infection. Core antigen is a main viral particle, and the E antigen is suggestive of replicating virus. Now, similarly, you have 3 antibodies. Anti-HBs antibody is a protective antibody. If your anti-HBs titer is more, you are protected from this can happen naturally after acute hepatitis or after vaccination. You have 2 types of antibodies, IgM antibodies and anti-HBc antibodies are of 2 types. IgM suggests of acute infection. IgG suggests of resolved infection. Anti-HBe is a seroconversion after loss of E antigen suggestive of protective antibody. Now, the major problem in hepatitis B is its integration to the nucleus of the liver cells, and that leads to what is called as cccDNA, and this covalently closed circular DNA problem is the one which makes difficult target for the antivirals and immune response, as a result of which the virus remains in body for many years. It has been estimated that even after acute viral hepatitis, in some individuals, the virus can remain in the body for a period of 8 to 10 years, as long as that, and can get reactivated. So before we know about the go on to the chronic, let us understand what are the phases of history, of natural history of chronic hep B, and then only we can understand the treatment. So you have 4 important phases. One is the immune tolerant phase, where you can see in the orange that the HBV activity is high, but there is liver enzymes are normal. That is called as immunotolerant phase. We know the histology in such patients. If you do the histology, there is a minimal inflammation. So in fact, the viral load is high, but there is no interaction between the virus and the body. And this phase is immunotolerant phase. We should not treat patient in this. Immunoclearance phase, there occurs an interaction between the virus and the body, as a result of which the viral particles fluctuate and reduce, and the inflammation is characterized by enzyme elevation. This is called as immunoclearance phase, followed by
inactive phase where viral load is reduced, the enzymes are normal, and followed by reactivation phase where again the enzymes increase. So one is E antigen negative, another is E positive, and this has been recently categorized by EASL into two varieties, E positive, E negative. These are not two different viruses, but they are it's the same virus in different phase of life. So when the virus infection occurs, it is E positive, subsequently because of mutation becomes E negative. You have two main categories in both: chronic infection where the liver is not affected, does not require treatment. You have chronic hepatitis, E positive and E negative, where the liver gets affected and requires treatment. Now my plan is to discuss various cases because these are the clinical cases which you observe in your own practice and how to deal with it. So it is better that I share some cases and that would educate how to manage this disease. The first case is a 26-year male IT professional, HbSAg positive. He was totally asymptomatic, went to give blood and was detected to have HbSAg positive. Now, this is which is called as incidentally detected asymptomatic HbSAg positive. This is a very common scenario in practice. Now, such patients always ask the history of transmission. You will have to ask history of blood transfusion, history of injections in younger age group, whether there is a vertical transmission, the family history of jaundice, the sexual behavior, tattooing, use of razors. All this is important. In the family history of Hep B is very important, which will come subsequently. The clinical examination should see for the stigmata of chronic liver disease like spider, edema, jaundice, palmar erythema. Then all these patients, once they are HbSAg positive, the workup is required, which is in the form of biochemical workup like complete blood count, liver function test. You have serological workup like E antigen and anti-HBe. All these patients, one should undertake HBV DNA PCR quantitative, and then they are submitted for ultrasound, fibroscan, and liver biopsy only in few cases where the viral load is high. Now, our patients, the liver enzyme hemogram was normal. His ultrasound was normal. There was no fibrosis. HBV load was 200 IU, that is about 1,000 copies. Normally, we expect patients to have crores of copies. So if you have 1,000 copies, means that the virus is inactive, E antigen negative, anti-HBC negative. The patient is chronic Hep B carrier, but inactive infection. Now, such patients would not require any treatment. What are the recommendations? This is a common scenario. No treatment required. Follow up every 6 monthly with ALT, ultrasound. Annually get PCR for 3 years. If all the 3 years the PCR is negative, that means the patient has inactive infection. Screening of family members of HbSAg. This is very important. One has to screen all the members for Hep B. If negative, vaccinate them. Protected intercourse, avoid alcohol. Do not treat. The message of number one case is do not treat inactive infections. I've seen in clinical practice, HbSAg positive, the drugs are started without investigating. That's a wrong practice. 70% of patients do not require treatment. This 35-year male, HbSAg positive, E antigen positive, that means a replicating virus. PCR high viral load, 1 crore 14 lakhs IU, that multiplied by 5 U will be around 6 crores. OTPT was normal, fibroscan normal. This is what is called as immunotolerant phase. Now, what are the treatment guidelines? If you have, go to this left side of the section where you have high viral load, normal liver enzymes, don't treat the patient, monitor with ALT and HBV DNA every 6 monthly. If you have enzyme elevation more than 2 times and high viral load, treat the patient as shown in violet. But if you have a DNA load high, but liver enzymes are 1 to 2, probably these patients would need an observation by repeat enzymes and sometimes a liver biopsy. Then that was E positive and this is E negative. Except in E negative, the viral load is less than 2000 IU according to the EASL guidelines. And so what is the normal level of liver enzymes? 2018, ASLD proposed that the normal liver enzymes should be 35 units for males and 25 for the females. Our labs are showing 44, 45. That's a bit higher level. So one has to take this account for the enzyme elevation. Transient elastography or the fibroscan is a very important investigation. This is an ultrasound-based investigation. It has 2 functions. It judges the stiffness of the liver, and by judging the stiffness, one can see whether there is a fibrosis in the liver. Another advantage is fatty liver is very common in clinical practice. You get patients with Hep B who are obese. So they have liver damage because of 2 things, fat as well as Hep B. So this investigation helps you to take the cap or find out the fat in the liver. So sometimes, as I said, why do you do biopsy? This is data from Dr. Sarin's group, where they have shown that patients with HbSAg positive and normal enzymes have about 39%, 29% have evidence of enzyme elevation. So 1/3 of the patients with normal liver enzyme can also have an active disease. So it is necessary that if you have a high viral load, so this patient, after insistence, because he was 35 years, we wanted to do biopsy. The biopsy has showed necroinflammation, as you can see here, with evidence of fibrosis on mesenteric stain. And so this patient underwent treatment. So I will summarize that for treatment, there are 2 criteria required. One, the virus has to be replicating, which according to E antigen negative more than 2000 IU, E positive more than 20,000 IU. But in clinical practice, if you have a replicating virus with necroinflammation as suggested by liver enzyme elevation, fibrosis on transient elastography, or inflammation on biopsy, they should be treated. All the patients with compensated and decompensated cirrhosis needs treatment with any detectable HBV level, irrespective of DNA level. And the patients with hepatitis, more than 2 times enzyme elevation and viral load. There are 2 exceptions to this, that in a patient who is 30 to 35 years, if you have a high viral load and a normal ALT, the EASL says that you should treat the patient. However, the American guidelines say that you should have a biopsy. Similarly, if you have a family history of SCC, then you may have to offer patients a treatment. So 2 caveats in this, that elderly 35 with high viral load and a family history, they should be treated. Now, one must understand that this is an important landmark study published from Taiwan, where this is a real study. 3,582 participants, a cohort of 3,582 HBV participants was followed for a period of 11 years. And it was found that those patients who had high viral load had high chances of developing a disease as compared to those with low viral load. As compared to a viral load of 300, patients with viral load of 10 lakhs had 10 times more chances of developing cirrhosis and liver cancer. So, irrespective of age, male, smoking, alcohol, this is very important, that high viral load. So, the main treatment of all antivirals is to reduce the viral load. Now, of all the treatment available, I still see the prescriptions of lamivudine, adifovir. So these should not be used. What are the drugs which are preferred now? All the societies have recommended that one must use the drugs which are having high efficacy and low genetic resistance. So entecavir, tenofovir, tenofovir adafenamide are the drugs of choice. PEG interferon, these are the 4 drugs only approved. PEG interferon in clinical practice is used in very few circumstances. Majority of the times it is a nucleoside analogs which are used. This is one of the trials of tenofovir and emtricitabine in a patient with immunotolerant phase. There is no benefit because we are discussing a case of immunotolerant. So the message from case 1 and 2, inactive infection, no treatment. Immunotolerant phase, no treatment. Now we go to the case 3. 34-year female, prodrome followed by jaundice, had direct hyperbilirubinemia, OTPT was raised, alphos was mildly elevated, albumin globulin ratio normal, INR 1.56, ultrasound normal, his HbA1c positive. Now, looking at this, one would jump to the conclusion that this is HbA1c induced acute viral hepatitis. What to do? Anti-HBC IgM done, negative. Normally, we expect anti-HBC IgM antibodies to core antigen positive when we have acute hepatitis B. So, E antigen negative, A negative, E positive. So, this patient is a chronic Hep B who has got hepatitis E positive infection. So, this also occurs in clinical practice, and the patients, they are inadvertently treated with Hep B. Fourth case, a 45-year male, HbA1c for last 10 years, develops edema fit, has a mild elevation of liver enzymes. This is one of the common scenario in clinical practice. Albumin low, globulin 3.5, sonography normal, no ascites, fibroscan cirrhosis. So this patient has a cirrhosis, but a compensated cirrhosis. Now let us see the prevalence of cirrhosis in India. This is again the data of ILBS. We saw that in 80s and 90s, cirrhosis form about 50% of patients Hep B. But now alcoholic liver disease is the commonest, followed by hepatitis B as the second important cause for chronic liver disease. Now, how does the chronic Hep B leads to cirrhosis and SCC? So chronic Hep B, if you get an infection in a neonatal period, 90% of the patients, once they get infection, will have a chronic Hep B as compared to 15% when they acquire in adult. So the major crux is one should prevent a neonatal infection by vaccination of the neonate immediately after birth. And that has to be emphasized and focused. And 40% of those with chronic Hep B will progress to cirrhosis. depending upon the immunity, alcohol, smoking, other factors. The cirrhosis, when they have low viremia, the progression is less as compared to high viremia. Then they get decompensated. Once they get decompensated, the average lifespan is very less, and the decompensated leads to cirrhosis and death. So SCC and death. So basically, what are the goals of treatment in chronic Hep B? The short-term goal is ALT normalization, HBV negativity. Normally, this is the sequence which is followed, that the ALT gets normalized, and the HBV negative, then the E antigen loss, histological improvement, HbA/Ag seroconversion, fibrosis regression, cirrhosis reduction, SCC, transplant need mortality reduction. So that's the aim of the treatment. Now, presently, the goal is a functional cure. What do you mean by functional cure? The HBV DNA should disappear and there should be no HbA/Ag. HbA/Ag antigen should disappear and HBV DNA. That's a naturally resolved person, as you can see in this violet one. But what is the aim of our treatment is clearance of complete CCC DNA. The virus which is integrated in the hepatic cells needs to be eradicated. That is defined as a complete cure. Once you have a complete cure, the complications of the disease is not there. The person is no more infectious and the transmission of the infection is not there. I think we are far, far ahead from the complete cure. Let us see, next decade, there will be drugs which will be acting on CCC DNA and help the complete cure. Now, the question is, we were taught in our undergraduate days, is cirrhosis not reversible? Is cirrhosis reversible? Yes, there are studies, the long-term data from Marcellini group published in Lancet 2013, where the hepatitis B 585 patients with chronic Hep B were taken and they were treated with tenofovir, and they had a liver biopsy at the end of 1 year and 5 years. And they have shown that when the baseline enzymes, normal enzymes was there, a necroinflammation, low inflammation was there in 8% of patients. After treatment for 5 years, this minimal necroinflammation has increased from 8% to 80% with tenofovir treatment, with E antigen loss of 54% and surface antigen loss of 11.8%. But still 11% only after treatment for 5 years. So necroinflammation improved in 348 matched biopsies. So also the fibrosis, as you can see here, overall regression of fibrosis was seen in 51% of patients through 5 years. So 176 out of 348 patients with matched biopsies showed regression of fibrosis. As you can see, this 39% minimum disease has increased to 63% and 38% severe disease at baseline reduced to 12%. Reversal of cirrhosis was seen in 74% of patients through 5 years. The cirrhosis reversed. So that's good news. Entecavir, again, a similar data of entecavir. This was published by Chang in 6 years of entecavir treatment, and the number of patients with liver biopsies were small, 86, but the reversal of cirrhosis was seen in 4 out of 10 patients. This same. Now, how long has the antiviral treatment has to be given? Literally, if you ask me, it has to be given for lifelong. So that's why taking a decision to start treatment is very important. The patient has to take treatment for long. Do antivirals prevent the complications of cirrhosis? This is one of the study, a C-team study, cirrhosis, Taiwanese entecavir multicentric study, which has shown that there were two arms in this study. Entecavir was given to 1,000 plus patients and followed up for a period of 3.6 years. And the historical control was a patient from 93 to 2008,503 whose historical data was available. And these two data were compared. Cohorts, these two cohorts were compared. The variceal bleeding, the chances of variceal bleeding are reduced, and they are reduced with drugs like entecavir more than lamivudine and adifovir, because it reduces by reducing fibrosis, reduces portal hypertension and the risk of bleeding. Also, the chances of spontaneous bacterial peritonitis are reduced, and hepatic encephalopathy is also reduced in entecavir group. Now, those patients who are waiting for the transplant, it has been seen that those responders, they were taken out away from the transplant. So transplant-free survival is also increased in patients with SCC. There are 3 studies which have shown remarkable decrease in the incidence of hepatocellular carcinoma with treatment for hepatitis B. One is a Hong Kong study which has reduced 50% reduction. A Taiwan study has also suggested 60% reduction, and the Japanese study has suggested 80% reduction, and the benefit is more with cirrhotic patients, those where it is needed. Now, how safe are these drugs? Because the treatment is lifelong. These are various trials which have shown the adverse effect, and the adverse effects are not much. Tenofovir associated with renal impairment and bone mineral density problem. Now, comparing between the TAF and TDF, that tenofovir adafenamide, which is a new analog, versus TDF, E positive and E negative patients, we don't see much difference between these two. The HBV DNA levels, efficacy-wise, both the drugs are same. DNA levels are reduced in the patient similarly, and the TAF is better in terms of bone marrow density and serum creatinine as compared to TDF. So, elderly person with bone disease and renal alteration should be given either entecavir or TAF over adafenamide over tenofovir. The one problem which comes in clinical practice is whether the person has acute hepatitis or whether he has underlying chronic hepatitis, and because of some reason the hepatitis has exaggerated, which is called as flare. Because acute hepatitis, it's a self-limiting disease. HbA1c disappears at 6 months, does not require treatment. While chronic hepatitis, if it is there, will require treatment, and the antiviral has to be given lifelong. So that's why this is important. These are various parameters, but in clinical practice, the best thing is when you have doubt, start the patient on treatment and do the HbA1c after 6 months. If HbA1c disappears, that means it is acute hepatitis. If HbA1c persists, that means it's a chronic hepatitis. Now, this is important. Pregnancy with hepatitis. All the pregnant women should be tested for HbA1c, Ag, viral load to be tested at the 28 weeks of pregnancy. And if you have a viral load more than 200,000 IU, then treat with antiviral to prevent a transmission to the fetus. Tenofovir has been said to be a drug of choice. Active passive immunization of newborn is a very, very important thing and should be done within 24 hours of birth. Another last few slides. Another thing which comes into my practice is a needle stick injury, post-exposure prophylaxis. Patients with HbA1c, gets the positive needle, you get a prick from the positive needle. What to do? That's a common question. Clean it, wash it, evaluate the HbA1c and HIV status of the patient, consider immunization. If you are not vaccinated, immediately, as early as possible, take HBIG 0.06 ml per kg of body weight and hepatitis B vaccine. If the antibody response is not known, test for anti-HBs titer. If more than 10, no action is required. If you know your anti-HBs titer, your protective, no action is required. If anti-HBs titer is less than 10, then you have to give HBIG and administer vaccine. Now, the last slide, what is the take-home message? It is better to prevent hepatitis B than to have an infection. This is very important. When you go for shaving, ask the barber to use a new blade. If you are going for injections, use the disposable syringes and disposable needles. If you are going for transfusion, ask the blood bank to check for HbA1c and anti-HbC total to find out whether you are getting a safe blood. Vaccination of a newborn pediatric population, contacts of HBV, family members, healthcare workers, special population like workers working in dialysis should get vaccination. Ideally, all the people should be vaccinated because vaccination will prevent the disease. Check your anti-HBs level. The protective anti-HBs level is 10. If you have a level more than 10, it is protective. Diagnose early, get HbA1c prior to the procedure. HbA1c has to be done in all hospitalized patients, for the procedures for the abnormal LFTs. Treat the patients with liver disease. The treatment is long-term. Ensure the compliance of the treatment because it prevents complications. HBV cirrhosis, vaccinate against pneumonia, hepatitis A. Ensure that the compliance has to be done. Why this is important? Because if the person forgets to take the pill, then there is a chance that the virus can get back and the patient has underlying chronic liver disease, gets hepatitis and goes into hepatic coma. There is a background. I just finished a couple of screening for SCC. Get every patient, even if it has a low viral load, it is not immune against SCC. Get ultrasound every 6 monthly for all patients with Hep B to find out whether they are developing liver cancer. Thank you. I think there is a lot of background noise.
Thank you, sir.
Thank you, Sudhir.
Dr. Mukhevar, thank you very much. As this is being a oration, there won't be any question answer session. So if any of the person wants any clarification from Dr. Mukhevar, he can contact him either on mobile or at Midas Multi-Speciality Center. Thank you, sir, for your kind words and for your nice lecture and oration. Thank you very much, sir.
Thank you, Sudhir. Thank you. Thank you, team IMA.
Thank you, sir. Thank you, Mukhevar sir, and thank you, Gupta sir. Words cannot express our feelings of gratitude for you, sir. You are really an inspiration for generations to come. We are fortunate enough to have stalwarts like you and Gupta sir with us. Thank you so much. And on behalf of Team NIMACON, we like to felicitate you with Shal Shrifer and a memento. Please accept the felicitation, sir. Thank you so much.
Thank you.
Sir, we are very much thankful to you for giving this prestigious oration, Mukewar sir. And because this is a virtual platform, we are giving you the felicitation also virtually, sir. We will definitely come to you and will felicitate you, sir. Thank you, Gupta.
Thank you,
sir.
Archana. Thank you so much.
Thank you, Gupta sir, for chairing this session. And Gupta sir is always very much enthusiastic in taking this oration and managing the faculty and everything. I am seeing from since so many years that the faculty is always brought by Gupta sir only. Thank you, Gupta sir. Thanks.
Thank you very much. Thank you very much, Archana.
Thanks a lot, sir.
The program would not end without giving a thanks to our MMC observers, Dr. Vinki Rughwani sir and Dr. Anil Laddat sir. Thank you so much for being the observers. Thank you so much. And I take this opportunity to thank the team NIMACON, myself and Dr. Kasturi for giving us this opportunity to be a part of the team. Thank you so much.
We are thankful to Prajakta, you and Kasturi for conducting this today's session as MOC and moderating the session. It's a very difficult and tough job. And you were sitting here throughout the day. We really appreciate your efforts and we are very much thankful to you. We would like to felicitate you with Gauri, please come. Yeah, you are fortunate to have a physical appreciation. Gauri, please felicitate Prajakta and Sachin to join. And you, Gauri, please felicitate Kasturi also. Thank you. Tomorrow we will be starting with the session sharp at 9 a.m. We will be starting with IMA schemes. So please join. We request you to be there at 9 a.m. sharp. Paper poster session is going parallel on another Zoom link. The link was also posted on this group chat in chat box. So you can join on that link to listen to the posters and papers. The students have taken a lot of efforts to give their presentations. So please join and appreciate them. And we are very much thankful to the audience who are present virtually here. Rajesh, you would like to say something?
Thank you everyone for joining us today for this NIMACON in every session. And special thanks to Dr. Vinki Rughwani sir and today's observer, Dr. Anil Laddat sir, Executive Member of MMC. Thank you, sir. All are requested to please join tomorrow at 9 a.m. We'll start scientific session at 9 a.m. morning. Thank you. Thank you, ma'am.